Start madboda. Welcome everybody. Uh, this is the neurodevelopmental care workshop and how to set up the neurodevelopmental clinic as well. Once again, I heartily welcome each and every one of you, people who there on site, as well as many of you who have logged in. At the start, I would want to apologize for the delay. The organizers had a little bit of a hectic run the whole of yesterday and early morning as well in trying to set it up. But I think with all good things, they do have a little bit of difficulties here and there. But it's all up and running and it's all good to go. So sorry for the delay, as I've said earlier. So what we're going to do is, we're going to have a whole day's workshop just on things pertinent to neurodevelopmental care and how to set up a clinic as well. So the first thing is, I'll try and talk to you about what are the various topics that we're going to discuss and how do we go about it. We wanted to have a hands-on session until a week to 2 weeks ago, but because of the current COVID situation, we've had to lightly alter or modify it. But we tried to make it up with the kind of videos and the kind of presentations that we've had. Believe me, all of us have put in a lot of efforts to make this a good learning experience for people who have just started, or for pediatricians who are already doing their neurodevelopmental care and they're interested in trying to set up a bigger unit or a bigger neurodevelopmental follow-up unit. So what we are going to have is, right now the first talk will be on the term as well as the preterm brain, the physiology and the pathology that you have in the term as well as the preterm brain, and what are the things that these children go through, these neonates go through, and how do you talk through with that. Dr. Anil is going to talk about that. He's a neonatologist from Hyderabad, and at the same time he is a developmental pediatrician as well, very accomplished pediatrician. The second talk is going to be on early identification of various behavioral problems and their development screening as well as the assessment tools. That is going to be done by a pediatric neurologist, very accomplished guy. He's done his pediatric neurology from AIIMS, New Delhi, almost 12 years ago. And then the third talk is by none other than developmentally supportive care by Dr. Amitava Sengupta. So his talk is going to be virtual. And as I said, we wanted to do a hands-on session. We've had a lot of things in place, but due to various constraints, we are not able to do it. But as I said, we are making all efforts so that the experience that you experience right now is going to be quite fruitful. Then the next topic is going to be by Ankush. That is going to be on early predictors of the cerebral palsy in term as well as preterm infants, and what are the predictors and how do you pick up those things. We've seen videos and we've heard a lot of people talk about general movements and things like that. So Dr. Ankush is going to talk on that. And then we have a neuroradiologist amongst us. His name is Dr. Shivakant, and he's going to talk about the neuroimaging, which is useful for us neonatologists as well as practicing developmental pediatricians. Then the next one will be the sessions like your MChat or Hein chart or your GMFM. How do you score those charts? And then the next thing would be, how do you set up? That's post-lunch. Post-lunch, we'll have a session on how do you set up the unit. What are the things you need to set up a unit? That's by Nitesh Agarwal and Femita as well. And then the next one would be on what are the things that we need to be careful, children with ROP, what time the follow-up needs to start and how long it needs to be done, with nice images as well. That's Dr. Aloka, she's a pediatric ophthalmologist. And Dr. Narayana, he's going to help us with the talking about the hearing assessment and the various things. And we have the tools as well, so that for people who are new to that, you could have a feel of the tools and see how they work. Both the ROP assessment as well as the BERA as well. Then Dr. Soumyakant, he's a occupational therapist. He's going to do the practical aspects of how do you go about doing the occupational therapy. And the last but not the least, the most important topic would be early intervention. None other than Naveen Jain himself. He's going to talk about early intervention program, when, why, how, and things like that. So I know we are a bit delayed. So without wasting much time, I'd straight go to Dr. Anil. If you could start the topic, please.
Hello. Mic is on, off.
Audible? ನಿಮಗೆ audible? Virtual audio ಬರ್ತಾ ಇಲ್ಲ ಅಂತ.
Hello. Hello. Without wasting much delay, I will start with the first talk for the day. That is on term and preterm brain, why, whom, and how to follow up. Yeah. First, as we know, improving perinatal care has led to increased survival of high-risk neonate, but the same improvement in survival has not been associated with a similar improvement in neurodevelopment outcome. Timely and appropriate intervention can prevent and modify many of these disabilities. First part of the talk, why do they need follow-up? Let's look at the statistics. 10 to 15% of surviving very preterm develop cerebral palsy, and 20 to 50% develop neurobehavioral impairment, including motor incoordination, behavior problems, and cognitive delay. If we see neurodisability in hypoxic encephalopathy, 80% survivor of severe HIE develop neurodisability, and 30 to 50% of moderately severe HIE develop neurodisability. In intraventricular hemorrhage grade 3, 54% develop motor deficit and 8% have abnormal DQ. If we see in periventricular hemorrhagic infarction, almost 100% surviving babies develop motor deficit and 80% develop abnormal DQ. Preterm babies that almost 20 times higher risk of hearing loss as compared to term healthy neonates, and visual impairment is seen in 5% and blindness is 0.5% of very low birth weight babies. The Cochrane database, which was published in 2015, concluded that early developmental intervention improved cognitive outcome, and this effect was seen till school age, but it was not sustained in adolescence age group. Now, what are the objectives of follow-up? Most important objective is to identify early deviation of growth, development or behavior, and intervention early as needed. To provide a clinical service to ensure that care beyond the nursery is optimized. Basically, we need to maintain the continuity of care in nursery and beyond nursery. To provide information, go back. To provide information to the family that might influence decisions about initiation of intensive care or palliative care. A baby has severe neurodevelopment disability and baby need intensive care treatment. So it gives idea to family whether they want to go for aggressive care or they want to go for palliative care. It also provides data about long-term follow-up to the family and to the healthcare providers. Next slide. Now we know what's the need of follow-up, then who to follow up. The risk classification is based on severity of parental risk factors, interventions required at birth and in NICU stay, demographic factors of the family and available resource for the follow-up. Broadly, neonates can be classified into mild risk, moderate risk and high risk. These are not the watertight criteria, some variation can be there from institute to institute. Like babies with gestation of less than 37 weeks to 33 weeks comes in mild risk, less than 33 weeks to 28 weeks in moderate risk, and extreme preterm baby less than 28 weeks, they come under high risk. Babies with weight of less than 2.5 kg to 1.5 kg come in mild risk, less than 1.5 kg to 1 kg in moderate risk, and extreme low birth weight babies, babies with weight of less than 1 kg, they come in high risk. Babies who have severe IUGR, the weight is less than third centile, they come in high risk. Neonates who need resuscitation like positive pressure ventilation, they come under moderate risk. If baby need extensive resuscitation like chest compression, need of adrenaline, they come under high risk. Neonates with confirmed culture-prone sepsis, they come under moderate risk, and severe sepsis like meningitis, multi-organ dysfunction, they come under high risk. Neonate with shock who needs iron drop, they come in moderate risk, and refractory shock, they come under high risk. Neonate with asymptomatic hypoglycemia, they come in moderate risk, and symptomatic hypoglycemia, they come under high risk. Babies with jaundice who need exchange transfusion, they come in moderate risk, and those who have bilirubin induced neurological dysfunction, they come under high risk. Neonate needing ventilation for less than 1 day, they come in moderate risk, and ventilation need for more than 1 day or complicated course, they come under high risk. Any neonate with encephalopathy or seizures, they come under high risk. In intraventricular hemorrhage, if baby has less than grade 3, it comes under moderate risk, and IVH of grade 3 or more, or periventricular hemorrhagic infarction, presence of ventriculomegaly, or periventricular leukomalacia at 40 weeks, they come under high risk. If baby has a medical illness like PDA needing treatment, necrotizing enterocolitis, and chronic lung disease, they come under moderate to high risk. If there is suboptimal facility for follow-up and low socioeconomic status, that's also one of the risk factors, they come under moderate risk. And if you have abnormal neurological examination at discharge, or there is suspicion in development, or in parental concern, they all come under high risk. Neonates with any chromosomal or genetic anomaly and inborn error of metabolism, or surgical cases like congenital diaphragm hernia and tracheostomy fistula, they also come under high risk. So these are broad classification how we classify into mild, moderate, and high risk, but these are not the absolute criteria. Next. Yeah. Now we know why we need follow-up, whom we follow up, then how to follow up. Basically, follow-up of a high-risk baby is a team effort. We need to have multidisciplinary team where neonatologist or pediatrician or development pediatrician act as a coordinator or central nodal person. We need ophthalmologist, ENT specialist and audiologist, physio and occupational therapist. Some cases might need pediatric neurologist and orthopedician and clinical psychologist. At discharge or pre-discharge, we need to have full detailed medical examination. In medical examination, we need to have complete growth assessment. Growth of the baby has to be plotted on appropriate growth charts, and nutrition assessment has to be done, because growth and nutrition cannot be ignored in high-risk babies. And we need to sort out any unresolved medical issue before or at discharge. Second, we have to have detailed neurobehavioral and neurological examination. We can use Hammersmith neonatal neurological examination to have full detailed neurological examination at discharge. We need to have neuroimaging as indicated, like need for ultrasound brain for very preterm babies at 40 weeks of gestation to look for periventricular leukomalacia. Nowadays, more and more evidence is emerging for the use of MRI brain in very preterm to look for, predict the risk of cerebral palsy. ROP screening, hearing screening, and screening for metabolic disorders. Vaccination, never forget the vaccination, because we know that all Sorry? Am I out? No? Vaccination, don't forget the importance of vaccination, because vaccination is very important. We know all the high risk babies are immunocompromised, they need more protection. And always assess about the parental coping and development environment. What are the support family have and what are the follow-up services they have. Okay, you can remove this. Hello? Hello? Am I audible? Hello? Hello? Yeah. So we always need to assess about the parental coping and what's the follow-up services they have and what is their background, because our development follow-up program won't succeed until unless we have involvement of family. So always involve family and educate them about the need for the follow-up services. Now brief about Hammersmith neonatal neural examination. It's like quick, practical, and easy to perform exam which can be done for preterm and term baby between 36 to 40 weeks of gestation. It has roughly 34 items which assess tone, motor pattern, observation of spontaneous movements, reflexes, visual, auditory attention, and behavior. There is a one-page Hammersmith Skinner. If we cannot do Hammersmith neonatal neural examination in busy practice, so we can use Hammersmith Skinner. Ideally, it should be used for term normal babies or in first follow-up in a busy follow-up clinic. This is a Hammersmith neonatal neural examination Skinner. How does it look? It's like central gray area is normal one. Left and right there are warning sign. If baby has one or two warning sign, then we have to go for full Hammersmith neonatal neural examination. Now comes to the follow-up. In follow-up, we need to have medical examination and immunization, neurological and development assessment, of the assessment, hearing and speech, behavior, cognitive and intelligence status. In medical examination, we need to have detailed physical examination, including growth and nutrition, because we know that head circumference is the most important simple tool that can predict the abnormal brain growth in future, and it also can predict the risk of neurodevelopmental delay in future. It has been published that growth velocity for an extreme low birth weight baby during hospital stay exert a significant and possibly independent effect on neurodevelopment and growth outcome at 18 to 20 months of corrected age. So growth and nutrition, they are very integral part of high risk follow-up. Then immunization and any unresolved medical issue need to be addressed in follow-up services. If we come to neurology examination, first when we should do the neurology examination, one examination at discharge, then in follow-up we need to have once every 3 to 6 months in first year and once every 6 to 12 months thereafter. So what are the methods, what are the different tools which can be used for neurology examination? There are different tools are available. I have mentioned few of them, like Hammersmith infant neurology examination, Amal-Tyson scale, Infanib, NAPI neurobehavioral assessment of the preterm infant, and NICU network neurobehavioral scale. I will talk briefly about first two scales which is being used commonly and they are studied more extensively across the world. This is the Hammersmith infant neurological examination. It's a very simple and scoreable method. It can be used between age of 2 months to 24 months. Total we have 26 items and they can be scored. On the basis of score we have optimal and suboptimal category, and then we can predict the risk of cerebral palsy in future. This is the Hammersmith infant neural examination. How does there are total 4 pages are there. We have cranial nerve function, posture, movement, tone, reflexes and reaction. These are all are scoreable items. Next, the motor milestones and behavior. These are two non-scoreable items. So on the basis of that, we have to calculate a score. Then we have to decide optimal and non-optimal. Then we can predict the risk of cerebral palsy. So it has to be done once every 3 to 6 months in first year, then 6 to 12 months thereafter. If we see Amal-Tyson scale, it focuses more on tone pattern as compared to Hammersmith examination. It can be used from birth to 6 years. There are total 4 components like neuromotor. We have tone assessment in upper limb, lower limb and axial tone assessment. hearing and vision assessment. Neurobehavioral, we have arousal pattern, quality of cries, sucking and swallowing. And we need to look at the head growth, like head circumference and skull for sutures. It should be done at the age of 3 months, 6 months, 9 months, and 12 months. These are all are corrected age. In Amyl Tyson, we need to evaluate tone in spontaneous posture, passive tone, and active tone. We need to also define the patterns of tone abnormality, whether it's diplegia, hemiplegia, or differential extensor tone against the flexor tone. Always look for the asymmetry and primitive reflexes. Most of the primitive reflexes, they start disappearing at the age of 3 months. Excellent. These are few parameters of Amyl Tyson scale. First, we can see the axial tone. That's a part of active tone. We can see axial tone in raised to sit, head forward and backward position. Next is axial tone, that is passive tone in ventral and dorsal incarnation, feeding and suckling, fixing and tracking, and rhatic erections. These are few parameters of Amyl Tyson scale. If we look at the angles in Amyl Tyson scales, we have 3 angles. One is scarf sign, like adductor angle, popliteal angle, dorsiflex angle, and scarf sign. And we have different age group, the range has been mentioned. So we need to examine all that angles for the tone assessment. There is a very good prediction for risk of cerebral palsy later in the life. In general body movements, they say it has got the best sensitivity and specificity for predicting cerebral palsy. And if baby has normal general movement at the age of 3 months, then chance of moderate to severe CP is very unlikely. This is one of the new emerging tool which has got a lot of evidence, and some literature suggests that it is as equal or maybe better than MRI in predicting the risk of cerebral palsy later in their life. We need to have proper formal training to have to look to assess general movement, and the extensive course and certification is there. If we look at the development assessment, we have 2 types of tool, screening one and formal assessment tool. Screen tools are there, easy to perform, they are quick, you don't need training, you don't need proper kit. Only disadvantage is they are not diagnostic tool. If there is any delay in screen tool, it needs to be confirmed by informal assessment tools. In screen tools, we have development observation card. That's a very simple tool based on 4 milestones like social smile, head holding, sits alone, and stands alone, 2, 4, 8, and 12 months. And make sure the baby can listen, hear, and see. It can be used for the family can use for this very simple tool. Next is Trivandrum development screening chart. That also very basic screen tool, can be used up to age of 6 years. It can be used for Anganwadi workers. You don't need any training and no certification required. Ages and stages questionnaire, that is parents completed questionnaire. Parents give feedback, on the basis of that we can calculate the score and we can know is there any delay or not. If we see the DDST, that's a multi-dimensional screen tool. It has more, we can assess baby in all the different domains like gross motor, fine motor, language, and adaptive. It takes around 15 to 20 minutes full DDST. Bailey scale of infant and toddler development screening. These are the part of screening chart. First 3 screening tools should be used for babies at no risk or mild risk. If baby is moderate to high risk, we should use either DDST or Bailey screener. In formal development assessment tools, we have development assessment scales for Indian infant DASI, which can be used for the age of up to 30 months. Bailey scale of infant and toddler development, which can be used up to the age of 42 months. This DASI scale is a adaptation of Bailey 2 scales. Now we have Bailey 2 scale, Bailey 4. So Bailey 4, this is the most comprehensive development assessment tool. It assesses babies on gross motor, fine motor, receptive language, expressive language, social and adaptive. For DASI and Bailey, you need formal training, certification, you need to have proper kit. A proper Bailey almost takes 60 to 70 minutes. For development assessment, we need to have corrected age till 2 years, or some literature say up to 3 years. In preterm babies, less than 37 weeks. For at-risk babies, those who have moderate to severe risk, we should use DDST screener once in first 6 months and then once in next 6 months. After that, once yearly. What are the indication of formal development assessment tools? If there is any parental concern or baby fails in screening test, and once in every year moderate to high risk babies, so we need to have formal development assessment to look for the early development delay. In ophthalmology assessment, we need to have ROP screening for babies born at less than 34 weeks or less than 2 kg, or maybe bigger baby if they have risk factors. Squint and refraction assessment by 9 to 12 months of age, irrespective of ROP. Then after that, yearly till 5 years of age. In hearing speech, all NICU baby, they have to undergo automated barrier response to look for deafness. There is rule of 136, always screen before 1 month, diagnose before 3 months, and intervene before 6 months. Now more and more evidence is coming, guidelines are saying it's 1, 2, 3. Screen before 1 month, diagnose before 2 months, and intervene before 3 months. And we have to repeat screen by behavioral audiometry at the age of 1 year. For language assessment, we have language evaluation scale Trivandrum, which should be used between 1 to 2 years of age to look for language delay, then yearly, once in a year till 5 years of age. For behavior and cognition problems, we have behavioral skills like child behavior checklist, Willand social maturity scale, MCHET-R. MCHET-R is the screening of autism that can be used between age of 16 to 30 months. For cognition or intelligence, we can use Vasual intelligence scale or Mullin's intelligence scale, that is the Indian adaptation of Vasual scales. Now we know why we need follow-up, whom to follow up and how to follow up, and till how long we should follow up. Most of the data and literature, they have followed up till the age of 18 to 20 months, but literature suggests that there is increased evidence of adverse outcome into school age and adolescence. So at least we should have follow-up till school age, if not possible till adolescence. Now to conclude my talk, first thing, always identify at risk neonate. Start intervention early. Start before discharge, don't wait for the discharge, and continue after discharge. Have a multidisciplinary team and have a dedicated person for high-risk follow-up clinic, because it's an all team effort. Single person cannot do all those follow-up. Early identification of neurodevelopmental problem, and always involve family, because they're the primary caregiver. If you don't involve family, if they don't have commitment, the neurodevelopment programs won't succeed. Thank you very much.
Basically, our psychologist, Dr. Ms. Ketura, will speak on the topic. I'm just giving an introduction. So, the topic is early identification of behavioral problems, developmental screening and assessment tools. So, what are behavioral problems? So, behavioral problems is a symptomatic expression of emotional or interpersonal maladjustment. If they have emotional maladjustment, that can express as behavioral problems. What are the various behavioral problems seen in childhood? They are inattention, hyperactivity, impulsivity, defiant behavior, drug use, and criminal activity. Next. So what causes behavioral problems? So the cause could be because the child does not possess the necessary social and emotional skills, or this abnormal behavior may be response to because he's feeling anxious, angry, and he is unable to process these feelings. And children, they do need attention from their parents for their emotional well-being, and this challenging behavior may be an attempt to gain attention from their parents and caregivers. Next. Next. Previous one, previous one. Yes, yes, okay. So there can be other causes also, like the child may not be well, or he hasn't had enough sleep, or he is feeling tired, he had too much of screen time, or he's feeling hungry, or there could be some recent change in family circumstances or routine. And these challenging behaviors, you need to rule out underlying health issues, or they may have developmental, social, or emotional problems. Okay. Next. So from here, Ms. Ketura will take on.
Um, Hello, I'm Ketura. I've been practicing as a child psychologist for the last 5 to 5.5 years. So I'll be just talking about the behavioral disorders, how to identify them early, and what are the tools that we use in the field to kind of go ahead with this. So when the problem behaviors that Ankush just explained exists over a period of time, over a span of 6 months or more, when it starts becoming severe, when the parents are not able to control it, then we start looking for something called as behavioral disorders, and they are eligible for the assessment and diagnosis of behavioral disorders that I'll be explaining to you about. So a behavioral disorder can also be diagnosed when these disruptive behaviors are uncommon for the child's age at the present, persists over time, or are severe. So it's not a typical, if a child is throwing a tantrum, you are expected to, children of the age between 2 to 3 or 4, you are expected to deal with those tantrums. It's allowed and it's okay for them to have those tantrums. But then if the same tantrums are thrown by a 7-year-old or an 8-year-old or someone who's older than that, that is not a normal behavior of that particular age child. So you're expected to look into, or you have a clue as to there's something else that's going wrong. Why? Because why the child is behaving so. So you kind of look for behavioral disorders. Next slide, please. Yeah, so the common behavioral disorders that you see in children from the age of 0 to 5 to 6 are attention deficit disorders, autism spectrum disorders, oppositional defiant disorders or conduct disorders, and behavioral problems associated with intellectual disability, and behavioral problems is associated with learning disability. Um, so attention deficit disorder is when the child is not having enough attention to complete a task that is age related. For a 3-year-old, the attention span can be 3 minutes or 4 minutes to perform a skill. But then if they are not able to have that time attention, then we have to look into the possibility of them having an attention deficit problem. And hyperactivity is when the child is not able to concentrate and do a particular activity for a longer period of time and keeps jumping from one activity to another, is not able to wait for their turn, and is not able to cooperate with his peer group, then it becomes a hyperactivity problem. So there are again 3 types, where there is just the attention deficit problems, and then there is hyperactivity problems, and then there is the common ADHD disorder, where both the conditions coexist together. It's usually diagnosed in children above 5 years of age. We don't diagnose any child with ADHD below that particular age to begin with. The second one is autism spectrum disorders. They can be diagnosed by the age of 3, but you can see their symptoms much earlier before they turn 3 years of age. By the time they are 6 to 8 months time, you will start having signs that start indicating that the child is at a higher risk for having autism spectrum disorders. So you can kind of start doing early intervention. That way it will lead to a better outcome right then and there. The other one is the oppositional defiant disorder and conduct disorder. They are very similar, but then they have their own nuances. So oppositional defiant is when the child starts, throwing, being rebellious, is not paying attention, is doing opposite to what the parents and the teachers and the society expects of the child. And conduct disorders is when they start involving in activities that they shouldn't be doing, like having truancy, not going to school, skipping school, lying about it, stealing. All those indicators of criminal activities start with conduct disorder. Usually, kids who are not treated at this particular stage might turn out to have personality disorders known as antisocial personality disorders, and they are the people who usually commit serial and severe crimes. So it's very important to kind of intervene for these disorders much earlier, as much as possible. And then you have problem behaviors associated with intellectual disability, and you have problem behaviors associated with learning disability. Both of them have their own features, and depending on the condition that's led to them having intellectual disability or learning disability, their behavior problem changes over a period of time. But usually they have less aggressive problem behaviors, like more of crying and tantrums, low confidence, people, they don't want to speak up, they are very shy, they are very reserved and things like that, that makes them not want to mingle with their peer group and grow and learn along with the peer that they are part of. So those are your common behavioral disorders. Can I have the next slide? Yes. So the main focus of early identification is early intervention. The earlier you identify and start intervening for these disorders, the better their outcome is. We actually try to start at an age below 3 so that the neuronal connections are also not permanent, they don't become permanent. And the earlier effect of these therapies can actually make a lot of drastic improvements in the symptoms that the children are showing, right? Next slide, please. Yeah. So the team required, I think Dr. Anil had already explained. So I'm just explaining the team again. You need developmental and general pediatricians, pediatric neurologist, pediatric psychologist. Sorry, that's a psychiatrist. So basically, why they are part of the neurodevelopmental team, and usually they are the first recipients of children coming with these disorders, because usually a parent doesn't take a child directly to a psychologist or an occupational therapist or so on. Usually they'll end up going to their concerned general pediatrician, and these guys, these doctors then send us the team, send the child and the parent to the neurodevelopmental team that consists of child psychologist, occupational therapist, neurophysiotherapist, audiologist and speech language pathologist, remedial therapist, and then the ophthalmologist. And I think Dr. Anil had explained how each of their field work. So now I'm just going into the tools that we usually use. So one of the basic tools we use is called developmental screening test. It's used for children between the ages of 0 to 15, usually with intellectual disability, and it's also used in the screening for learning disability, and you can even pick up signs of autism and ADHD with this particular tool. So it was developed by Bharat Raj in 1983. So it's an Indian adaptation of Denver developmental tool. And this tool kind of studies the developmental sequence of children. So it goes as a age rating scale. So every item that the child is able to pass, we add 3 months or 6 months or 9 months to the total age that they are trying to calculate. So in total, it gives you the developmental age or the mental age of the child, which allows us to kind of calculate the developmental quotient, which is a precursor for an IQ. We don't check for intelligence quotient for any child below the age of 7. So they become a good predictor as to how the IQ of the child will be after 7 years of age. So then we use the DST. So the main purpose of early intervention will be to keep increasing the developmental age of the child, and they become a benchmark for the child to start improving on. Next slide, please. The next slide, next test we use is the VSMS test. This actually kind of goes along with DST every time we use it. So DST and VSMS is done together most of the time. And this was developed by Edgar Arnold Dahl. And this again has been converted into an Indian adaptation. And it's again for children between the ages of 0 to 15. Yes, sorry. Okay. Okay, so I'll just, you can tell them, or you want me?
Hello everybody, we're very sorry for all the technical glitches that have been occurring throughout the day. Right now we will have to pause for some time because the virtual connection is completely cut off and our fellow delegates who are joining virtually are not able to see or hear anything. So until that's resolved, we'll be briefly pausing the presentation. We are very sorry for
Self-help ability, locomotion skills, occupation skills, self-direction, self-eating, self-help eating, self-help dressing, and socialization skills. So basically the child is measured on these particular aspects, and you have an individual score for all of this. Apart from that, there is a total score also that is calculated as the social age of the child, which again gives us a social quotient, which in tandem with the developmental quotient, we kind of see the child's mental age compared to their chronological age. And the next, sorry. just few more so you can. Yeah, so the other screening tool that we use is called MChat. It's modified checklist for autism in toddlers specifically. The age range is between 16 to 30 months. So basically this is not a diagnostic tool. It is a tool that gives you a risk factor or a risk rate that will tell it's a low risk, high risk or medium risk for children developing autism or autism spectrum disorders as they grow up. So it says 30 months, but then we have a leeway of using it till the child is 2 years and 11 months as well, because after 3, we use a tool called ESA to diagnose the child. So this can be used till 2 years and 11 months. The main purpose is to assess the risk for autism, and I think we'll have an hands-on session on how the tool as such works. So I'll be explaining more on detail on this. It was developed by Robbins, Faines, and Barton in the year of 1999. Yeah. So the next thing is the other tools that are usually used is ESA. I just mentioned it. It's Indian Scale for Assessment of Autism, and it's used for children with above 3 years of age till around say 15 or 16. And the other one is called Attention Deficit Hyperactivity Disorder Self-Rating Scale. This one, there's a parent version and a teacher's version, and usually used for children 5 years and above. So we either get the responses from the parents or teachers to kind of come up with a score of attention deficiency and hyperactivity for us to kind of judge how much percentage of disorder we can kind of establish. So we can here in this tool kind of diagnose all 3 types: attention deficit, hyperactivity, and the combined version of both. And another one is called Seguin form board test. This is usually used in children who don't have speech or hearing. So if they have speech and hearing problem, we can't use the other tools because it's all biased towards children who have hearing and speech. This is more of an action tool. So there is a board with shapes, geometrical shapes in the board, and there is a block that goes along with it. You kind of measure the time that is taken for a particular child to do that test completely. You do it thrice with them, take the best time, and then there is a conversion sheet that gives you the time, the age equivalent for the time that they've taken, and then you kind of see how their mental growth is going on. Apart from these, we have a lot of intellectual disability. There are tests like Malin scale. So that's an adaptation of Wechsler's scale. And there's something called as Binay Kamath intelligence test. So again, that's a Indian version or an Indian adaptation of Simon Binay's intelligence test that was done earlier. And for learning difficulties, we have something called as DTLD and LDDI. DTLD is a person for the child to be tested with. So the therapist or the psychologist directly tests with the child, and LDDI is again a parent rating scale where the parent gives us information about the child's performance in reading, mathematics, communication, self-help, and all of that, and based on that scores we kind of diagnose them with learning difficulty. Learning difficulty is again diagnosed only post age of 7 or 8, because by then there is a chance that the child will improve. So a child not being able to read or write at the age of 4 or 5 will not be labeled as a learning disabled or a learning child with learning difficulties. We usually wait till the time they are 8 to diagnose them, but then early intervention can be started much earlier by the time they are 4 or 5, and that can actually reduce the impact of the disorder that they are having, and which can even lead them not having a label as such with them. So yeah, that's my presentation. Thank you. If there are any questions, you can go ahead. So minimum age, as I mentioned, we don't diagnose any child until they turn 3. But then children below the age of 3, you can tell them that they have high risk for autism. So you start off therapies and interventions at that time. Mostly it will involve occupational therapists and behavior therapists, as in child psychologists who are constantly, and speech therapists working along with them, because usually autism has problems with speech communication and a lot of hyperactivity and repetitive motor movements. So these are the 3 people team that will be mostly involved. the child psychologist for behavior modification, occupational therapist, and a speech pathology therapist who will be working with the child. So they might not have eye contact. Eye contact is the first thing that you kind of pick up in a baby, because it kind of develops by the time it's 4 to 6 months after their birth. When you're talking to them, or when you're trying to play with them and all of that stuff, if they're not able to hold it or maintain it, that's a telltale sign of autistic features. Another thing is social smile will be absent. So by the time 3 or 4 months occur, they start smiling, and if familiar people come in their picture or in their visual background, they start being happy and smiling and all of that stuff. So that will be absent in children who again land up having autism spectrum later. And they are usually people who will be very aloof even as a baby. They will not be able to identify their mother as the mother. They just know them as a primary caregiver. They will not want to be cuddled, pampered with. They prefer being left out as they grow older. Usually by the time 1.5 years, all the development that they get kind of regresses. That's another telltale sign of autism spectrum disorders. Yeah, so they would have picked up speeches of having 1 word, 2 word um, things like amma, tata, nana. All of that will start, but then 1.5 to 1 year, 8 months, it kind of regresses. It's like the child has completely forgotten whatever he's learned, and they start deteriorating from there. Then it's again a telltale sign of autistic features. Yeah. Yeah. So bisyllables, again, there should be some meaning to it, right? They can just keep repeating amma, but then they might not look at their mother and tell that word. That also can be a sign. So just because they don't have eye contact, we won't be able to tell that the child might have autism, but then there is a risk factor increases a little bit. So when I do MChat, I think when we do the MChat hands-on session, you will understand it a little better. Yeah. Anything else? Okay. Thank you.
If we do it for such a long time, for the baby to improve, whether we do it well or not, there will be some amount of neurodevelopmental this thing. It's only a question of recognizing it early and taking proactive measures. So I think it's very apt, all three are together. Secondly, I must apologize for the problem with the net connection. You may have recently heard that Indian Army inadvertently shot a few civilians, right? This is something similar. The JCB machine, which was doing its leveling job, uprooted the internet cable. Do you know that? So now they are struggling hard to reconnect. So it was a friendly action which has resulted in this disaster. So sorry about that, bear with us, okay? Thank you. And I thank all of you for patiently waiting, firstly for attending, and the faculty who have spared their time to come here and conduct the workshop. Thanks to one and all. Thank you. You had the group photo? Okay. Thank you.
Seeing that we saw in the first talk also that a lot of NICU graduates, they land up with neurodevelopmental impairment. So what are the various methods by which we can detect among this population which one will develop neurodevelopmental impairment and which one will be developmentally normal? So what are the various methods for early prediction of development of cerebral palsy in term as well as preterm infants? Next slide. So basically I'll be talking on three methods. The first method is general movement assessment. Second one is MRI of the brain, neuroimaging, and third one is neurological examination. Hello. Okay. Next slide. So we'll start with general movements. Next slide. So general movements, actually we can depending on the age, actually you can divide the general movements into writhing movements and fidgety movements. So writhing movements, they can be seen in the fetus also actually, and they continue up to 6 to 9 weeks. And after 6 weeks is over, you can see fidgety movements. The fidgety movements can be seen as early as 6 weeks, but they become more conspicuous by 9 weeks, and they disappear at 15 to 20 weeks. Okay. So now we will see what is a writhing general movement. So writhing movement means what actually the description is that they are gross movements. They involve the whole body, and the duration lasts from a few seconds to several minutes. And actually the neck, the trunk, the upper limb and the lower limbs, so the all body parts, they will move, but they will not move together. They move in a sequence, in succession. And this sequence of movement of different body parts should vary actually. It should be variable from one movement to another. It should not be monotonous to describe it as a normal writhing movement. And this variation should be there not only in the sequence, but it should also be there in the amplitude, in the speed of the movement, and in the intensity of the movement. And the movement should begin gradually and it should end gradually. It should not start with a jerk and end with a jerk. So that is the normal description of a normal writhing movement. So what are the abnormalities? So basically, actually, the Prechtel, who actually started description of general movement, he described two kinds of abnormalities. First one is poor repertoire, and the second one is cramped synchronized movements. So what is poor repertoire? So in normal movement, writhing movement, we saw that the variation should be there. Variation should be there in the involvement of the different body parts, movement of different body parts. If this variation is not there, if the sequence is monotonous from one movement to the second one, then it is termed as poor repertoire. Then cramped synchronized movements are if all body parts, they move together, they start moving together and the movement stops together, then it is termed as a cramped synchronized movements. The movement looks very rigid. Otherwise the movements the normal movements look very smooth and they have a fluent character, but here the movement looks very rigid actually. So now once the 6 weeks is over, the writhing movements will disappear and fidgety movements appear. So what is fidgety movements? They are described as circular movements of neck, trunk and upper and lower limbs, and the movement should be there in all the direction that is available, in all the spatial direction. It should not be localized to one direction, and they are described as having small amplitude, moderate speed and variable acceleration. And they are continuously present in the awake infant. But while recording the movement, the child should not be focused. You should not be, try to engage the child. He should not be focusing on you actually. So there should not be any focused attention. He should not be fussing or crying. The child should be awake actually, awake. And it may be seen with other movements also. And that is what they initially appear as isolated events. They will gradually build up and then decrease in frequency. So what are abnormal fidgety movements? So abnormal fidgety movements are of two types. One is abnormal fidgety movements, that is they look like fidgety movements, but the amplitude, the speed and jerkiness of the movements are exaggerated. So that is abnormal fidgety movements. And then there is absent fidgety movements. Absent fidgety movements means the fidgety movements are not seen at all from 6 to 20 weeks of age. Although other movements may be there, but fidgety movements are absent. Next slide. So this is the classic paper from Prechtel, published in Lancet in 1997. So what they have done is they have recorded general movements in 130 infants, and then they assessed their neurologic developmental outcome at 2 years of age. So what they have seen is all children who had normal writhing movements, all children with normal writhing movements went on to have normal fidgety movements. So before 6 weeks it was writhing movement. So after 6 weeks, what they have seen is normal movements translated into normal fidgety movements. But the converse was not true. Children with abnormal writhing movements, they later on went on to develop normal, abnormal, or even absent fidgety movements. So it is actually the fidgety movements have more importance in the developmental outcome of the child. Next slide. So regarding fidgety movements, they found that in infants with normal fidgety movements, 96% of the population went on to have normal development at 2 years of age. So a normal fidgety movements guarantees by almost 96% that the development will be normal at 2 years of age. In the group with abnormal fidgety movements, more than 80% had abnormal development at 2 years of age. So abnormal fidgety movements has a very high predictive value in that, and in the population with absent fidgety movements, all children had abnormal development at 2 years of age. So absent fidgety movements has the highest predictive value in predicting the development of cerebral palsy at 2 years of age. So this is actually what they have tried to do is, this is general movement optimality score. They have tried to quantify the general movements, and so they have studied the movement of the body as a whole, and then they have quantified the different body parts also. So this is the scoring for the global movement of the body. So I said that the variation should be there in the involvement of the different body parts. So if the variation is not there, then the involvement of different body parts is monotonous, then score of 1 is given. Cramped, synchronized, in which all muscles started contracting all of a sudden, and then they relax. Then it is termed as cramped, synchronized, and the score of 0 is given. Chaotic, they have described another abnormal movement, that is chaotic, in which the movements have a very high speed and amplitude. Then a score of 0 is given. So normal score means, so higher score means the prediction would be a good, but a lower score would signify a worst outcome actually. So this is for global assessment. Then you have scoring for individual body parts like neck, trunk, upper and lower extremities. So in the neck, actually, if the neck is involved in the sequence of the movement, a score of 2 is given. If the neck is not involved, then score of 1. Regarding trunk, if there are rotations, fluent and elegant rotations are there, score of 2 is given. No, just a few rotations, score of 1, and no rotation, score of 0 is given. Next slide. Regarding upper and lower extremities, they have described the movements under these headings. They have what is the amplitude of the movement, what is the speed, what is the spatial range, whether proximal or distal rotatory components are there, how's the onset, is it gradual, the onset and the offset, or is it all of a sudden, and whether tremulous movements are there or not. So each heading is scored actually. So if the optimal performance is there, then a score of 2 is given. Less optimal performance, score of 1 is given, and non-optimal performance, score of 0 is given. Next slide. So the maximum score is 42 and minimum score is 5. And this is the maximum score for individual body parts actually. So now this is known as GMOS, General Movement Optimality Score. Now they are quantifying the general movement the general movement assessment, and this general movement optimality score is being used to predict the developmental outcome of the child. Now the recent studies, if you go through the recent articles, they are using general movement optimality score. So coming to the second method, so neuroimaging, so neonatal MRI. So this is a paper from NEJM. What they have done in this study is, they have taken 167 very preterm infants, that is who were born at gestational age of less than 30 weeks or less, and MRI brain they have done at the gestational age of 40 weeks when they became full term. And then developmental assessment was done at 2 years of age. So they have described white matter, they could see white matter abnormalities in form of signal abnormalities, decrease in the volume of white matter, cystic abnormalities, ventricular dilatation and thinning of the corpus callosum. Gray matter abnormalities were also described in form of signal abnormalities, delayed gyral maturation and increased size of the subarachnoid space. So what they have seen is that white matter abnormalities on MRI translated into delayed development at 2 years of increased risk of cognitive delay, cerebral palsy at 2 years of age. And children with more severe white matter abnormalities had more number of neurodevelopmental impairments. So white matter abnormalities actually signify, they can be used to predict development of cerebral palsy. Even gray matter abnormalities are associated with developmental impairment, although not as strong as white matter abnormalities. So they concluded that abnormal findings on MRI at term in very preterm infants strongly predicts adverse neurodevelopmental outcomes at 2 years of age. So MRI brain at term is a very powerful technique in preterms to predict whether cerebral palsy will develop later on or not. Next slide. So this is another paper. What they have done is they have taken 97 very preterm infants, that is who were born at less than 30 weeks gestation, and as control they have taken 22 healthy term borns. So again they have done MRI brain at around term from 36 to 42 weeks gestation, and they have actually described MRI as abnormalities were described in these areas: cerebral white matters, cortical gray matter, deep gray matter, and cerebellum. So they have seen that even the deep gray matter and cerebellum is also involved in children with preterm infants. Next slide. So they have actually tried to quantify the changes actually. So cerebral white matter abnormality they have scored actually from 0 to 4 under these headings. So each heading has been scored, whether cysts have developed or not, signal abnormalities, myelination of the posterior limb of internal capsule, thinned out corpus callosum, dilated lateral ventricles, and reduction of white matter volume. So cortical gray matter abnormality, they have also been scored from 0 to 4 for signal abnormality, delayed gyration, and dilated extracerebral CSF space. Deep gray matter abnormality has been scored from 0 to 4 for signal abnormalities and volume reduction. And cerebellar abnormality has been scored from 0 to 4 for signal abnormality and volume reduction. So this is how they score actually. So you can see for cerebral white matter, if no cysts are there, then a score of 0 is given. So low scores means better outcome. If the cyst is unilateral, only on one side of the in one cerebral hemisphere, and it is focal, then a score of 1 is given. If it is on the both sides and it is a focal cyst, then score of 2 is given. If it is unilateral but extensive, the size is more, then the score of 3 is given. And if it is bilateral and extensive, then score of 4 is given. So higher score means there is high risk of development of cerebral palsy. Similarly, for focal signal abnormality, if none is there, score of 0, focal punctate score of 1, extensive punctate 2, and linear is 3. For myelination delay, if posterior limb of internal capsule and corona radiata are myelinated, then score of 0. Corona radiata is not myelinated, only plic is myelinated, score 1 is given, and if both are not myelinated, then score of 2 is given. So forth. You take the thickness of the corpus callosum, depending on the thickness. If it is thinned out, a higher score is given. If ventricles are dilated, then a higher score is given. And if the volume of the white matter is reduced, then a higher score is given. So how do you measure the white matter volume? You take I will show you the diagram. So you take the biparietal width. If the biparietal width is more than 77 mm, that is normal. So the score of 0 is given. Next slide. So same for cortical gray matter. You take signal abnormalities and you take gyral maturation and increased extracerebral CSF space. So if gyral maturation is less than 2 weeks, I mean you are doing MRI of a let's say 40-weeker child, and the gyri appear something between 38 to 39 weeks. So the delay is less than 2 weeks. So a normal score 0 is given. If the gyri appear as that of a 36-weeker child, so there is a delay of 4 weeks. So that would be in score 2. So as we know, gyri, as the maturity progresses, the gyri will become more complex. The gyri will they'll become more in number and complexity. So similar for gray matters, you take signal abnormalities and volume reduction. And for cerebellum, again cerebellum and signal abnormalities and volume reduction. So how the volume is measured, that we'll see. And this is how scoring is done. Next slide. So this is to show how do we measure the white matter volume? So you take the coronal section of the MRI and you measure the biparietal width. Okay, so this is how exactly in this section actually. So this is how you measure the white matter volume. So we know if the preterm has taken more hit, actually the white matter volume will be reduced. And this is how you measure the subarachnoid space. You actually take the interhemispheric diameter. So again, an increased interhemispheric diameter or increased subarachnoid space signifies poor outcome actually. And this is how you measure the width of the corpus callosum. You take the mid-sagittal section and you measure the thickness of the genu, the body and the splenium. And so you take the ventricular diameter in the coronal section. This TCD is transcranial diameter. You take the transcranial diameter for, it symbolizes the cerebellar volume. And this is deep gray matter area. You take the axial sections and you measure the largest deep gray matter area. Okay, so both, if deep gray matter area is less or TCD transcranial diameter is less, then it signifies poor outcome. Next slide. So this is how, so in the first row actually we see the cysts. The cysts are there in the white matter. So in the picture A actually the cyst is there only on one side. So it is focal and unilateral. In picture B you can see there are bilateral cysts. In picture C you can see the cyst is unilateral but it is extensive. And in picture D actually the cysts are, multiple cysts are there on both the sides. Extensive cysts are there. So so the A picture would be score of 1, B is 2, C is 3 and D is 4. So this is how scoring is done. Row 2 is actually for signal abnormalities, and row 3 if you can see, I don't know, you can see the signal abnormality in the basal ganglia, which is punctate actually. In picture I the signal abnormality is more extensive. In picture D the signal abnormalities are there in the cerebellum, and which is punctate, and in picture K it is more extensive, the signal abnormality. So this is how the MRI is, it is read and scoring is done. So these 3 MRIs are actually done all at 40 weeks. All 3 are of preterms, but you can see they are of same age but you can appreciate the difference in the gyri. Okay, so this is the first one is the gyri, that this is normal actually. So you can see the gyri are small and they are more in number and complexity, while the middle picture you can see the number of gyri are less, they are more wide. Okay, so this is seen at around 36 weeks of gestation, although this MRI is at 40 weeks. And the third one is, again you can see the gyri are still more wide and they are less in number, less in number. So this is actually a MRI of a 34-weeker child. Okay, but this MRI is at 40 weeks. So you can see that just by looking at the gyri, you can see that the prognosis would be bad, worst for the third child actually. Next slide. So now we come to our last method, that is neurological examination. So neurological examination, it monitors the development, provides early identification and treatment of high-risk infants. So these are various neurological examination methods are there. Hammersmith infant neurological examination, Tarwan infant neurological examination, Amiel-Tyson, Bailey and Dubowitz. So this is Hammersmith infant neurological examination. So it is freely available on internet. Anybody can download it. It is simple, it is scoreable, and it is standardized. It is done from 2 to 24 months of age. Next slide. So there are 3 sections of Hein. So we have already seen in previous talks actually. So there is neurological examination which is scored, motor milestones which is not scored, and behavior which is not scored. So actually neurological examination comprises 26 items divided into 5 domains. These 5 domains are cranial nerve function, posture, quality and quantity of movements, muscle tone, and reflexes and reactions. So each item is scored individually from 0 to 3. Maximum score for any item is 3 and minimum is 0. Overall, the global score is calculated by summing up all 26 items. So maximum score is 78. So the higher the score, the better would be the developmental outcome. Okay, so the maximum score is 78, but for they have tried to find out the optimality score for at each age actually. Next one, next one. So, so this is the 10 centile score. 10 centile. So 10 centile at 3 months is 67. The maximum score is 78, but 90% of the population at 3 months will have a Heinz score of more than 67. So, back. So at 6 months it would be 70, 9 months 73, and 12 months 73. Next slide. So this is optimality score for at different weeks actually. Next slide. So over 5 months there is 90% predictive accuracy for detecting cerebral palsy, and it provides objective information about likely motor severity and distribution of cerebral palsy. Scores below 40 predict non-ambulant cerebral palsy. This is very important. Next slide. So this is a paper from European Journal of Pediatric Neurology. So what they have done is they have taken 70 infants with a diagnosis of CP at 2 years of, who were diagnosed with cerebral palsy at 2 years of age, and they had been evaluated with Hein at 3, 6, 9, and 12 months of age. Next slide. This is the GMFCS scoring levels. So what they have found is that 3 to 6 months, if the score was less than 40, then it translated into GMFCS level of 3, 4, and 5 at 2 years of age. That meant they were quadriplegic or had severe diplegia. That they were not, they had difficulty in walking. They were not mobile, and a Heinz score at 3 to 6 months between 40 to 60 translated into a GMFCS level of 1 to 2 at 2 years of age. That is meant they had mild to moderate diplegia or hemiplegia. So the cutoff score is 40 actually. So they concluded that Hein has a strong and significant negative correlation between the scores of the neurological examination and the level of the lower the score, the higher would be the GMFCS level. So this is another paper. They have a large number of study subjects, 1,541 infants who were discharged from NICU, and they were assessed using Hein at 3, 6, 9, and 12 months. And at 2 years again, developmental assessment was done, and they were grouped into with infants with normal outcome, with mild disability, and with cerebral palsy. So here you can, yes, next one. So here you can see that the N is for normal infants. So in normal infants at 3, 6, 9, and 12 months, score is never below 40. Score has been always above 40, equal to or above 40. While in the group with cerebral palsy, even at 3 months, almost 54% of the population had a score of less than 40. And if you see the median scores also, there is significant difference between the median scores. At 3 months, the median score is 64 in the population, in the normal population, while in population who later on developed cerebral palsy, the corresponding the score is only 35.5. So at 6 months it is 68, it is 40. At 9 months it is 70, while in CP it is 44, and at 12 months it is 73, and it is only 45. So there is a significant difference in the Heinz score between the normal developing child and child with cerebral palsy. So Heinz scores can be used to predict whether what will be the development outcome at 2 years of age. So actually they have actually given cutoff scores also. So at 3 months of age, if the child which you are assessing, if the Heinz score is less than 56, then you can actually predict that the child will go on to develop cerebral palsy at 2 years of age with sensitivity of 96% and specificity of 85%. So similarly at 6 months, any score less than 59, you can predict that the child will go on to develop cerebral palsy. At 9 months, the cutoff score is 62, and at 12 months, any score less than 65, you can predict that the child will develop cerebral palsy at 2 years of age with a sensitivity of 90 and specificity of 90%. So these studies actually evaluated the global score, global overall score. So this study actually, they have tried to find out the predictive value of single items. So I mean there are 5 domains, so which domain is more important in determining the neurological outcome. So again, they have taken 658 infants who were discharged from NICU, and Heinz scoring was done at 3, 6, 9, and 12 months. And at 2 years, they have assessed the development. Next slide. So what they found was the quality and quantity of movement has the highest predictive value across the entire range, whether at 3, 6, 9 or 12 months. The, the quality and quantity of movement alone has the highest predictive value. Next item is tone. So tone also they found in the first 6 months of age, muscle tone has a very high predictive value, especially the methods that assess the tone in the upper limbs, which are assessed with scarf sign or pronation, supination, and ventral suspension. Okay, so we'll discuss Hines how exactly Hine is done. All of us must be having some basic knowledge. So you test the tone in the upper limbs using the scarf sign and the pronation and supination. So these have actually the highest predictive value. I mean, the movement, quality and quantity of movement have the highest predictive value. Then comes the tone. So for example, 75% of the infants who have normal outcome, they will have normal tone in the first 6 months, while only 5% of the children who later on go on to develop cerebral palsy will have abnormal tone in the first 6 months. So tone in the upper limbs, it has a very high predictive value. So apart from tone, reflexes and reactions also have a very high predictive value beyond the 6 month. Among the reflexes, the forward parachute, you can see it is present in 40% of normal infants at 6 months, while at 9 months the corresponding it is present in 82%, and at 12 months it is present in 96%. Next slide. Next slide. So here you can see actually, I have compared that in children who later on, when they have normal development, if you assess them at 1 year of age, forward parachute is present in 96% of the infants. While in children who later on they develop cerebral palsy, if you assess forward parachute at 1 year of age, only forward parachute was present in only 8% of the children. So similarly, arm protection was present in 70% of normal infants at 1 year of age, while it was present in only 4% of children at 1 year of age in cerebral palsy children. Vertical suspension in 80% of the normal children. So you know, vertical suspension, you hold the child with axilla, and the infant would actually move the lower limbs, alternately kick the lower limbs. So while the response was not there in children, it was present in none of the children at 1 year of age, and in lateral tilting was present in 90% of normal children at 1 year of age, while it was present in only 15% of children with CP at 1 year of age. So this is a system. Hanji, arm protection. So they will actually demonstrate how Hine is done. We have a separate talk also. So what you do is arm protection. The child is lying in supine position. You actually give support to the pelvis, and you lift the child with one arm. Let's say you lift the child with left arm, and then the child will reflexively, he will try to support his body with the right arm. You can see if somebody is lifting you with your left arm, you will try to protect yourself with the right arm. You will try to hold so that is the normal response. We have a different entire talk on the demonstration of Hine. So this is last slide actually. So they have actually compared the various methods that are used to predict the development of cerebral palsy. So general movement assessment, they have said that it has a sensitivity of 98% and specificity of 91%. Cranial ultrasound of 74%, sensitivity and 92% specificity. Neurological examination has a sensitivity of 88% and specificity of 87%, while MRI brain has a sensitivity of 86 to 100% and 89 to 97%. So the general movement assessment and MRI brain, these are the two most powerful techniques, powerful methods to predict whether the child will develop cerebral palsy later on or not. Okay, and they can be done at neonatal age, when the child is full term. Okay. Even now they are doing MRI at preterm age also, and they are able to predict whether the child will develop CP later on or not. But general movement assessment is as good as MRI of the brain. While in general MRI of brain, it is expensive, You need to take the child to the MRI unit. है ना? You have to sedate the child also sometimes. While general movement assessment, I mean, you don't need anything. I mean, the neonatologist who is monitoring the child in the NICU, he has to, what they actually do is they record the movements for 3 to 5 minutes. That's it. When the child is awake and he's not focused. So that assessment is said to be as good as getting an MRI of it is as good as, it is not inferior to MRI brain. Okay, but yes, as I mean, it is a very, there is a general movement trust actually. So you have to attend their program and you need to learn how to do general movement assessment. Okay, thank you.
Already mentioned a few things in my previous presentation. The age range is between 16 months and 30 months, but then we can take the leeway of using the tool until the baby turns 35 months. And we usually use this to assess the risk for autism. There are all yes or no questions. The scoring is a little complicated when it comes to this tool, but then this tool has been made free and available online as an online tool where you just measure the scale and then it kind of gives you the score and the risk factor that is available, right? So according to the scoring, after the score, if the score is between 0 to 2, it's at low risk. So the baby has no features or no immediate risk of the child having autistic spectrum disorder after they grow up, and no follow-up is required as such. So you don't have to worry about this child, developing autism once they turn 3, 3.5, and so on. And the score between 3 and 7 indicates a medium risk. This kind of indicates to you that you have to follow up with that child once in 3 months and once in 6 months. And if the child's risk remains at medium risk or lower, then the child is good to go. But usually you start off therapy or early intervention by the time they come to medium risk. So which will be your behavior therapy, occupational therapy, and speech therapy, and that will usually aid them, and they go from medium risk to low risk quite easily. So if the score is between 8 and 20, then the child is at high risk, and these are kids that by their behavior and their symptoms you would know that they have much higher risk. Like they won't be able to respond to their name being called, they will not make eye contact, they won't respond to their parents when the parents are expecting the child to respond. These are kids who are going to do whatever they want to, and if they feel like responding to the parents, then they would respond. So sometimes the parents even would think whether the child is having some hearing problem or so on, because they would have called that child so many times, but then the child wouldn't have even bothered to turn back and look at their face even for one of their name being called. And most of your severe autistic features will be present in these children by the time they are even 2, 2.5, and they are the ones that you have to start with early intervention quite early, and you'll have again behavior modification, occupational therapy, and speech therapist working. Along with that, usually there's a pediatric neurologist also working with them. If the hyperactivity doesn't reduce, or if there are other supplements that is required as medications for the child to get better, then the neurologist comes into picture, and then he kind of helps you to give the medication that is required. And usually then later, once he starts stabilizing, you taper him off the medication and continue with therapy. And by the time they are 3, 3.5, they will still have a diagnosis of autism, but then it might not be the severe or profound category. They will still be in the mild or moderate category, which is still manageable as they go earlier. But if these kids are not identified earlier and they'll end up having autism by the time they turn 3, they'll have severe autism, and after that the prognosis doesn't look that great. The manageability of the disorder becomes lower, and they will have a lot of difficulty with social interaction, peer interaction, and so on. They might still be able to do their routine work of self-help skills and self-direction and so on, but they will have difficulty with peer communication, social communication, and so on. For them, abstract will always be a problem, so education also will take a hit, because they won't be able to fare really well with social English and history and geographical lessons, but then they would do quite well with maths, physics, chemistry, so on, because there is a set pattern of things to study, because there's a formula, there's a step, and they will be able to manage with that. So yeah, this tool kind of helps us to assess the risk for autism in toddlers much earlier than how it is going to be. So basically, they are simple yes or no questions, as you can see in the tool that is given to you. Um, it'll be like, does your child enjoy being swung or bounced on your knee? Yes or no. So most of the times the parents will end up giving you answers saying sometimes they do, sometimes they don't. So that is the time you kind of ask them, out of 10 times, how many times does the child like to? If they tell any number more than 6 or 7, then you have to take it as yes. And if they are telling something lesser than 5 or 6 or 7, then you can put it as no. Another thing is, does your child take an interest in other children? So does the child pay attention? So if a normal 1.5-year-old, 2-year-old baby is there, if there is another baby in the room, they'll automatically pay attention to that child. They might not go and interact with them, they might not play with them, they might not even smile at them, but then they will know for sure that there's another baby. He has his own set of toys, or she has his own set of toys. But then a child with risk for autism will not be able to see the child until and until the parents literally take the child and put him in front of the other baby and then make them pay attention. Even then, the attention given to the other child might be a very fleeting, 5 second, 10 second, and then they will still go back to whatever they are doing. So then that's when you mark them as yes and the other one as no. So things like that are very simple questions that you have. So does your child ever use his or her index finger to point to ask for something? The thing is, autistic children, they will not be easily able to point. They can take someone else's hand and point, or they will go and stand near that place and keep, just start crying because they can't speak again or have that sentence formation of I need this, can you get me that? So they will just start crying, or then they start throwing a tantrum or so on. So they will never be able to point using their own finger. So that is one telltale sign of children with autism, and them using another person's hand. The next question, if you see, is a little different, where if you point at something, if they are able to follow the direction of the pointing and look at the thing that you're pointing at, that a child will be able to do. But then children with autistic features, symptoms, they will not be able to follow that as well. They will have struggle with even following your direction, pointing, and so on. So like that, all your questions will be yes or no, and you kind of keep rating them, and then the total score will fall between these scores, and then you can use the tool to tell whether they have high risk, low risk, or medium risk, and based on that, develop their treatment plan or management plan. So if there are any questions, you can ask me. Otherwise, I'll hand it over to Samyakant, where he'll be explaining HINE and GMFM. Sorry? Yes. No, so the scoring is a little different. We actually don't have that much time to explain it. So the thing is, there are some questions where if you tell yes, it goes to a separate question directly. So since it's not very convenient for everyone to use it, they've made an online version of it. So you can just check for MChat online, and you will get the web version of it, where you keep clicking yes or no, and at the end it will give you the score automatically. We wanted to show it, but then because of the internet difficulties, we are not able to do it. That's why it's on a slide. So, but then I just gave the hard copy so that at least you guys will get familiarized with the questions, and if you have any doubts, you can ask me as to what you can measure in the question or so on, and then based on that we can have a discussion kind of thing. So, sorry? Yeah, mostly milestone based. They should be able to perform it by that particular age. If they fail, then it's kind of, this is particularly for autism spectrum disorders, not any other developmental disorders or other neurodevelopmental disorders that we have been talking about. No. So this is just a screening tool, as I mentioned, and it is used till 2 years and 11 months. This again just gives me a high risk, medium risk, and low risk. After 3, once they turn 3, if the symptoms still persist and I still need to see whether the child is still having autism or not, then I go for ESA. It's called Indian Assessment Scale for Autism. So I'll use that, and that is an approved diagnostic tool. It was created by the Indian government, so that's what they use for certifying and diagnosing the child. Yeah. No, so this is not an age-rated scale. DST and VSMRs are age-rated scale, and I think Bailey and Dasi considers gestation age and preterm babies' age into the consideration when they are scoring. This is more of an yes or no question, and it's not an age-rated scale. It's just a binomial rating scale. Yeah. Yes, yes, yes. You can go with their chronological age. Yeah. So they will start flapping their hands or keep tingling or do that, or they will keep using someone else's hand to play with it. So all of that is unusual hand movements. Sorry. No, headbanging can be early sign of any problem behavior. Usually it's seen with autistic kids because their speech still doesn't emerge much later. But then it can occur in children with mental retardation, that is intellectual disability, or children who are not able to speak. So when they want, when a parent is doing something or the teacher is doing something, and if they don't have communication skills to tell them no, then they would have accidentally head banged or did something, and then the parent or the teacher would have stopped that behavior right then and there. So it gets reinforced for them that if they do this, they'll be able to stop the behavior of the parent or the teacher, so they involve in it more and more. That is more in autistic kids because their speech and communication doesn't emerge much later. No, some can be repetitive movement, but then if they are harming or so there's something called as function of a problem behavior. There are 5 different functions. So based on that, we'll have to decide whether it's just a repetitive movement or there is a particular function which the child does. Usually, they do it to stop someone else's behavior. Yes, yes, yes. It can be even in a child with no developmental disorder. Okay, all right. I'll hand it over to Sabi.
Again, good afternoon all. So probably we have discussed quite a few times earlier in the morning regarding hind. To brief about, it's like more of it is useful for a population of 2 to 24 months, and where it is mostly predicts the high risk of cerebral palsy. Looking into the components, it has mostly 3 sections. One is neurological exams, which has to be scored. The other ones, it is more of an observant, but you cannot score it, just for the observation basis for the milestone and the behavior section. The total are 26 items, and in that we can rate it 0, 1, 3 looking into the performance, where 3 is the high score, and we can put it 78 as a total score. So coming to the, I'll just briefly demonstrate some of the things from uh, the neurological examination part, where first this is the cranial nerve examination. It is more of an observation basis, where you will see the facial appearance, eye movement, the visual response while you are showing some of the objects, and auditory responses. Is it audible? No? Okay. I'm sorry. This one is also not. Is it audible now? No. Now it's audible? Ah, okay. So basically, first thing we'll check about the cranial nerves, the facial appearance, eye movements, and visual responses, auditory response, like giving an auditory response or sound. You will see whether that is responding towards the sound or not, and you will see the eye movement by giving some object showing in front of them, whether the child is tracking to the object or not, and how is the shock swallow pattern. And looking into the responses, you will score the highest one is 3, and gradually you will reduce. The second one is more of an assessment of posture, where you will see the posture of the head, trunk, and the arms and legs is more in sitting and also in supine position. Then comes the movement, where you will assess the quality and quantity, like how the quality is normal, or whether it is sluggish or excessively jerky, and how freely or alternately whether he is doing or taking so much of time to execute those movements, that we need to observe. Next is more of a assessing the tones. First thing is we'll see from the arms with the, like if we are trying to see the scarf sign, then what we'll see is we'll try to pull the arm towards one side. Like suppose this is the child, I am trying to pull the child's arm towards midline, and we'll check the elbow. So suppose while we'll try to pull, he will try to resist and it should not cross elbow. So if you see, and then when it crosses, then it is more of a sluggish, and it completely resists, is more of a more of hypertone. And if it crosses the midline, then it can be a low tone and the child is having low tone. Similarly, if we are trying to pull the arm from the extension, then this will be the similar kind of reaction. And for the lower extremity, what we need to check is we'll try to abduct. We'll try to abduct and check the angle. Looking into the angle, then we decide what would the score has to be given. More of 150 to 180 is the normal score. And similarly, for the popliteal angle, we'll try to check the popliteal angle and the ankle dorsiflexion as well. So this is how we score it and rate it. More than the so any score around 70 or more, then that will come as like it's a normal typical development. Less than that, there is a risk of having a cerebral palsy. And mostly in between 51 to 71 score, it will be like they can be termed as more of a CP. The GMFCS level is 1 and 2, where they will be ambulatory or ambulating with the support. But where it is GMFCS level 4 and 5, which is maximum support, like if they will need wheelchair support, whether to be propelled by themselves or the caregiver, less than score of 41 will be deciding among them. This is brief about the HINE. We cannot demonstrate because of the technical error. So mostly for the ease of application and documentation purpose, we have made it into the software, and that's why we check it and like in the 2 months, 6 months and so on. And next assessment tool what we use is more of a GMFM, gross motor functional measure. So as long as the paradigm set towards a more of a functional rather than the disease or disability, so GMFM came into picture. So it looks whole over it the child's thing into a more of a functional aspect, okay, how the child is functioning. So it is not only assessing the functional level of the child, but also it sets the goal, like what is the goal area to be targeted for the child to work on. Can we go for the next slide, please? Next slide. Yeah. So this can be also used from 5 months to 16 years. In fact, so GMFM is said to be more useful from, GMFM 88, I am sorry. So this is GMFM 88 is more useful for the, if you are using clinically from 5 months to 2 years, that is more responsive. And also some of the kids who are using orthosis to measure their functional level, GMFM 88 is more reliable than GMFM 66. The GMFM 66 has 66 items and this has 88 items. But if you are, if you have a more detailed assessment of the child's functioning, GMFM 88 is a better version to use it. Mostly there are 5 dimensions: lying, sitting, crawling according to the functional status of the child, standing and walking, running and jumping. And if you notice with the each dimension, there will be questions set it and at which position you will be testing, like whether it is a supine position or lying prone position. That way the questions are set, so that while assessing the child, we don't have to move the child frequently from one position to other. And another scoring criteria for is the scoring criteria is 0, 1, 2, 3. 0 is basically it doesn't initiate at all. The 1 is where it initiates but it fails to complete at least 10 to 20% of the whole component. And it's 2 is he tries to complete, he tries to initiate, but the percentage of completion is 2, in between 2 to 100%. He cannot complete the whole movement. 3 is able to complete the complete task. But where you are not able to test the thing, there you will be putting NT, while scoring it will be counted as 0. But they suggest it has to put at NT, but then while counting the total score of the components like the dimension, you will put it at 0. Coming to the dimension scoring and how do we decide what is the percentage. So if you go to the last page, so there has been divided into the, there is the total dimension, each dimension have number of items. So you will be, the highest score, that is 51, 60, 42, 39 and 72 subsequently, and how much score he has got, and total is the 100% you will calculate for the percentile score. And how do you decide the goal areas? If the percentage is less than 50, that will be the targeted goal areas for the therapist to work on. Sorry? Okay, so for the scoring part, yeah, for the scoring, what you do is the total dimension score has to be added on and the percentile score has to be calculated. If the percentile score is more than 50%, like suppose if you go to the last column, that is A, B, C, D, E, if the percentage is coming more than 50, then it is okay to be not worked upon, but then you can individually work on each items also. Like suppose one component the child is not able to execute of one transition from one position to other, that can be worked upon the therapist, but major goal areas would be where the percentage is less than 50%. So suppose in the lying rolling the child has achieved 90% and sitting it is 60%, but while crawling and kneeling it is less than 30% or nearly about 30%. The target areas would be more of a crawling and kneeling. And while you testing each item of the dimensions, what we do have to do is take maximum 3 trials. Sometimes you have to judge between in between 3 trials, suppose the child is not able to execute that particular function, but then what happens is that there is a spontaneous response after some time the child does it, but then you have to calculate, you have to take it in those 3 responses what you have got the maximum score in those 3 trials. Any doubt in regarding GMFM or Hein, so we can clear. Yeah, please. I'm sorry. Yeah, but then sorry, individual item to be right now I think we could not execute because we will not be able to get a child, because what Dr. Satish told initially. So we had thought of demonstrating the videos online, like how do you do, but then because of the videos now, probably because of the internet issues we are not able to show it. That was the reason. I mean, I think I can go for any one. I mean, I can show it in this. I mean, any particular thing or anything randomly, if somebody can choose, then probably we can go for it. That way we can do some of the thing, maybe. Okay. We'll go for the tone basically, so that will be much more important for our clinical purpose. So I'll come here so that it will be little easier for me to do this, or maybe we can move this table little bit forward so that it is visible for you. Yeah. So first thing I told you about the scarf sign, where you will check the elbow thing, okay, and then is more of a passive shoulder elevation. You will try to elevate the shoulder and check it. See how much resistance is a typical resistance, but then if we are not able to completely move, this is the one, the score 0, that you have to put it this way. The more, or either completely sluggish, like suppose it crosses the midline. This is the score in between 2, where you see the resistance is not typical, then there is much more there, or the child is appearing as to be as little sluggish, okay. And this is the score 1, where you will see this is crossed off. So no, so suppose what is happening is, if you are testing with the right side, you will put it right, and the left side you will see the second. The mostly, but then you will see for the score for each, it cannot be scored for right or left each side. It will be more of like one side, which side you are testing, you will put it up. We can do it this way and we can do this way as well, both the side. So it's basically showing that how this is the midline. When you see, yes, exactly. No, you can do it both sides to check it individually. Sometimes it can happen that the child can turn out to be hemiplegic or monoplegic also, mostly. So that way also you can diagnose that whether the tone is appearing to be this time it is more of a normal or typical, or this time whether it is a hypertone or low tone. That also you can discriminate in between this. And this way also the same thing. Like if I am trying to pull it up, whether that is a normal resistance like this or it is completely sluggish like this, there is no resistance here. I am completely pull it up, or you are hard finding it to pull it up. Yes, like you will try to pull it up from here. That video also I can demonstrate. No, you will hold it from the shoulder. So proximal part mostly you will try to pull it up. Okay. Now the next thing is this pronation supination. There will be full range of motion when there is a typical performance. Okay. Then subsequently you will see whether there is a resistance or what there is a marked resistance. That way accordingly you will pull it up. Suppose there is like when you grade the tone, you are able to do this, but there is some type of resistance, then the tone is more of a milder tone. Like we can say that there are different scale like modified also scale, it can be termed as 1, where the range is possible, but then it is where you see the catch. But then you are not able to do the full range of motion, then the tone is going to be a much more higher side, like where you can score it as 2 or 3. Then we go for the, so you can hold this way and do this. So this is more of an anti-gravity position for both pronation and supination.
How do you take the grip? By the fingers or by
Here, wrist.
I mean, if you are holding the bicep,
No, so you will stabilize here, the elbow is stable here. Now if we do this, there is part of the range is working against our, yeah.
so you cannot grip the bicep. No, that is what is the pronation.
No, pronation supination is more of a forearm, yes. Now next we will go for the, we will try to abduct. We will try to abduct and see what is the amount of abduction range we are getting. Yeah. Mostly we will go for the abductors. Yes, if it is between 80 to 150, then it is typical. Okay. This is the score 2. We will put it more.
The infant's leg extended.
You can do it this way also. More of it this way if we do for to isolate for the long adductors as well. Okay. And
Adductor angle?
yes. So
This is adductor angle.
this is abductor angle. The abduction, how much abduction this is doing. So you will check it this angle. Okay, pelvis as the thing. So if it is between 80 to 150, this is typical. Then we will go for the popliteal angle. Well, popliteal angle we will try to touch this and score this range. So what, because this is a soft one, we are not able to, but this angle we need to check, the knee angle. Okay.
Separately for each.
Yes, each leg. Okay, but then while scoring, you will put it up according to the range we are getting mostly, in between which range, and this one will.
Both of them not same. Which number we should take?
The highest one. Which one you will put?
Is normal asymmetry.
It can be happen. Yes, it can be.
And secondly, do you use goniometer for measuring these angles, or is it just arbitrary?
No, goniometer also we use. Goniometer. So because nowadays we have, I mean, because once you develop doing in an assume you can put it the range, but then it is appropriate to use the goniometer for accuracy. And
both the sides at a time.
Sorry, sir.
Both the sides simultaneously.
No, this is the thing. Both the sides.
For popliteal.
Popliteal angle you have to check both. One side you will check, then the other side.
Alternately.
Yeah. You will put it. Yeah. And then next is the ankle dorsiflexion. This also says about the tone also. While you doing it, you will see the appear of the movement, and when it is a free rhythmic movement, then you will see that the tone is normal. When there is a resistance, you feel any point of the time while executing the movement, whether it is the initial range or mid range or throughout the range, then the tone is getting higher. But then if the angle is completely straight, in this case, this is more of a low tone. It's suggesting it is able to completely extend. Okay, this is
differentiate voluntarily resistance given by infant and resistance offered by a muscle.
No, so that the voluntarily the muscle is given. If when you are saying that the tone is spastic.
Maybe spastic, or if a child is trying to,
Correct.
Trying to
So that's why these angles are made, right? This is a typical performance of the child where this will be this much of angle resistance will be there. It is again, in fact, it is not 90 degree.
Okay.
Or you are not getting completely stretched to the 180. So it's coming 150 to 100. So that is much of resistance you will get it. But once it is going, if you go here, it is more than 150. So that means you are able to stretch more. That means it is appearing towards a more of a low tone. This is also, if it is a less than 90 or is going more of a spastic one. Whether it is less than 90 or 170, that means either way it's going towards spastic or low tone, then you will mark as 1. If it is 0 means completely tight, you are not able to move. I mean, it is completely fixed. Okay. And then you will go for the ankle dorsiflexion.
What is the ideal age for hind?
I two months to 24. 2 months. 2 months. 2 months to 24 months.
4 months, 6 months, right?
Yeah. Then we will go for the ankle dorsiflexion. Again, the range is you can get it like 30 to 85 or 80, 85. That is a typical performance. And if you are getting anything less or more, that is going to be scored accordingly. Yes, ankle dorsiflexion. Like suppose if this is their ankle, then you will make it a dorsiflexion. Yes, yes. This angle you will take it. Then you will try to pull to sit. This. Okay. Okay. Pull to sit. Okay. So mostly basically when you are pulling, you will try to pull it up. So what will happen is that this way it is there. If it is completely sluggish or completely doing this, then according see this is completely sluggish. That means the child is completely hypotonic. This is appear to be more of like flexing. We are this way it will happen. We'll try to hold it from here and try to pull it up. Normally, but while pulling it up, you will try to give a little bit of support of the head. But then although there is no head control normally at the age of 2 to 3 months, but then still that child will try to control the head and appear to be a little bit of maintaining the posture. But then whether it is a more of a tight, it will come to a more of a flexion, or if it is this way, it can go to a oppositoneous posture, and this can never be always be a low tone also. Sometimes what happens, we call is a oppositoneous posture, where that is extensor tone is high, so that time also they can go for this way more, and then it is more of a ventral suspension. See, you will try to drop. Okay, while dropping, then you see whether it is completely sluggish or trying to make it more flex. Okay.
Ankle dorsiflexion.
Okay.
Under the score 1,
Okay.
it is 20 degree or 90 degree?
Less than 20.
Under the score of 1,
One.
yes. If it is less than 20 or it is 90 degree, then you will put it at 1. See, the normal range is 30 to 85 degree. That much of resistance you will not get completely 90 as a normal thing.
Okay.
And sir, in pull to sit and ventral suspension, how to differentiate extensor and flexor tone?
Okay, so while you see that when you are pulling to sit, that I exactly told, no. So when you do a movement, the tone is basically is movement specific. Okay, when you do a passive movement, then only you can appear the tone, you can see the tone when there is a hypertone. So you can completely see how much of resistance this is. Mostly if there is a extensor tone active, you can feel it from the trunk. You cannot see it like this way. And this cannot completely say that whether this posture is, I mean in the hind it is not mentioned that whether it is more of a low tone or high tone, or never, I mean none of this. They have only mentioned that if this is the angle, you have to put the score, but it is never concluding that whether it is a hypertonic or hypotonic. It is showing that there is definitely an abnormal tone. This section completely shows that there is an abnormality of tone. It is because of our clinical judgment we are saying that okay, this child is appearing to be low tone or hypotone.
When we pull to sit,
Yes.
we are
Okay.
checking the flexor tone of the
Trunk.
trunk
Yes.
or the head.
Yes. Both the trunk and neck. When you are when trying to pull to sit, it is not only the neck, it is also the trunk flexor tone.
Do we like in HNNA, do we also पीछे को वापस लेके जाते हैं उसको?
Like
Pull to sit करके?
pull to sit. This is the pull to sit, but this is more of a ventral suspension. You will hold it like here, then try to drop all of a sudden. Okay, that is what here. This is what you will see and appear. What is the exact posture? If it is completely erect, even though this is the first thing what you will see is that the child control is not there. I mean according to the age, if the child neck control has achieved, that well and fine, but if the child's neck control is not there, then what will happen is that initial for 1 second or 2 seconds the child will appear like this, but then he will try to control his neck at the upright posture. He might not maintain it for a longer time, but then he will try to maintain. So you will see that okay, the posture is incorrect, but if the child is completely sluggish or the how much of the movement is like this way or this way, accordingly you will score.
Why you are asking to drop it?
No, you will hold it like this. It will appear up like
it
this.
will appear as
Bec
Why not to hold child like this thing rather than holding like this thing?
No, it is a more of a ventral suspension, so that's why we are holding here. See, horizontal around the trunk area. Okay, so that way this is more supportive, and we'll free the neck. We'll see whether he is trying to make it into the midline or not. And these are more of a reflex reaction. Now what we'll see is pull the infant's arm. what we will see that ki what is the other side of the arm is executing, okay, and while pulling this will stabilize the contralateral hip, the opposite side of the hip, okay. So what will happen is that ki if you are trying to flexing it, this the other side will be extended, okay. In this more of this is the normal side, see, note that the reaction of the arm of the opposite side, if you are doing it on the one side, the other side will be extended, okay. This is more of a semi flexion position, and it is like it can be fully flexed also like this. This is more of a abnormal posture. Vertical suspension, when we do, we will see the leg movements, how frequently the leg kicking is there, like there will be a symmetrical kicking in both sides, and according to the movement you will see how what is the movement, the kicks one leg more or one leg is less, then that can use it, or it even sometimes the child might not at all kick also. So when you sit and pull, and normally when you try to touch the feet, they will try to make it this kicking movement, they will pull it up, that is the response they give. This is lateral tilting, you will hold again with the trunk, leave it and see the lateral tilting, and it will try to protect himself to bring it to midline with the child, and according to sometimes what will happen, lateral tilting, some people will like, some kid will like this, infants, some people will appear more of a flexion, this is more of a flexion, this is more of a extended. No, in the vertical position you will try to tilt either left or the right, okay, that way you will check. And the
normal in this, what normally will the child do?
normally he will try to maintain that position, if you even if you try to make it lateral tilt, he will try to maintain into that upper position, midline posture, but in the abnormality what will happen, either they will do a complete flexion of the arms and legs, or they will completely extend like this, the hips and the arms. The last one is the forward parachute, you will this way you will try to drop it and see the reaction, how much he is trying to control in the forward parachute. Yes. And now the next one is tendon reflexes, like the DTRs, you will see how it is elicited or exaggerated or not elicited, accordingly you can mention it then.
In this lateral tilting is just to look into midline, how midline posture baby maintains.
What is the reflex or reaction to this kind of postural changes the child is executing? This is more of a reflex and reaction section. So lateral tilting, forward parachute, these are more of a reflex towards or reaction. But this can be also, if you notice that some of the things are like reflexes which we like a different level of reflexes, like the brainstem, midbrain. So those kind of reflexes are also there. The last one you will check its milestone. Milestone, what is the milestone I have achieved? That way you will tick it. But this is not non-scoreable. The only scoreable part is this assessment of tone, reflexes, and the posture. Yeah, posture, it's more of observation in supine sitting. What is the symmetry of the head, trunk, arms, legs? That way you will score it.
At age of 2 months, how are you going to assess then posture?
You will put it in supine posture, midline, and
Yeah,
even inside the leg in
position.
sitting,
This is
you
in sitting.
will try to make it in sitting. You will try to
supporting
supported sitting. Sitting means it is supported sitting. Then you will see whether the leg is neutral or properly aligned, and then whether there is an abnormality, whether it is completely flexed or completely extended or lagged. That way you will put
You
it.
have to support at the head
This
or back.
this.
Okay.
Okay. So here if you put it, then it is going to be controlled more of. Score, it is in between your clinical observation, in between 3 and 1. So that way you will be putting.
How to test this? Please tell this thing.
Okay. Yeah. You will try to maintain. You will try to appear to maintain, but then you have to see that how much of tilting, whether this is forward. I mean, still it will be little forward bend, but then how much curvature it is appearing. That way you will score it up. Whether it is completely slug.
2 months, mostly the score will be 1.
It cannot be. It can be straight also, because even if you try to make him sit, so first few seconds the child will be like this, but then he will try to make an upright posture. In that attempt, that is the typical performance of that child in the 2 months. But then if he doesn't try and completely doing this, that means this is the very stupid or round. Or it's like if you're trying to see, when I told that there is an extended thing, they will go towards the back, like, but there is extensor tone is high. So that way, for the first initial 2 second or 3 second, you will notice that this will go little bit of forward, because obviously when you are working against the gravity, he will not able to hold it up, that has not developed, but then he will try to maintain that upright posture of the erect posture.
For momental period.
momental period of time. Probably I'll demonstrate few of the videos in the subsequent session, then that will know that for that fraction of time even the child doesn't develop, but then he tries to make it that posture exactly.
So you score for that try.
Yes, yes, exactly, but at the 2 month that is typical.
For all those parameters, like where there is the option of right and left, the child is responding to one side, like if it is responding to left is normal, but right is not normal.
Where there is more of abnormality we put it that way, because it can be hemiplegic also, right? Suppose right side is a typical performance and left side is there is an abnormal tone, then you score for the left one and you can mention in the notes. There are notes to be mentioned also, you can put it, there are asymmetrically notes also, you can put it there.
इसमें और कोई arms and hands, legs, इसमें कैसे होता है?
Leg का भी posture आपको देखना है, like suppose in sitting you'll see the legs posture, whether it is a flexed one or completely extended, how much sometimes tone I mean the tone is higher, there will be a flexor tone, there will be a flexion, it will try to make it more of a flexion posture.
And for 2 months old baby, how to make मतलब making baby stand?
You can make him sit. Standing though there is nothing, in mostly supine.
And in standing.
So you don't have to do in this. It's you have to check it in supine also. You can check it in supine also.
Okay.
You might not make it in sitting also if this is not achieved. You can make it in supine and see that whether the child is kicking properly. I mean you can see that whether so this is the typical performance, and you can see whether this is completely hypotonic. You will just observe that without any movement. Here we don't have to execute any movement. You have to still only observe and see that how much it is there. This one? No, but for the ease of application we have just because this is free scale available online site, so we have just made it in a software version and we are using it for that way it is more easier to record it. This is more of a, this is also freely available.
More of towards OT or PT examination.
Yes. So this is where you can you have to procure the scale, I believe. I mean, although it is this scoring sheet is available with online free of cost, but then you have to procure the assessment scale. It is more of a performance based. How in every position you have, it's more of a milestone, like it's supine, neck control, rolling. If it is rolling, roll towards the right, roll towards the left. That way you will need to pull up. No, it is also a detecting value detector of CP. Like it can be used after 5 months, but 5 to 16 years it is.
When we recognize that particular domain where it is deficient, we can work on that.
Correct. It is more of it measures the child's functioning, and also it helps the professional to exactly focus on which goal areas you need to target more of.
Where to use this one, 8 and where to use this one?
When you see yeah, so the 88, this is 66, it has lesser items, but then when you see there is no difference. You can use it in clinical practice both the way. It is obviously when there is 88 of scores, that is more it is more specific and more sensitivity. And when the child, there are two things where you can find out more better results with 88. One is when there are orthoses used for the child. When the child is using any orthoses and aids and appliances, then you need to mention some of this. Oh, the last page is not there. So there is one item where you need to put it that whether in standing, sitting, whether the child is using any orthoses or not. So that thing you need to mention. So those ways it is more specific for the 88 items, and also like from between 5 to 2 years, this is much more specific. 88. 5 months to 2 years.
Hind for screening. Once the baby's infant is subjected for early intervention.
Yes.
Can we again use it to just to look
yes,
for?
Yes, you can reassess it, no, like 2 months, 6 months, 9 months, 12
there
months.
Will be improvement in score.
When you are doing therapy, then there should be some improvement. Yeah.
So, but this score can be validated for to check improvement in tone or behavior or something like that.
Yes, obviously.
If there is improvement with therapy, then the score will improve.
Score will improve. So mostly 71 and more, I mean 71 to 78, we say that it is a typical thing. I mean it is the child is typically developing. It's done. We need to. You have it? You kept the copy?
One more doubt.
Yeah,
When
please.
we do routinely, if we see babies in OPD, we find the neurodevelopmental impairment is there. So what is the use for this performer? We don't use it good.
This is mostly used for by the therapist for the purpose of documenting the functional level of the child. It is more of a standardized tool to measure the functional level of the. In that way also we can subjectively write this the child is doing, this is the child thing not developmental milestone wise also. But then this is more of a subjective way of objective way of evaluation of the functional thing.
This also they do once and then.
Yeah, you can re-evaluate also. Yes, there is
Do we need skill for this, or anyone can do this?
Sorry?
Do we need to be trained?
No, I don't. There is no training required for this. There is no training required for this. No training required for this.
Also for hind also, no? Like we do routinely.
Yes, yes. Once
Like
you
this
keep
also.
yes, once you keep doing this, then probably you will get a hand on more that where is the flexor tone is high or extensor tone is high or whether it is a hypotone. That you gradually develop once we start keep doing more and more. Yes, till 2 months to 2 years you can do. Yes, only it's not. It is not checking abnormality, but then it is checking which level the function is the child is functioning. It is not detecting any abnormality. But then it is saying that which are the functioning the child has not developed yet or yet to achieve. Those things need to be worked upon. That thing it's. This is more valid on cerebral palsy. The population it has been first standardized in cerebral palsy, then it gradually went to on TBI, traumatic brain injury. Not in the older population. The age criteria is again 5 months to 16 years. Then it again went on to do on muscular dystrophy. That has been also standardized in.
If you don't mind, what we'll do is
Yeah.
we'll start the next session.
Yeah.
This one clarity regarding HINE and GMFM. We'll do it immediately after the next talk once more from the stage. The reason is it will be not nice
Yes,
if we are
yes, correct,
together.
correct.
If we are spread out, it will be better. So we'll do that session and then we'll get.
ठीक है. अच्छा the other one.
Able to join because of internet issue. Slides.
Next slide.
These are the like Fenton preterm growth chart what we follow for the preterm babies. Nowadays intergrowth chart is being used most commonly. Next slide. This is the IAP growth chart which can use from term onwards, 40 weeks onwards it can be used. What is neurodevelopment care? Because all NICU activities impact neurodevelopment, whether it's related to baby or baby surrounding environment. By optimizing the care, we can maximize the growth, speed of recovery, and support neuromaturation. Activities like babies related, like we are doing intubation, ventilation, these are related to babies. Other activities like how is the environment, like temperature, our noise, and light, pain. So these both things we need to taken care of to improve the neurodevelopment outcome. Then what are the strategies for neurodevelopmental care? First we have neurobehavioral strategies, then we have neuromotor, neurosensory, and multimodal like kangaroo mother care and feeding strategies. Others like ROP prevention, discharge planning, family counseling, or family involvement. In first neurobehavioral cues, what we can say positive cue. In neurobehavior we have good behavior, bad behavior. Good means self-regulated behavior, what is good for the baby. That flex posture is a good sign for the baby. When hand to mouth is a good sign. In negative cues we have when these are the bad signs for the baby. When baby is not happy, like baby is crying, this is like playing of the hand, extended posture, tongue thrusting, these are the bad behavior. We call this stress behavior. First one we say is self-regulating behavior. Negative cues are stress behavior. Subsequent DSC lecture, there will be more detailed discussion on those neuro behaviors. Like in neuromotor, we can see the abnormal posture is quite extreme. That's a bad posture.
Put an enter.
And
Enter.
first slide, I think not visible. We can see that nesting. What's the in utero growth is completely adduction of the shoulder joint, flexion at that elbow joint, adduction of the hip joint, and flexion of the hip joint and knee joint. And the both toes should be pointed upward. So there's a good, it mimics in utero position. There's a good position for the baby. In neurosensory, we have nesting, contentment, and kangaroo mother care. In nesting means we have to maintain the flex posture for the baby, and contentment hold, this will basically facilitate tuck. The one hand is on the head and another hand is on the body of the baby, so it gives baby comfort. This is kangaroo mother care. We know it's very important for all that preterm babies or maybe sick low birth weight babies. And the next slide, next one is no, actually it's not facility tuck, it's like swaddling. Facility, we keep one hand on the head and other is on the lower limb, just to give the comfort of the baby. Others like sleep-wake cycle, we have to control sound and noise, like we have to have optimal light in the NICUs. We need to cut down excess sound, our telephone sound, mobile sound, our warmer sounds and the ventilate sounds. So we need to have that around 40 to 60 will the permission limit for the NICU that we need to maintain. They are all the part of developmental supportive care. Next slide. These red flag signs already have occurred in my slide. The same is a repetition of the red flag signs. Next slide. Next. Yeah, these already have covered. Everything is repetition. Now, there are a few abnormal neurological signs in neonate at the time of discharge, which is very high risk of prediction of cerebral palsy. First is the abnormal tone. If babies have abnormal tone at discharge, the risk of CP is 12 to 15 times. If baby has diminished activity or poor cry, it has 21 higher chance of cerebral palsy later in life. Weak or absent suck, almost 14 times higher risk of cerebral palsy. If baby is not able to feed self, the need of supportive feeding like GABA's feeding or gastrostomy feeding, the chance of CP are 16 to 20 times higher. This is Amyl-Tyson angles. Already I have described those angles. Next slide. Yeah, next slide. Yeah. Now we come to motor assessment in newborns. It will be taken care of by Dr. Soumyakant.
Click on the videos. No, can you go up the slide and click on the videos? Yeah. Yeah. So just previously I told we'll be seeing more of a typical performance of a child with some of the assessments. Can you please play on it? I told to check it, he told playing it was. Did you not recheck? I gave it last. Wait a minute. Can we go to the next slide by that time, please? Yeah. No, the previous one, please. Yeah. So why it is important for positioning in ICU? So it optimizes the growth and development and the weight overall. It reduces the pain response of the child, the sleep awake cycle, and it also facilitates the normal physiological responses, like it reduces the stress, and it also facilitates the normal optimizing the tone. I mean facilitating the normal movement pattern and tone as well. It also encourages the symmetry, like if there is any asymmetry, then the symmetrical development should occur as well. No, the other one. Yeah. No, go down. Yes, yeah. Just go back to the PPT. Not, can we go back to the folder? Go to the folders. No, go to the folders. You don't have to close it, just open the folder. The, please open the folder, the same folder, the videos. Can you go for the right one, videos? Scrolling movement. Can we go for the movement of upper extremity? No, movement. Yeah, we can put on the lower extremity, then we'll go for the upper extremity. Yeah. This is popliteal angle. What we told last time, it is not completely 90 and it's going just little bit less than 90. It is hill to ear. The same thing he is demonstrating again. Can we move to the upper extremity next? Yeah, we'll go to the next video. Yeah. This is the arm extension. For any asymmetrical response, we have to check all the side, both the side. There is a resistance, you can feel it, the child is exhibiting while doing, it's not completely extended. This is the arm recoil. Once you flex and extend immediately, then it will again go back to the flexion position. It again got flexed. Okay, we can go to the slides now. Yeah. Next slide, please. Yeah. So what should be the guidelines for proper positioning? So we have to see for the pressure areas and the skins whether there is a blister or anything, any attachment, or whether when we are supporting the midline, the timing and positioning while we'll modifying from one position to other, and whether the nesting is appropriately done or not, and most importantly educating the parents to when we are discharging from them or we are graduating from them, how they will be able to do the similar kind of nesting or positioning at home. Next slide, please. Then most coming towards the feeding and nutrition, the first thing it is major goal is to optimize the nutrition, and we always encourage the human milk for the optimal diet. There are two kinds of more of a oral stimulation we do. One is perioral and one is intraoral, whether it is cheek circle or tracking the upper and lower lip or tracing down the nose to chin, and the intraoral it also goes from the tongue, cheek and the hard palate and gum as well. Go to the next slide. Yeah. This is one of the method what we use for the more of a intervention based we use for premature infant oral motor stimulation. This is more of a standardized method that has been we are following. Can we go to the next? And the most important factor is parents training, how they can execute this multisensory input, whether it is tactile or vestibular or more proprioceptive, whether it is a kind of massage or passive range of motion, or how do we do more of a proprioceptive input and vestibular or auditory input. That way we train them and also encourage them to do for those tummy time as well to improve the tone and posture. Anil, okay, where is Dr. Anil? Okay, so now suppose at what the age term corrected, if these are the questions when we see, I mean normally we might find as well. Can you go to the next slide? Yeah. So at these are the also question. I mean some of the child, infant we can see. the child is not reaching for the object, the child is not bringing the hand to reach to the object, child is not controlling the head, or there is a asymmetry in the posture, then what do we do? Can we see and whether the video of the subsequent? No. Okay, so here in this video mostly what we are trying to do for the child, this is a home based intervention basically. What we are trying to do is we are trying to make develop the control of the neck while giving an auditory input and visual input in front of the child, where the child tries to look at and enjoys those input, and while doing that he tries to develop the control over the neck or the strength of the neck. Now suppose at the 6 months, now the head, there are these kind of questions you can see, that whether the child is not rolling over, even the hand is not coming to the midline, or they are not grasping with the bilateral objects or trying to take both the hands together. What do we do then? And can we go to the next one? Yeah. Here what here what we are trying to do is, while this is the child has not achieved the basic upper extremity functions, where we are trying to do is developing the child to bring it to the midline and sorting a stack of cubes. So that what we are trying to develop with the child, and also doing what is happening is also he is trying to maintain the sitting posture and maintaining a symmetry of the trunk as well. So that way we are also actively engaging the trunk to improve his sitting posture as well. Now in at the 9 months, some of the child might not develop sitting, also they are not doing a palmar grasp, or like trying to hold control the hold and throw. I mean, there will be a controlled throwing they will try to develop, we call it a wrist hand dissociation. They will be able to dissociate the wrist, stabilize the wrist and try to throw. So what do we do? And they are not able to bear the weight on the hands, and how they are not able to appear to sit as well. So that way we are also here we are trying to develop the trunk control, and where it facilitates sitting more of, and also we encourage parents to make it more of a sitting device, whether it is a corner sitting or where chair sitting, where rather than the child lying down they will be sitting, and where it will be actively engaging the trunk in a more of a corrected posture. Now in the 12 months, when we see that the child is not crawling, I mean there is no transfer from the child is rolling and trying to come up to sit, but then when trying to sit to crawl or reach forward, it's not crawling and try to or there is no dissociation of the hip, he's trying to more of a dragging. Then what do? Then we try to initiate supported crawling, which has been demonstrated in the last video. So where we are trying to teach him to crawl, where there are supported crawling, where we give them assistance from the trunk and try to give any audio visual input or toys, and where the child will try to reach for, and once we start the dissociation of the arm and alternate movement, then gradually the trunk dissociation we support, and that gradually goes on. In the subsequent video we showed upon how the child will transfer from sitting to standing, then it comes the kneeling posture and half kneeling. So that transition has to develop, and where both the knees will be working against each other. I mean one knee is stabilized and one knee is trying to put weight up to the other one. So that way we are trying to train. Now after 18 months and 24 months, where we see that the child is not able to walk or run or climb, there we mostly engage the child actively through the play at that age, where we let them explore the environment and giving more of a play, developing their play behavior. We try to engage their themselves to make more of a functioning, like whether they will appear, they will try to stand more of. Initially we start them more of a holding the objects together, like a ball. Suppose we can give him holding a ball together, and the therapist or the mother can hold it together. So that way it will be more of a supported standing, and gradually we try to reduce the support, where the child will be automatically holding, and that's how he develops standing with that posture. And also similarly we try to focus more of a active running, and then we go for the climbing. For the upper extremity function, we try to make it more of a throw, target hitting, and where they will try to do more of a overhead throwing bilaterally. So these are the functions we take care of at the age of 16 months, 18 months to 24 months. Anything, any doubt regarding? Yeah, please. Uh, I think Pilat technique, that video we have not got. But then oromotor stimulation, it again depends upon whether we are doing extraorally or intraorally. It is not necessary every time you have to do the both the thing. And also whether the child is having more of a you have to see the tongue appearance and the cheek appearance, whether there is a low tone or a hypertone in the muscles. So that way we try to go for the stimulation of the extraoral areas initially first, then we go for the intraoral areas, like where the moving the tongue and the soft palates and the gums and the chins also. Some of the times also we go from ear to chin as well. There are quite a few techniques that we use, but then some of the techniques are like, this is one of the standard technique where we can do, where it is more of a it's not a term delivery, where it is a more of a premature delivery. But then in some of the cases when there is a term delivery where there is a suck-swallow coordination has not developed, then there it is more of a clinical judgment, what are the things the child is lacking, and that way we need to more of a try to do the stimulation. And also at the same time what happens is, we also not only try to develop the coordination of the muscle, but also we try to subsequently orientate towards more of a non-nutritive sucking, where we'll try to make him more of the smell towards the mother's milk, then gradually we'll sew and then make him smell, then gradually we'll put it in the tube and then they will suck. So that's how we try to, then it goes for the nutritive sucking. So we try to develop first NNS non-nutritive sucking, then that goes to the nutritive sucking, when there is no suck-swallow coordination initially with the tongue corrector. So it is not only about the muscles, it also giving a gustatory input to the child to be oriented with the smell of the mother's milk as well. Yeah, I think I'll leave the stage for the next speaker. Thank you. Initially 5 days a week has to be, I mean any kind of motor stimulation, whether it is oral or in the upper extremity or lower extremity or trunk, 5 times in a week has timed out to be better improvement, and where we can see improvements in 2 to 3 weeks.
Even, remember they were asking questions regarding which charts to use when, Hein, whereas all
Yes.
these things, while you're on stage, you could do that as well, right? So when to use GMFM, when to use Infinib, when to use Hein, Hammersmith Infant Neurological Examination, the same charts, if you can just talk for
Yeah.
2 minutes.
So that exactly what I told about the which age group we can use. But then what for our clinical use, what we normally practice is 0 to 2 months we use Infinib, and then for 2 to 2 years we try to use the Hein, and after 2 years, as because we have GMFM which caters from 5 to 16 months, then so normally we do not do GMFM, we go for after 2 years to see that key if there are any the age group after 2 years to more than till 16 we use GMFM mostly. But then 0 to 2 months we use Infinib, and 2 to 2 years we majorly use Hein for our ease of clinical practice.
To all our dear delegates, friends and dignitaries in this august audience. There's been quite a lot of technical glitch, but these unavoidable circumstances we often have to face in life. So let us now start off, and I'll try to cut short the talk as much as I can. And I'm Dr. Amitava Sengupta from Paras Hospitals, which is a tertiary unit in Gurgaon, and from the DSC Foundation for Newborn and Children India. So I'll, without much ado, I'll move straight into the program. Just 1 second.
ಏನಾಗಿದೆ ಗೊತ್ತಾ ಅಲ್ಲಿ ವಾಯ್ಸ್ ಕೇಳಿಸ್ತಾ ಇಲ್ಲ ಅವ್ರು ಮಾತಾಡೋದು ಬರೀ ನಿಮ್ದೆ ಅವ್ರಿಗೆ ಹೇಳಿ ಇಲ್ಲ ಸರ್ ಡಿಸ್ಟರ್ಬೆನ್ಸ್ ಆಗ್ತದೆ ಆ ಕಡೆ
Okay, right. So now, just a few things. Right away, I would like to thank the organization committee of NeoCon 2021, and also my dear friend Dr. Satish Ghanta, director of the Little Star Children's Hospital at Hyderabad, for giving me this opportunity to share my experiences and thoughts on DSC and preemie care and neuroprotection in the NICU. So having said that, and without further ado, we go right into the scenario and talk about the changing global scenario in neonatal care. So now, in the last 4 decades, if you may be aware, all of us have seen considerable advances in knowledge and technology of antenatal, perinatal, and neonatal care and sciences, right? And this has led to the highly increased survival of the micropreemies, preemies, less than 1,000 grams ELBW babies. And however, we have to note that this population survival has increased, but the incidence or the percentage of impairment of neurodevelopmental outcome has really not come down, and that is I would say a matter of major concern. You see, these kids who are surviving are in fact going through all this scenario of about a month and a half stay at which is coming at enormous physical, um, then emotional and financial costs to the infants and the families and everybody all together. And so we have to now really focus ourselves and think that the outcome, good functional outcome, good neurodevelopmental outcome, and reach the gold standard of intact survival. So these tiny preemies grow into healthy infants, children, adults, and are of have a fruitful life for themselves and for the region and the country. Perhaps I demonstrate this. Well, this is the place I come from. I belong to Paras Hospitals, which has a tertiary med neonatal ICU, and this is where we started our research and core work on DSC about 9 years back with Dr. Amy Carroll, who is associate prof at Thomas Jefferson University at Philadelphia now. And along this journey, we have had Satish as a very dear colleague and faculty along with us for all these many years. And so, warm greetings from Paras Hospital and DSC Foundation to you all. So, having said this, this is basically we were talking about the advances, greater understanding of pulmonary function, pulmonary mechanics, respiratory devices, the advancements, pharmacological agents, nutrition, so many odd, and so on and so forth. So I will be just basically cutting short my talk because of the paucity of time, but we have talked about advances. Then we'll talk about the huge global burden of preterm growth, and then also the effect of the positive and the sensory inputs into the fetal and neonatal brain, intrauterine environment and extrauterine environment. We will compare the two environment and milieu, and then I'll tell you a little bit about the core measures which are essential to be known before you implement in your unit. And we'll talk about therapeutic positioning and stress and self-regulation, a bit of sleep. So quickly, we move straight away, keeping a close watch on the clock. Preterm birth, the global burden. First time, 2012, WHO went into this project, Born Too Soon, to get factual figures of what is this global burden about. And it was seen that this global burden of preterm birth affects the developing countries as well as the developed countries. India had a figure of 3.5 million births. China had 1.1 million births. America had 0.5 million births. Nigeria had 0.8 million births, and so on. So it affects the entire globe. So basically, we have huge global burden of preterm birth. Advances have increased the survival of tiny babies.
So this whole population is huge, and we better look at their outcome. Rather than just survival, we have to see quality of life and the intact survival. So herein I will just quickly rush through two main milestones of preterm related to preterm birth in utero. Third trimesters, 7, 8, 9 months, the flexor tone and the flexor posture starts developing, and by term, the baby is nice, well, good tone, flexor tone, as you can see in my visual over there. And this development of this flexor tone and posture lays the foundation for future neuromotor development and has effect on the neurobehaviors, which we will talk about some. So this is a very important thing. The last 3 months, the ventral muscles are maturing on the chest. So the baby is getting larger and the baby contracts. Yes, Satish. Yes, I'm watching the time. Hello? Yes. So now there is, you see this baby is in extension and is a preterm baby. So as a result, gravitational pull, baby is hypertonic and in extension. The other baby, 36 onwards, is a good flexion. The next important one is the third trimester is a very busy time for the brain. Lots of brain cell production, neurons are being formed and being differentiated. Okay, there is synaptic pruning, the joints between the bridges between the two neurons. So it's a time when the germinal matrix, the factory is producing, and so this is the time negative sensory input into the fetal or neonatal brain will cause absolute great harm. Positive sensory input is great. So this is very important for us to know. You see how the brain rushes through 20 weeks, 29 weeks, 35 weeks. The term neonatal brain has basically 100 billion cells, and it is advancing and developing in a very fast rate. A quick word about the intrauterine environment. Positive sensory input is happening. You see, here is a baby who is in containment, inflection tone, less exposure to sound and light, preservation of the sleep cycle, and a continuous connection with the mother by chemosensory, somatosensory, and auditory pathways. This is what I had just mentioned. This is a list of what I mentioned. So I'll rush through. You have already been told. Uterine wall forms a good wall. And you know, auditory stimulus, maternal voice, heart sounds, bowel sounds, and blood flow through the. These are all heard by the the baby in utero. And the most important point is the filtered sounds from extrauterine. The extrauterine sounds are coming through the skin, the fat, the muscle, the organs, and very refined one is coming into the baby. Whereas once the baby, preterm baby comes out, boom, there's a huge sound. So we have to look after all these things. This is a baby in the NICU. You can see they are being looked after, great intensive care, but they're on their own, family centered. Connection is cut off, which we have to learn how to evolve. There's a huge fluctuation in temperature, tactile, olfaction, auditory, and basically the bottom line is negative sensory inputs replace positive sensory inputs into the developing brain, and this can alter the brain development in a permanent manner. So you see this tiny baby, and the small one you can see in this horrendous environment. We have to learn how to treat these babies like individuals, speak to them, talk to them, sing to them, and look after them in a very humane and supportive manner neurologically. So DSC basically cuts down on your stress, control of external stimuli, right? Autonomic stability is brought down. It supports normal sensory, motor, and neurological development. It decreases length of stay, weight gain, and brain growth. It's a team who looks after you. See, baby is right in the center, and we have the neonatologist, the NICU sister. The neonatal therapist is a very important individual in the team, and occupational therapy and physiotherapy, the neonatal therapist is imperative to help us to look after the baby and along with the family. Quickly, core measures, which are very important to know. 2009, Colleen had discussed about 5 core measures, and these we better know before we think of implementing or learning about application in our unit. Number one is the protected sleep, which gives you a deep physiological sleep, which gives good weight gain and brain growth, that good healing. Pain and stress assessment and management, activities of daily living, which is positioning, feeding, and skin care, family centered care, and healing environment. Now, you please note the number 3 has 3 individuals. Now, then in 2013, Philips, Altimer and Philips, they recategorized into 7 distinct varieties. It's the same thing which has been further expanded. If you notice, healing and environment has remained the same. Partnering as families is with family-centered care, minimizing stress and pain, and safeguarding seal is protected sleep. So now, if you go back quickly, now the third one, where you had positioning, feeding, and skin care, they have been given individual identities. Positioning and handling, very important. Protection of skin and optimizing nutrition and feeding. So here you see healing environment, then you see partnering with families, depicted on the petals of a lotus. Safeguarding sleep, stress and pain. Now, here we won't be able to deal with all these things in a great manner, but just quickly about each one. Pain. Neonates were thought to not be able to experience pain. Absolutely wrong. And they were thought not being able to surmount any measurable response to pain. Absolutely wrong. The babies can have acute impact on the physiological status with pain, and prolonged exposure, repeated exposure to pain can give you gross neurodevelopmental problems. Protection of skin, optimizing nutrition. One note I would share with you, which we do in our unit, all these tiny babies need exclusive human milk diet. We either use mother's own milk, MOM, express breast milk, EBM, or PHDM, pasteurized human donor milk, which we get from the breast milk bank. We have a scenario in Delhi. From there, we get it at a very reasonable cost, and we use that, or certain companies also supplying the breast milk. This, if you see, are all the core measures, 7 core measures. Healing environment is the same, is in the center. They are all intermingled. There's this areas which are mixed. So that means they are all working conglomerate, working together. It is not that you are in charge of optimizing nutrition, so you will not bother about protecting sleep. So each one has to work for all the measures, but maybe you would be solely responsible for one unit. And in this methodology, you can split your unit with your sisters and your workers into different units, different co-measures, and each one being responsible. That gives a sense of responsibility and belonging to this entire project. Now, quickly, sequence of maturation of the senses. 1, 2, 3, 4, 5. So here I will teach you a method where you can learn the sequence. In the non-COVID days, we used to say, okay, shake hands or embrace. Human touch is a very major scenario of our being. Now, of course, it's different due to COVID days. So touch is first, then the position balance, then you can touch your nose, olfaction, then you come down gustatory and go clockwise, auditory and visual. So if you know this cycle, if, as you can see in my visual, you will never forget the sequence. The main thing is you cannot stimulate a sensory system out of turn or out of sequence or out of cue. First one which you can manage with is tactile, then vestibular, then olfaction. You cannot do visual and auditory, that will make everything go haywire. Protective sleep, as I said, conserves energy, increase weight gain, and optimal brain growth. Safeguarding sleep, just two words: all non-emergent care to be done in wakeful states and involve the things like facilitated tuck, swaddling, skincare in your daily day-to-day routine to promote sleep. Light, sound levels we know of in families. Stress and self-regulation. This is a format which we use in our unit, which I can't get into the details because of paucity of time, which we fill up as the baby comes in, and then we periodically keep filling it up, not every day at all, because this has got too many details. So just to remember, stress is on my left side maybe, and you have three markers: autonomic markers, motor markers, and attention markers, and the right side is the self-regulation, and then you have the sleep states in the center. So neurobehaviors. What are neurobehaviors? They're the five subsystems. Stress, as I have said, autonomic, motor, and attention, three gone. Self-regulation, self-calming, which is the best for us, for the baby, and sleep states. There are five categories, so these are the five neurobehaviors. The last one to mature is self-regulation. More term the baby, more the maturity, and more the self-regulation. A preemie baby has no chance of self-regulation. You have to self-regulate the baby. Neurobehavioral capacity is the capacity to self-regulate. Quick rush through the pictures: autonomic rates, autonomic stress signs, the motor stress signs, back arching, splaying is a very common one. You know, sitting on a, and attention and self-regulation. Self-regulation, the best one is the flexion position, midline oriented, very important. And that is what you should look at as soon as you enter your NICU. What is the position status of your babies? Hands to face, foot bracing, and this is a very interesting one. The grasp, you can put your little finger there, the mother can put the little finger there, and the caregiver can. And so this is grasping, is goes self-calming. This is a baby in stress, of course. We rush through positioning. This is an infant position assessment tool. I can't get into the details now. As Dr. Satish said, we're running very short of time, but there are six items, and we have you know modified it ourselves, and happy to state that this has been published in the textbook of neonatology of IAP and NNF in 2021, this chapter of ours. And so here you see the head, neck, shoulders, arms, hips, and in sequence, if you remember, it is easy. And so there are six items: 2 for best and 0 for min. So you can get 12 out of 12 or 0 out of 0. And in this new one, we have added also, as you can see, the autonomic markers, and we have got entry dates for 3 dates. So anything between 10 to 12 is great. Acceptably beyond 9 and below 8 is, it needs repositioning. This picture, as you can see, self-regulation, hands to face, foot bracing, nesting is very nice, is a good deep trough. Here you can see the baby has got 2 because the neck is midline and well flexed, good position. Shoulder is also turning inwards. So this kid has 10 to 12. So score. Positioning along with supporting environment gives protected sleep, and protected sleep augments the weight gain and the brain growth. This is a similar baby. And you see now, one important thing which I would just focus on in this slide: remember that when you're doing diaper change, always keep the hips absolutely below the level of the head. क्या होता है, diaper change करते हैं, we have a tendency to put it up, change the diaper, and the head is below. In this situation, where the head is below and the hips are above, there is a great chance of increased intracranial pressure and of germinal matrix hemorrhage. So remember to keep the hips below the head level while diaper change very carefully, and to keep the baby in a midline orientation. These are some pictures of our babies at PARS who are in supine position, the well nested, midline orientation. This is prone position. You can put a ventral support. These are methods by which we are trying to neuroprotect these babies so that the babies are well preserved when they are being discharged and going into the high risk neonate clinic. They should be supervised, otherwise, you are in fear of SIDS. Sideline position. One note here, the dorsum must be protected. Dorsum must be supported. An unsupported sideline position is one of the most stressful situations. So if you see this baby here, he is in midline orientation with bracing, but a dorsal support is there. Even in the incubator, whether you use the giraffe or any other one, you have to follow the same protocols over there. Sleep states, basically, I would say, quick way 6, but the differentiation between deep sleep is there is no movement of eyeball below the closed eyelid, very minimal motor activity. Light sleep, there is movement of eyeball and a bit of what you define as motor movement. Dozing and awake could be quiet alert or active alert, which is with movement. You just see now. Now here you see our friend. I hope you can see the video. This is a baby in our unit in deep sleep. There is no movement of eyeballs, regular respiration, and no movement. So this baby is in deep sleep. That's good for the baby. Now next one. Now this one, if you keep a close watch, there's mouthing movement of eyeballs below the closed eyelid. But light sleep is also good for the baby. This is REM sleep. Deep sleep is non-REM sleep. And so you will see that there is some fine motor movement. Now here in adults, and in adults you have a very less amount of REM sleep, and otherwise it's mostly non-REM. In the babies, you have 50% REM sleep, 50% non-REM. Preterms can spend up to 75% in REM sleep, which is very good for the brain activity as well as for the learning things. And this is a drowsy state, which is the third one, where you can see he is in a scenario of switching over. Here you see a baby who is in a quiet and alert state, aware of the surroundings, looking very well, is a good neuro behavior, but not much motor activity. And sound and light, you anyway know. I won't go into the details. 10 to 600 lux is at the infant bedside. 1500 to 2000 is for procedures. It should be a fragment free and a scent free unit. You should not be permitted to wear very fancy perfumes or colognes or aftershaves. And also, I would like to mention that in the present days, when you are using so much of sanitizers, you should be sure that the hands are dry and even smell that there is no the smell of pungent sanitizer, because as soon as you do that and you touch the baby, that is a noxious odor which can be harmful for the baby. Mother scent via breast pad, octopus therapy, etc. is good. Gustatory drop of milk of colostrum even on the tiny baby's tongue is very great. Auditory and visual we have talked about. Partnering with families is a detailed chapter itself, but we can discuss at some other time. We have talked about sleep, stress and pain, and protection of skin. You have to be very careful of the adhesives which you are using. Main thing is to prevent unnecessary skin breakdown, and use Braden-Q scale, which you can check out for I cannot explain now, for skin integrity, so that you will know and score the risk of skin breakdown. Optimizing nutrition, here again I have mentioned, it is essential that we focus on exclusive human milk diet. Now here is about the you know neuroprotection. Hips below head level, diaper changes, keep head in midline. And when you're ventilating a baby, don't be very excited in having PCO2s below 30 and keeping it at 25. You will have leukomalacia. Now you will ask me why. Because below 30, if you keep persisting with PCO2 below 30, you will have vasoconstriction and ischemia to the brain. That will lead to leukomalacia. And so that is what we don't want. And the mean arterial pressures we should keep under control. Minimize pain, handling, temperature, and decibels, because these can cause brain germinal matrix hemorrhage. And of course, antenatal protection, you are aware of betamethasone and magnesium sulfate. Now, temperature, thermal environment has to be looked after. Crying may impede blood return and may cause increased cerebral blood volume and cerebral. Stimulation such as light and sound can raise your blood pressure and cause various problems of germinal matrix hemorrhage. Infuse your fluids very slowly. Suctioning again and again on a routine basis, absolutely uncalled for. Suctioning can increase cerebral blood flow. So please be careful. And we have already talked about these things. Now, just the next, I think I've got 3-4 minutes left, Satish. Just a quick visit to octopus therapy. This, to be very honest, we learned when we were visiting Russia, St. Petersburg State University, to deliver our workshop. That was one of our first international workshops of DSC Foundation. And while we were delivering our stuff there, my colleague says, "Sir, they're doing octopus." I said, "What is this?" Then they showed us their unit. It was great. This is crochet, made of crochet, no fiber, no wool, nothing available here. It's absolutely clean, just to be soap and water cleaned. And it is very popular there and in Scandinavia. Finland is next door, so that is how this comes up. And it started in Denmark initially. And from there on, it's been spreading into Europe also. And we picked it up in 2018, and we have been practicing it with great happiness in our unit. But to be frank, they give us about 10 or 15 of these octopi. And so now we are trying to see how we can get some made here with that quality. You see, the tentacles remind them of the umbilical cord, number one. And when they are gripping on it, there's a similar experience, the chemosensory stimulation also, smell. And squeezing of tentacles creates a sense of safety and comfort. Regular heart rate, levels of oxygenation are better. And also their project research people had said that it prevents preterm babies from grasping on the tubes and pulling them out. Some of our own mothers very proudly exhibiting the octopus given to their baby. And as you can see, this is a grasp reflex the baby is on, so that is giving self-regulation. And this baby is in deep sleep, very happy with his octopus. You can see a good grasp reflex. They tend to go for it. And now another thing which we did ahead of the St. Petersburg people, and that is what we told them, that we need to sort of do kangaroo mother care for the octopus prior to the delivery, if we can counsel the parents. Now this is an acquired alert situation. The baby is with the octopus and having grasp reflex. This was in deep sleep. Now here, this first what we do, just 3 minutes, 3 minutes more please. So this is another proud mother. And what we do in our unit is we give the octopus to the mother. After explaining the entire science, we even give a bit of PPT presentation to the family. They get very excited and learn about this new stuff. And we tell them to give 8 hours kangaroo mother care to the octopus, so that the maternal odor is transferred to the mother. And then we put the octopus next to the baby. He has umbilical cord sensation and the maternal odor. But she gave us a brilliant idea that once the baby is born, every day I have to do KMC for the baby and KMC for the octopus. Why can't I do it together? I said, fantastic idea. And so that is what we learned from her, and we have been advising other mothers that once the baby is born and the baby is on octopus therapy, you can definitely give KMC to the baby and the octopus together. And then when you go home, we use the octopus with all these sensory system stimulation of the baby. This is another of our babies, and this is from our friends in St. Petersburg, some of their babies and their twins. And so, having said this, we are at the end of the situation. I rushed through, and sorry I could not get into details. Contribution to positive outcomes should be our highlight. Environment should not have more sensory stimulation than the infant's individual stress. I should be able to tolerate what you're exposing me to. We have a good session, then we go down and we said, let's discuss about the session and go to a quiet dinner spot. Otherwise, somebody takes me to a loud disco, I can't tolerate. We move out. But here the baby can't move out. Proper balance between infant and care environment. The baby should be well organized, good neurobehavioral status, neurobehavioral capacity, as I said, conserve energy for growth and development and brain. Avoid contribution to negative outcomes, physiological instability due to sound, light, rough handling, caregiver behavior is not good. So many odd scenarios which are detailed. It's a huge book which we have written, but so just trying to just sensitize you. Pain, you have to have protocol based pain protocols, whether you use premature infant pain profile or whichever one you wish, some regulation on pain, and so that you know that repetitive pain exposure is not there. And finally, again, that same slogan of mine, improving functional outcome, having positive neurodevelopmental outcome, and having an intact survival for a good, healthy infant, child, adolescent, and adult with a good, fruitful life, contributing towards his or her own life and the country and all of us. Thank you very much again. And sorry I had to rush through, but then we had to do so because of time constraints. Thank you. Thank you. Thank you very much. Satish, that's done. Satish, are you there? Junior? Okay, I'll stop sharing the screen. I hope you could hear me loud and clear. And our participants also could hear me. I had to rush through. But, anyways, thank you very much for this opportunity, even though it was cut short. But I'm sure things will go very well now on. And was just for my own knowledge, was the sound clear at the physical end? And if I may ask Satish, just can you give me, if you wish, if you can give me 5 minutes, 3 minutes, I can show some interesting videos and close it up in 5 minutes. Okay, fine. Thank you, thank you, thank you. Okay, then maybe maybe I can show them one video so that they can two videos. That's one self, one no, just one you can see, and then you can see this and like it for yourself. So here the baby, as I will describe, is in a deep sleep state. He is in midline orientation with a good flexion posture, hands to face. Oh, sorry. I have to stop sharing. Sorry. 1 second. 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 Sorry. Okay. Yes. Oh, there's something coming up here. My sharing has stopped. Somebody else has come into the screen. Okay, I'm ready. Can you see now? Yes, so here we see a baby who is in deep sleep, has got a good nest around him. He is in midline orientation with good flexion. Self-regulation is primary, hands to face, hands to ear, flexion, bracing. The diapers are a bit too big. I'm not happy. It should have been smaller. But however, the baby is doing pretty well in this scenario. I'll quickly stop this and show you oh. No, well, no. Can you see this video now? You see, this has been a great disturbance. The baby went into leg extension and splaying, and the autonomic markers have come down. No, we can just have a quick rush again. The baby is pretty happy, well nested. Now we have to learn to tone down, you see, leg extension, sitting on air, and finger splay. So this is an example of environmental stimulus, which is the phone call. And so this tells us that we should definitely reduce the levels of our mobile. Should not be in full volume. They should be either in vibratory mode or silent mode, and the phone calls also. And now this is the last video, and because there's not much time, so even babies who are being ventilated in our unit, we stabilize them within 1 or 2 hours, and we get onto them. You see, good flexion at the knee, midline orientation, hands to the midline, good bracing, hence your nest has to be similar. He's on ventilation, he's on maybe lots of infusions, but he's maintaining a good autonomic stability, intra-arterial monitoring also going on. But that does not stop us from keeping a good view of therapeutic positioning. Sleep state you cannot talk about here because maybe the baby is on fentanyl for pain, and so that is the whole scenario. So I think that's it, Satish. We are short of time, so I would quickly stop sharing, and that's it. And thank you very much. And I'm sure we'll have a great time again. And really, I admire your perseverance in really working hard in spite of these odds. And you have set it right, Satish Junior, Priyanka, and the whole team. Congratulations again for taking it off. Thank you very much. Right. Thank you.
Yeah, hello. Yeah,
So I
Nitish,
think
can you
there are
hear me?
some audio issues at the site.
No, no, it's
Uh,
okay. Nitish, you can start now.
yeah, great,
Nitish, you
super.
can start.
Sure, thank you so much. So again, to go back to so far whatever we have spoken for the advantage of the people who missed us out, primarily you need some infrastructure, we need some equipments, but that's not a lot. Primarily what you need is a small room, a low chair, and some toys, and a lot of forms wherein you can actually, the therapist or the assessor can actually assess you and then offer therapy. Okay, so that is what is the primary goal. Whatever are the high end things like CT scan, MRI, EEG, EMG, those kind of things we can actually share with larger organizations. Therefore we are able to utilize appropriately the resources which are very limitedly available to us. Okay, so again, a part of the charts or the graphs which you would be using would be growth charts, whether it is preterm or term. So apart from that, you need the, see, uh, DASI is a very good test for our Indian kids. It is looking at developmental assessment of Indian infants. Okay, so these are small group of toys, and it is looking at all the four domains of the way the progress is happening. And then based on the deficiency that is identified, the care could be provided. There's a very simple toys, simple form which is available and can be used extensively. This is just a very simple, Hammersmith is a very simple visual cues as to where you should consider disability. I'm not going to go into details of this because in the morning session there has been a lot of discussion on all of these already. So these are very important. Denver scale, again, looking at the milestones, we draw a vertical line at the month of the child, and whatever is to the left, the child should have achieved. If not, again, it tells you whether there is a gross motor problem, therefore you ask your physiotherapist, language problem, where you ask your audiologist or speech therapist, fine motor problem, your OT, and personal social, your psychologist. So that is how we actually want to utilize the available resources with us. It's not that we need the high-end resources for every kid. TDSE, again, an extremely useful scale for us to be able to identify problems and therefore offer care. Language assessment with the help of LEST. And this is an MChat. Audiology, this is one equipment where I would recommend us to be spending some money on, primarily because the infants, they're all sensory beings. Primarily, they learn everything, they're able to offer or get to know their milestones by seeing and listening. So otoacoustic emission as well as BER are extremely important for all NICU graduates, for all babies who have had some difficulties in their early life. So that is extremely important. It costs about 2 lakhs, and all children ideally should be screened. Again, with the ROP screening also extremely important. As I said, it is very important that you either tie up with a center which is offering the care wherein they bring in their equipment, or you can spend about 1 lakh and then have a person who would just come in without their equipment and perform the things with you. Now, when it comes to the personnel, it is a team effort. I mean, again, I've heard in the morning, I've seen there's a lot of talk on who all are important. We all know our roles. The pediatrician is the nodal person. He should be able to identify who and which service is required and offer that to the child. But again, we don't need each one of them to be present full time. Primarily, the full time people which we need, or where does the money go, is in a full time receptionist who will be multitasking primarily for giving appointments and follow ups. The main problem that a lot of child developmental centers are facing are lost to follow up. So, therefore, if we have a person dedicated for that, it obviously helps us a lot. A nurse to help with all the therapists, just not the pediatrician, but all the therapists, the nurse will be able to help. In fact, she'll be able to help the receptionist. These are the two full-timers I would expect them to have. And how much would a full-time nurse or a receptionist cost? You all know, somewhere between 15,000 to 25,000 in depending on where you are situated. Therapist, an early intervention therapist is preferable. He could be sessional, but it is preferable to have a full-timer. And again, a therapist would cost a little bit more than a nurse, but a way lesser than a doctor. So you can imagine where we are in terms of our ongoing costs. All the other people are all sessional people. I mean, they may do a session or two with you per week, and you can take their costings based on where you are situated. So when it comes to the infrastructure and equipment, there's not a lot that you need to be spending on. It's primarily the money is going towards personnel, and that too, that's not a lot. And when it comes to the assessment forms and stuff like that, if you should ask Dr. Naveen Jain, he'll say, look, I have a blue book which I give to all NICU graduates, which costs between 40 to 60 rupees to me. And he's been very kind enough to have shared a lot of those books at many workshops. And I'm sure soft copies he'll be very happy to kind of give, so that each child may need 5 forms, 5 rupees. So that's the amount of money it takes to create those small booklets for following up these children. Now, some of us also have very high-end softwares and programs that may cost a lot. So obviously it depends on where we are situated and what kind of degree of work we want to do. But that is more for data collection, more than the provision for therapy. So the take-home messages are not a lot of space is needed, not a lot of equipment is needed, a few dedicated personnel are needed. Sharing of high-end facility helps a lot. That is what I strongly encourage a lot of pediatricians who are listening this talk to kind of take home, that please do not look at buying the EEG, buying the CT scan, MRI facility at your own center. Please try and use this facility as is available within your city. Okay, and with little intervention, a lot is to be gained from neurodevelopment interventions. With that, I'd like to thank my talk. Thank you all and finish my talk. Dr. Femita is going to tell us with these measures, what I have just spoken to you about so far, what developmental advantages they have seen in babies in their child development center. Thank you so much.
Thank you, sir. Am I audible, sir?
Yes, madam.
Sir, shall I start screen sharing?
Please.
Visible, sir? Is the screen visible, sir?
It is visible. Please go ahead.
Yeah.
Please go ahead.
So we've heard in the morning with all that stormy events that happened, what the country's experts have to say about the need for neurodevelopmental follow-up and what is to be done, what it constitutes of, and from Nitesh sir, what infrastructure it requires, how less infrastructure it requires in really. But I'm sure most of you are wondering whether it is actually sustainable, and if it is sustainable, does it make a difference? We all agree that however tumultuous the journey is during the intensive care of a baby, it is the outcome in terms of neurodevelopmental disability or ability and growth and a normal life which matters both for the parents as well as for us clinicians who feel very good when they come back healthy and happy. Now, allow me to lay some foundation before delving into what I'm going to present now. We at KIMS Health have been doing for the past several years outcome measurements. So, in any sphere of human development or endeavor, the heart of improvement, whether it be science, education, economic, or health, good decisions come from good measurements. And these are measurements of outcomes that you need to do systematically. So, when the methods and techniques of these measurements are well planned right at the start itself, then the result is the availability of data that is systematic, reliable, precise, and dependable. So, with that very goal in mind, the KIMS Health has been having for last more than 2 decades now a neurodevelopmental follow-up clinic. And here I am to present to you the data over 8 years from our level 3B unit, which has an attached child developmental center. The outcome of these preterm infants who were less than 34 weeks of gestation at birth at 3 years of corrected age when they're expected to be preschool. So that definition is kind of changed now in COVID era, but it is preschool. So at 3 years of the corrected age, what happened to less than 34 weeks of gestation over 8 years in our unit? So like Sir said, we have this blue book. We're very proud of it. It happens to be a validated risk stratification model. And there's a real-time checklist there, which most people do use nowadays. And we have a structured follow-up plan also in terms of timely assessments for all of these things that you have heard of today and will be hearing also more. So I won't go into much of those details. So you might want to counter me and tell me that the parents or the babies may not be able to come back physically for assessment now during this era because of difficulty in travel and lockdown situations and very unpredictable situations. But we have been doing the ages and stages questionnaire online nowadays. If you have my video blocking the right side of the slide, just move it off and see that the development therapist who is sitting on the left of the video is waving out and doing her social overtures and is actually getting a response from the child on the other end and is also able to interact with the mother who is expressing her concerns and whatever doubts she has. So yes, it is possible to do developmental follow-up even in the COVID era when physical presence of the patient or the parent is not possible. So that's what is happening now. With that, I will present to you what we found by a retrospective observational data analysis. We included all of those who were less than 34 weeks of gestation and who were discharged from our NICU alive after completion of care. So the primary outcome we wanted to measure is important. We wanted to know how many of them, of all of them, that is the proportion of preterm infants who were discharged from our NICU had no major neurodevelopmental disability. Now, let me define major neurodevelopmental disability to you. It was any one of either motor or mental impairment in terms of a Darcy DQ of less than 70 in any one of those, that is motor or mental developmental quotients, or visual impairment with blindness in one or both eyes, or hearing impairment in terms of requiring some kind of aid or therapy. So it is the number of ors that I have added, which makes it a very, very sensitive definition. And any of these would make it neurodevelopmental disability. So we wanted to know how many or how much proportion of the babies had none of these things that we listed just now. So there were some other secondary outcomes that we intended to measure. We wanted to analyze what perinatal and neonatal risk factors may be independently and statistically associated with neurodevelopmental disability, and NDD defined just that in the previous slide. Also, the compliance to follow-up and other eye and hearing outcomes. So you can see the flow diagram there. Out of 840 infants who were assessed for eligibility during these 8 years, we enrolled nearly 700 of them. And no major neurodevelopmental disability was found in more than 90%, which means that more than 90% of them had a normal outcome. And this word normal is very, very, very nice because this definition of NDD is very, very sensitive. So even if one domain had a problem, we classified them as NDD. So no NDD means that they were absolutely good, and more than 90% of them happen to be like that. Now, let me emphasize one more point there. In the second box there, you can see that 28 weekers and less were nearly 80 plus in number. And out of those, 86.2% of them happen to have no major neurodevelopmental disability. So that's quite encouraging. Out of the 17 risk factors that we analyzed, that is perinatal as well as neonatal, these were the 3 which we found as independent by multivariate analysis: refractory shock, symptomatic hypoglycemia, and cystic PVL at 40 weeks. If you go back and see, 2 of them at least are potentially modifiable risk factors where we could have probably done something better. So we need to audit and see what we did with those babies who had refractory shock. Could we have managed them better? Should we have waited for symptomatic hypoglycemia to happen, or should we have managed them better? So if you do a risk factor analysis, you might find 1 or 2 of them which are modifiable and which might help in improving outcomes. This, I believe, is the most important of the outcomes, that in less than 28 weeks gestation, that is the highest risk group, at least 88.9% of them were available for follow-up at 3 years of corrected age. That would be nearly 3.5 years if you take it. So either by direct assessment or by telephonic assessment, something could be done to find out whether these babies were okay or not at 3 years of age. That's 88.9% of compliance in the highest risk group. Now, you will ask me what happened to those who were lost to follow-up. So what we did was we tried to analyze those who were lost to follow-up versus those who were not. And we compared the last available follow-ups as well as the risk factors between these two groups and found no big difference between them. So hopefully we did not lose too many of them who were really bad. So the fact that 88.9% of the less than 28 weekers were available for follow-up to us, and out of those 86.9% of them were normal, is not easy to ignore. It's quite an encouraging finding. We leave out the first and the last one. I'd like to underline the second point, that is the squint and refractive errors requiring intervention were nearly 6.5%. This is very easily correctable form. So if my video is blocking the right side picture, remove it, and you can see the baby sitting there with the specs out there. That's how they adjust to it, and they do very well once their visual outcomes are better. Really, if you can't see my slides, you wouldn't be interested in listening to me at all. It's the same for their case. Their learning, everything will suffer if you can't see. So in the discussion and conclusion of our findings, look only at the fourth point. There's good compliance to follow up. Yes, there is. It is possible to do neurodevelopmental screening. Now, owing to increasing technology and better understanding of pathophysiology, advancing whatever is available to us, we have been witnessing improving survival even in those who were at the thresholds of viability. So you can see at 24 weeks of gestation, the survival rates are touching 80%. So if that is happening in your center and you're improving and improving with each year, then there's really no reason why you should not have a neurodevelopment follow-up clinic. You don't have to save them just for them to go elsewhere, and you would never get to know what happened to your babies. So follow them up in your own center. And as Nitesh sir said, it's all that requires is one room with 1 or 2 people and quite a structured process. That's it. Thank you, sir.
Thank you, madam. I think we might request Satish to take over once again. Physically, he is available at Bangalore. And if there are questions from any of the participants, kindly put them in chat box so we can discuss them. I guess we are behind schedule, so it's better to put them in the chat box. Um, Satish could take over the physical form.
Because he'll be available on this thing as well at the end on the panel discussion. So if you have any questions, you could do it now, or we could do it at the end as well. You're okay? Yeah. Next one. Play the next one. Ask this guy to log in.
Myself, Dr. Shivkant, consultant radiologist from Narayana Health, Bangalore. So, welcome to this presentation. I've been doing exclusive neuroimaging for the past 5 years. So, when it comes to the MR imaging of brain, both in terms of acquisition as well as interpretation, the difficulty level significantly increases as the age goes down. So, today we'll be discussing mainly about the neonatal imaging, and I'll go into the preterm as well as infant in some areas. So what we are going to discuss today, the overview of the talk is what the normal imaging appearances are. We need to know a little bit about the brain development and maturation in terms of myelination, and also what to look in different sequences. That is more important. Once we know what to look in different sequences, then we'll discuss about the approach to some of the common clinical scenarios that you come across in your routine practice. Before going into that, we need to know certain practical limitations. What are the limitations for neonatal MR and also the checklist for interpretation? So these are neonatal scanners which are exclusively used for neonates. In US, they have been approved in the last couple of years, but so we are not fortunate enough to have these kind of scanners where these are small bore MRI scanners which are attached to the NICU so that the minimal mobility will be maintained so that it is easier to scan the babies. So when it comes to neonatal MRI, the main practical limitations are to be able to maintain the complication rate minimal. So it is a good teamwork as well as from the clinician side as well as from the imaging team. From the clinician time, like scheduling of the MRI and making sure that MR compatibility is there. There are no any devices like cardiac devices are not there which are not compatible with MRI, and sedation and monitoring during the scan. All this is done to make sure that baby is not mobilized, not moving too much during the MRI scan so that we'll be able to get a good quality images. And also having a provisional diagnosis before starting the MRI itself will help in planning the type of sequences also. When it comes to the technical factors, main factor is the coils. So because of the head size of a neonat is too small, the routine adult brain coil may become too large for the neonat. So if you are doing it in a 1.5T scanner, it is better to do with a knee coil so that that will be enough to cover the neonatal head and make sure that isocenter is placed exactly at the center, then the selection of right sequences. These are the technical issues that we need to consider. And coming to the checklist, before interpreting any neonatal or any infantile MRI, I'll always look at these factors. First thing is gestational age at the time of delivery. First thing, then at the time of scan, what is the adjusted gestational age if it is a preterm baby? Then the type of delivery and relevant birth history, onset of symptoms, then contrast is given or not, and the technique. Is there any sequences that are missing or any significant movement artifacts are there which need to be repeated? These things we'll look at before trying to interpret the scan. Now let's have a look at the normal neonatal MRI. So in order to interpret the MR images properly, you definitely need to have a very good understanding about the normal anatomy and normal development. We can divide the development into three parts actually: cortex and white matter, or the ventricular system, and then the vascular system. So how the normal anatomy is appreciated on different sequences is very important. That forms the major part of your approach to any pathology. So when you come to neonatal brain MRI, these are the basic sequences that are required. Diffusion weighted images, T2 axials, T1 axials, T2 flare, SWI or GRE sequences. These are considered as basic sequences which have to be done in all cases. Whereas these are some of additional sequences like MR angiogram or venogram, Fiesta or FFE, and post-contrast imaging, which are required in select scenarios, whereas the advanced imaging like MR spectroscopy and DTA, they're more useful in much more select scenarios only. So let's try to look at the basic sequences once for understanding the normal anatomy. Let me take you through the images. So these are the DWA images. In the beginning, it may be tough for you to identify the diffusion images directly, So in any scanner, even if you are looking at films also, usually you will have a patient data on either right or left hand corner. Along with the patient data, you will always find the sequence. So during the beginning, at least you get to know the sequences better. Try to look at the sequence that you are looking. After that, you can try to interpret the sequences. So when you are looking at the diffusion weighted images, one thing you should remember is there should not be any bright signal anywhere in the diffusion weighted images. That is called as restricted diffusion, and that is what you are looking for. So for example, when you are looking on the images, you can appreciate that there is some bright signal along this area and here. That is an artifact which occurs because of the adjacent bony and the soft tissue interface here, bony and parenchyma interface along the basifrontal areas and also along the posterior temporal lobes. So this minimal hyperintensity is normal, that is normal variant or artifact you can call it as. Whereas apart from that area, there should not be any bright signal anywhere else in the parenchyma or in the ventricular system or in the calvarium or outside also. Just for example, in this case, if you are scrolling just outside the calvarium, you can appreciate some bright signal in the subgaleal planes. You can just make note of it before going to the next sequence. So when you are looking on the diffusion weighted images, you may not be able to differentiate the cortex and gray white matter. That is not your job. You are looking only for the restricted diffusion or bright areas, because majority of the acute scenarios, they will show restricted diffusion, and picking up the restricted part is very important for your diagnosis. And also make sure that you always start your inspection with the diffusion weighted images so that it will become easier to put forward a pathophysiology. Now let's look at the T2 axials. So in the T2 axials, normally the CSF will give bright signal. So in the ventricular system or in the cerebral sulcal spaces, you will be able to appreciate the bright signal. That is one thing you should remember. And in the neonatal, because the myelination is not yet complete, entire white matter will be showing hyper intense signal, whereas the gray matter will be giving dark signal. Here what you can see is the cortical gray white matter junction is clearly differentiated. So if you have any gross cortical abnormality, you will be easily able to pick it up. Apart from the cortical abnormality, white matter, it's better not to talk about the white matter in neonatal brain on T2 weighted images also. It is normal to have this kind of dark and white patches in the white matter because of the ongoing myelination. So when you are looking on the T2 weighted images, one more thing you should remember is the vascular structures. The vascular structures will give dark signal. These are called as flow voids. This is the superior sagittal sinus. Here, this is the vesicular artery, ICA. So any vascular structure will give dark signal on T2 weighted images. So that is one thing you should remember. So when you are looking on T2 weighted images, just look at the symmetry of the brain. Then any hypointensity or any obvious mass effect is there, or any periventricular seepage, any ventricular dilatation. These are the things you should try to understand or try to observe. So that is about T2 weighted images. Now let's look at the T1 weighted images. So during the neonatal or infantile period also, T1 weighted images form important sequence because of the undergoing myelination. So all the myelinated fibers will give bright signal on the T1 weighted images. Just for example, here you can see that this is the posterior limb of internal capsule as well as the globus pallidus and also ventrolateral aspect of thalamus. So these are the areas which are myelinated at birth. As you progress superiorly, you can appreciate that the bright signal is moving superiorly in the centrum semiovale. The remaining frontal white matter you can see as a dark. Posteriorly, parietal white matter is also dark, but in the centrum semiovale, you can appreciate the bright signal. So the myelinated structure from the superior and pre and post central gyri, that is the primary and motor and sensory cortices. From them, they'll start off and inferiorly along the centrum semiovale, along the posterior limb of internal capsule, ventrolateral aspect of thalamus. These are the areas which are myelinated at birth, and these are the areas which give bright signal on T1 weighted images. So if it is a term baby, definitely you should look for the myelinated structure. But if it is a preterm baby, then even the myelination will not be complete. So even these structures will not be seen as bright colored, bright areas. So apart from the supratentorial compartment, in the infratentorial compartment, the dorsal brainstem is the one which will be myelinated completely at birth. So that is one thing you should remember. So when you are looking on T1 weighted images, what are you supposed to look for? One is the myelination. Apart from myelination, any areas of bleeds, if it is in the subacute phase, it will give bright signal. So it is easier to pick up the subacute bleed components. So any areas in the extracranial or extra-axial, that is in the subdural collections, it is easy to pick up on the T1 weighted images if it is in the subacute phase. So these are the areas that you should observe when you are looking on the T1 weighted images. Now just look at the T2 flare images. So because of the ongoing myelination again, you will not be able to differentiate anything. The gray white matter junction or gray matter white matter also you will not be able to appreciate. But the utility of flare imaging in the pediatric or neonatal images lies in its detection of CSF, because flare is a sequence which will suppress the signal in CSF. So as you can see, the ventricular system as well as the sulcal spaces, they are not giving any signal. So any abnormality in the sulcal spaces, be it subdural collections or leptomeningitis component, it will be easy to pick up on the flare images compared to any other sequence. Just as you can see here, you are able to appreciate the subgaleal component here, minimal subgaleal component, which is not appreciated clearly in all the other sequences that we have seen. You are able to easily appreciate it because of the background suppression of the fat and fluid also. So when you are looking on the flare images, make sure to look at every structure. Any area of bright signal in the parenchyma or outside the parenchyma, particularly in the CSF spaces, you should be able to pick it up. This is your aim when you are looking on the flare images. Now the another sequence that is very important, this is SWI or GRE imaging. So in this sequence, you will be looking for any areas of blooming. Any area of hemorrhage or calcification will give dark signal in these images. And in GRE images, fast flowing vascular structures, for example, arteries will give bright signal. As you can see here, the basilar artery and ICA, they are giving bright signals, whereas the slow flowing structures, the venous structures will give slightly darker color. But this is not synonymous with blooming. Whereas when you see areas of blooming, that is intense dark areas in this sequence, those are the areas which correspond to hemorrhages or calcification. So when you are looking in this particular sequence, either at GRE or SWA, you should be looking at any dark areas, and if they are not continuing with the vascular structures, they are definitely foci of blooming and they are foci of hemorrhages. So this sequence should be used for picking up the hemorrhages as well as calcifications. So these are the basic sequences we have seen. And let's see MR angiogram. So brain is supplied by the anterior as well as posterior circulation. So these two are the ICAs and these two are the vertebral supplying the posterior circulation. And the ICAs will divide into laterally placed MCA and this is the medially placed ACA. So ACA branches will be traversing in the interhemispheric fissure, whereas the MCA branches will be traversing in the lateral cerebellar sulcus, lateral convexity sulcal spaces. So, whereas the posterior half here, this is the PCA. The basilar artery will divide into two PCAs, and the PCA will supply the posteromedial aspect of the cerebral hemisphere. So, when you look at this one, in the entire brain parenchyma, the anterior medial part is supplied by the ACA, posterior medial part is supplied by the PCA, and the remaining lateral portions are supplied by the MCA. So this is important to remember because of the underlying hypoperfusion related injuries or any hypoxic injuries also. So just for example, let's look at these in next case scenarios. So these are actually adult cases only, but I put just for our understanding about the normal vascular territories and areas of involvement. So these are infarcts in typical entire ACA territory. This is infarct in entire MCA territory, and this is infarct in entire PCA territory. As you can see, ACA is supplying the medial portion, PCA is supplying the posteromedial aspect, and the MCA is supplying the lateral portion. Here, you need to understand one important concept called marginal zones or border zones. These are nothing but the areas which are lying in between the two vascular territories. For example, if you consider this area, this is lying in between the ACA and the MCA. These are called as marginal zones. And these marginal zones are slightly different in terms of preterm versus term. For example, if you see here, in the preterm, the cortical branches will have to penetrate deeper and supply the deep white matter as well as the periventricular white matter. So what happens is the periventricular area is farther away from the main vascular supply, and the periventricular area forms the border zone or marginal zone in case of preterm. What happens in term babies is the penetrating arteries from the ventricular ependyma, they start penetrating into the periventricular and deep white matter, they will be able to supply the periventricular areas in a proper manner so that the marginal zones will be moved laterally, that is towards the subcortical and deep white matter. So what are the marginal zones? Marginal zones are the areas which are farther away from the vascular supply. This is very, very important to understand because of the underlying hypoxic injury concepts that we are going to discuss. So in preterm, the marginal zones are lying in the periventricular area, whereas in term, the marginal zones or border zones are lying in the subcortical and deep white matter and not in the periventricular region. Just one point about spectroscopy. Usually it is done with 144 millisecond, and in some select scenarios we'll do with the low TE spectra also. Normally it is acquired in the basal ganglia region. And remember that even in term neonates, normally also there may be some mild elevation of choline, which should not be confused with the pathologist. That is one thing you should remember. So far we have seen about the normal appearances in term baby. Now let's have a look at the preterm. If the preterm baby, the cortical development and white matter development are not yet complete. So because of that, when you look at a extremely preterm babies, for example, this is a 26 weeks delivered baby on day 2 of the life scan was done, where you can see there is no cortical infolding at all. There is smooth cortex is there all around. So that is how the normal cortex will be in preterm babies. Up to at least 28 to 32 weeks of gestation, you will not see much infolding. As the baby advances, as it nears the term, this is a day 6 term baby where you are able to appreciate the normal cortical infoldings and the sylvian fissure, all the fissures properly. So when you are looking at the preterm, hello. Oh, okay, fine. Okay. So in case of freedom, so you'll not be able to see much of abnormalities. Don't label this as abnormal. And coming to the white matter also, the white matter myelination will not progress much even in preterm versus term. So don't comment about white matter on preterm as well as even term babies also looking at the T2 images. And this is a normal variant that we already discussed. For example, if you see foci like this is definitely abnormal, whereas just engorgement of the veins is a normal, whereas having larger areas is definitely abnormal. I think, okay. So what are the common clinical scenarios and role of imaging? I'll just go to directly to the underlying. HIE is the most common one which we appreciate. So for example, there is one more concept that you need to understand, that is selective vulnerability and duration and severity of insult. As we discussed, the blood flow is different in term and preterm. And also the underlying the concept of selective vulnerability is the metabolically active areas in the brain, that is the myelinated areas, the perirolandic gyri and the posterior limbs of internal capsules, these are metabolically active. So they need constant and continuous blood supply. When the insult is mild or moderate, just for example, I'll show you, this is a severe and term. So in these, this is a sequelae, but in this also, you are able to appreciate that there are some gliotic changes which are seen in the precentral gyrus, that is the motor cortex. In the motor cortex on either side, bilaterally symmetrical, which are extending inferiorly along the corona radiata into the posterior limb of internal capsule and the ventrolateral aspects of thalami. So these are the areas which are metabolically active at term. So if any severe insult happens, then these are the areas which will be affected first. Whereas in case of mild to moderate variety in the term only, what happens is because of mild to moderate variety and because of that selective vulnerability, all the other areas will be involved except these areas. As you can see, the motor and sensory cortex are reasonably preserved, whereas all the other cortices are significantly involved. So this is how the selective vulnerability concept happens. So when the insult is mild to moderate, the redistribution of blood flow will happen to the important areas, thereby leaving these unimportant areas to undergo gliosis. So this is what happens in the term. And also what we have seen in the term, the marginal zones are lying in the cortical and subcortical locations. That is why you're not able to see any gliosis in the periventricular white matter. Because it is not severe, you don't see any gliosis in the basal ganglia also. Whereas in case of preterm, what will happen is the severe preterm, it is also similar to the term, except that it may involve areas of vermis and cerebellar parenchyma also. That is, and the brainstem also can be involved in some cases. Again, it is the same concept. Metabolically active areas will get affected first in case of severity, whereas in case of mild to moderate, in preterm, as we discussed, the marginal zones are lying in the periventricular area. So the cortical and subcortical areas are spared, whereas only involvement of the marginal zones is happening. So this is a classical example of preterm hypoxic injury, which is of mild to moderate severity. This is the sequelae in a 10-month-old baby, where we can see the ventricular dilatation because of the adjacent gliosis. There is the rest of the parenchyma is completely normal. The cortical subcortical areas are not involved, only the periventricular areas are involved. Whereas sometimes it is very common to see the combined involvement, where you will see involvement of the central areas as well as the peripheral areas. So it is common to have the wide spectrum of abnormalities, and there may be some atypical presentations also, which is quite common. So these are some of the atypical presentations of HIE, where subcortical and deep white matter can be involved in an asymmetrical fashion. It need not be symmetrical always. That is one thing you should remember. So just apart from Terminal Jones, we'll skip this for now.
Another 1 minute, please.
Okay. Yeah. And I'll not be able to complete, sir. Just I'll finish. So these are the slides, and subdural hemorrhages, how to pick them up. On T2, you can see the hypointense subdural collection. T1, as I mentioned, it will be seen as bright signal. It will show significant blooming. It can cause mass effect. Because of the mass effect, underlying ischemia is also there. And again, flare is the very good sequence to pick up the proper abnormalities. Then, okay. These are all multiple vascular malformations which you should be thinking. This is one case of CVT of left transverse sinus presented with lethargy. So, okay, I think I'll skip to the next component directly maybe. When you're looking at neuro infections, one thing you need to remember is the leptomeningitis component as well as the cortical involvement. So when you're looking at leptomeningitis component, the enhancement in the sulcal spaces, that is the clue for leptomeningitis. So that is how you will be able to diagnose leptomeningitis. These are all multiple cases I thought I'll show, but we'll skip just one last case. So encephalitis, when you are looking, this will be like a atypical presentation. It will not fit into HIE, and the patient will have clinical features of fever and all. So as you can see, there will be widespread involvement of cortex, and on post contrast imaging, you will be able to see significant enhancement in the multiple areas as well as in the sulcal spaces. Cortical as well as sulcal space enhancement along with restricted diffusion is the classical for encephalitis component. So that is how we'll be able to diagnose encephalitis. And this is one more just case of multiple abscesses where you are able to appreciate the restricted diffusion lesions. These are multiple abscesses in a neonate. So metabolic, and these are some just congenital abnormalities where agenesis of facial nerve. This is the fiesta sequence. When you are having a doubt about the facial nerve agenesis, these are the sequences to be done. On the left side, there is only 8th nerve is seen and the 7th nerve is not seen. Similar image. So this is another right skip. And okay, so just to summarize, so it is very important to have a good idea about the normal imaging anatomy, how the normal anatomy looks on different sequences. That is the key. Whenever you see restricted diffusion, first thing is whether it is fitting into any vascular territory or not, or is it in the marginal zones. You should remember the diffusion restriction pattern, that is the hypoxic injury in both the severe and mild to moderate variants. Then the other area, other patterns of diffusion restriction. Flare imaging is not for parenchyma in neonate CSO spaces. Then the location of bleeds and SWA is the sequence to look for the bleeds location. So imaging is always helpful when you have the proper clinical differentials, so that we'll be able to pinpoint towards one or more towards one particular entity, so that further workup can be done. I thank you.
Sure. Thank you, Shivakant. I understand that you can't
Yeah.
finish it in half an hour. I do understand that.
No problem, sir.
Very interesting. Thank you so much. And
Thank you.
could I request Aloka to unmute herself and start her talk on?
Yes, Doctor. Yes. Thank you for the opportunity. I think Dr. Shivakant will have to stop sharing so that I can share my slides. Yeah. Is it visible full screen? Now it's full screen. First of all, thank you, Dr. Satish Ganta, for this opportunity for the workshop, and Dr. Junia for trying her best to get us all together. Um, uh, ROP screening and vision assessment of newborn babies. We know that the advances in neonatal care have been very rapid, and in last 2 decades, but the entire neonatology spectrum has changed in our nation. And with this rises a very important lacunae, that is neonatal eye care. Now, what are the challenges? The challenges that we face are need for ROP services. We know that the cities are still lacking in good ROP services. Vision assessment for neonates is again something which not all ophthalmologists are trained for, leave alone pediatricians. So all the need for everything under one roof. Neonatal care requires multidisciplinary therapies, and it is very much important to train the parents, because they are the ones who are going to get the babies. So parental as well as a doctor's education is the challenge that we face. Now we all know retinopathy of prematurity. These are the Indian criteria that we give for screening: less than 34 weeks gestation, birth weight of less than 2 kgs, or even if a term baby but has had a very stormy neonatal course with presence of RDS, sepsis, multiple blood transfusions. And if you have a very small baby, say less than 28 weeks gestation or birth weight of less than 1200 grams, then the screening should be done at 2 weeks of birth. And for other babies, around third to fourth week would be ideal. Now, I just want to show you, we have a third edition out now. Just before the pandemic, the group met, and the ICROP third edition classification has come out. The few things which have remained the same are this is the stage 1, which is a line. This is stage 2, where the line widens, and as we know, this is the vascularized, and this is the avascular retina, in between which the stage is developing. If you go to C, this is stage 3. This is where you have a big ridge which has formed. It's like a wave coming on the beach, and from this wave you have the detachment starting, that is the traction coming on and pulling onto the retina, causing the stage 4 ROP. There is this is the arteriolar tortuosity and venous dilatation that we see in plus disease, and this sometimes can be there even if you do not have a staging. You can just have a plus disease, and that itself is an alarming factor. Now, these zones are again the same. Zone 1 is 2 radii circumference around the optic disc. Zone 2 is from the nasal ora serrata and a circle around, and all the remaining part is zone 3. So as you would agree, this is the optic disc and this is the macula. So zone 1 is extremely important for our vision, because macula is the one where the nerves are maximally concentrated, and zone 1, any ROP happening is of course much more dangerous than the rest of the zones. Now, so this is how you would like your ophthalmologist to document. This is extremely important, where pictorial representation is done, and in medical legal cases, they fight saying that documentation, if not done pictorially, does not stand true. Now, a new concept which was introduced by the new ICROP classification is this a notch. This is ingress of the avascular area or the ROP line into another zone. So suppose this is all in zone 3, but there is an ingress of this notch into zone 2, then you document it as zone 2 notch ROP, and therefore the severity of this increases. Another classification, they have taken out APROP and now have called it as AROP, where they have understood that in Indian babies, the aggressive ROP no longer is only posterior, only zone 1. It can also advance to the peripheries, and therefore we have got the term aggressive ROP in this. Now, aggressive is here. You see this vascularity, tortuosity, extremely avascular retina. Here, nothing is vascularized, and there are these retinal bleeds. These are the babies who require very urgent ROP care. Of course, retinal detachment is what none of us want to see, but it still does happen. This is a zone 4, I mean stage 4 ROP, where 4A means the macula is still intact, and 4B means the macula is also detached. And this is stage 5, which is a complete funnel ROP. You can see this is an open funnel, this is a closed funnel, and this has made the lens of the eye also whitish, causing complicated cataracts. And both stage 4 and stage 5 only require surgery. Now, how do we classify? Earlier classification was, this is still followed, that is type 1 and type 2 ROP. Threshold ROP is no longer used. Type 1 ROP is, so like I said, anything in zone 1 is dangerous. So zone 1, any stage with plus, zone 1 stage 3 with, even if there is no plus, and zone 2, that is stage 2 and 3 with a plus disease or aggressive posterior or aggressive ROP, is type 1 ROP, and type 1 ROP is the one which requires urgent care. Now, how do we care? The gold standard still is laser photocoagulation, especially in children with zone 2 ROPs. Laser photocoagulation is fantastic. As we know, it is done in the NICU. It does not require general anesthesia, as is said in the Western world. In India, we still do ROP laser under under topical anesthesia. And this is how the retina is going to look after the laser. See all these 3 pictures where how the ROP regresses. Now, indications for ROP, you will find lot of material over this, but again, the same thing reiterates, that is zone 1 ROP requires laser, zone 2 with a plus. So anything with a plus disease requires laser, and you are more concentrated on the zone 1, which requires laser. So 2 important points here, that is this is the type 1 ROP, which requires laser. And if you have a stage 1 or stage 2 in the zone 1, you require 1 to 2 weeks of follow-up. Now, how did the role of Avastin come up? Now, we found a lot of problems with laser, especially those babies who had zone 1 ROP, had severe myopia. It takes time for, so laser, if it is done today, the effect might be seen around 10 days or 2 weeks later. So that again, traction can happen in that medium period, and we were finding that difficulty to laser in plus disease with a very small pupil. Long time duration, as you know, it takes 2 to 3 hours to do a laser, and sometimes even multiple sittings, which is very, very difficult for the baby to tolerate. High myopia risk, and of course everything is burnt off, so there is a vision field loss that happens. Now, to go back to what happens in ROP, what we see is in utero you have a normal vessel growth, whereas in premature baby there is a drop of IGF-1 and drop of VEGF in the early say 1 or 2 weeks, and that is why that is a quiet state of ROP. Nothing happens here. Then suddenly the hungry retina starts wanting more and more oxygen, and then you have a increase of IGF-1 and rapid increase of VEGF, which causes the neovascularization. And so if this VEGF is tackled here, that is how ROP could be reversed. Now, there are a lot of studies again here, where there are 2 major studies, which is the BEAT ROP study and the CARE ROP study. Both of them have studied 2 types of anti-VEGF-A drugs, and both of them are equally effective in ROP. Of course, in our country, Avastin is much more cheaper, readily available, and so we do select that as an option here. There is again this safer protocol which has come out, which just tells you that you should be putting it in the NICU in very, very aseptic conditions, and with topical anesthesia. It is very easy to do this injection in the NICU itself. Now, going to the safety profile, there are lots of papers and there are a lot of studies which are still going on about how safe is this anti-VEGF in the body of this small baby, because as we know, VEGF is important for the neurological development as well as the lung development of the baby. So we still don't have any long-term studies done, and we are awaiting results. The second problem with Avastin in the eye itself is recurrence. Recurrence can happen of ROP even after your Avastin injection, and unfortunately, it can happen in a much more angrier manner. So we have hybrid forms of ROP, sometimes very difficult to laser because the baby is too big. And after the injection of Avastin, almost around 60 weeks later, also you can have a recurrence, and therefore you need to follow these babies for very very long duration, which is difficult with our Indian scenario with children more in towns and villages. So coming back, so as we see here, the prevention is of course better than cure, but not and easier said than done. Preventing preterm delivery is again very important. Having high tech centers in the towns and villages is extremely important. And in the delivery room, gentle resuscitation with avoiding ventilation, using more CPAP, using more of blenders, not giving 100% oxygen is, of course, I think you guys know much better than I do. But this has to be promoted at all PHC levels also. So that is here. That what are we hopeful for? We're hopeful for a lot of data coming in. There is the role of EPO coming in. There's a role of omega-3 fatty acid coming in. So we are looking at promising results here where we can have some shining light into how to save these babies, because as we know, it's not only about oxygen. There are a lot of other factors in place, and we are hoping that the next decade will shine more light on this. Going to kids eye care now, before going to this vulnerable group, let me show you what happens to a normal baby. A normal baby, a newborn, would see around 20 to 30 centimeters away from their eyes, so very close to face is all that they can see. In the first 3 months, they see only black and white. They might have squinting sometimes because the vision is still clearing. In the first 3 months, the color vision clears. Social smile is a very very important visual milestone, because that means the child is emulating the caretakers and therefore smiling back. And so to stimulate, you need these toys and having and face-to-face play with a child. I'll go to the red reflex test, which you can all easily do in your well baby clinics. It should be done in a dark room. This is an direct ophthalmoscope, and this is what you see when you shine the light. This is a good normal red reflex, and any of this is bad. So a black reflex, a white reflex, a yellow reflex, or a turned in reflex all require sending to a pediatric ophthalmologist. If you don't have a direct ophthalmoscope, what you can easily do is get your digital cameras out, not your smartphones but your digital cameras, and click a picture in dark room around 4 meters away from the child, and this is equally good. Again, these show the red reflex. What I do is I do a good vision assessment of the neonate. I do a retinoscopy to find out any glass numbers. I do a squint evaluation for a child anything more than 4 months, a dilated retinal evaluation, of course, ROP, if follow-ups are there, then a dilated evaluation, and ultrasonography if required. So this is very important to check whether the baby is seeing equally with each eye. Many times we all check with both the eyes, but we forget to check with individual eye. And there are other tests. So I have OK and Drum, which is again a downloadable app on your mobile. As this drum moves, that's how, if you see this, the child looks at the drum stripes and you can see that nystagmus coming in, which just shows that the child is able to see the optokinetic drum. And then we have these Teller Acuity cards and Snellen Cardiff cards, which are visual preference cards, which means even if the child doesn't know anything, but he looked at a pattern which says that the vision is good. So then there is a retinoscopy with all these lenses that we need to do, and of course indirect ophthalmoscopy, and so many things that we pick up. This child with bilateral cataracts, so squints, this again an exotropia, this is an esotropia. Both of these require urgent management to prevent amblyopia, and you can have even these infected lacrimal sacs there. High myopia is not uncommon to find even in a small 6 months baby, especially if the baby has had an ROP laser. And unfortunately, you can even pick up retinoblastoma, yellow reflexes. Delayed visual maturation. Now, this group many a times has this DVM, which means the other things are developing well, the child is not seeing. In this, the neurological evaluation will be normal, and the child can have a normal visual behavior by 4 to 6 months. But to not lose time, I usually start them again on vision stimulation exercises. And CVI, cortical visual impairment, is where you have a loss of vision with no problem in the eye. Your eye exam will be absolutely normal. Going back to the visual pathway, what could be happening? Let's see. So light falls onto the eye, goes to the optic nerve, through the optic chiasma to the lateral geniculate body, through the optic radiations, and reaches your occipital cortex, which is the primary visual cortex. Now, the work is not done yet. There is visual processing that happens. From the occipital lobe, you have signals going into the parietal lobe, which help us decide where is this located. So if there is an object, if your body part, hand, leg, you know, where am I spatially oriented by the parietal lobe. And it also goes ventrally into the temporal lobe, which helps you determine what is this. So there is a visual memory center there. So if the mother's face is seen again, the baby will recollect by this ventral visual stream. So causes of CVI, I think we all know: hypoxia, hypoglycemia, intraventricular hemorrhages, encephalitis, trauma, CNS malformations, hydrocephalus or metabolic degenerative encephalopathies. All of these could cause CVI. I think Dr. Shivakant has very beautifully shown the difference between preterm and term baby brains. And what he was talking was the watershed area. And therefore, we classically see periventricular infarcts in these preterm babies compared to term babies, which would have cortical or subcortical, like he showed. So in CVI, many times you may not directly see a problem in the occipital lobe. Of course, occipital cyst is common, and that can cause gross visual problems. But we also see periventricular leukomalacia, cortical atrophy, subcortical atrophy, thinning of the corpus callosum, porencephalic cysts. And as you know, the optic radiations are very close to the periventricular areas. And when this area is having gliosis, we have problems with vision too. Now, again, going back to vision processing disorder. So originally, CVI was known as cortical visual impairment because they thought it has everything to do with occipital cortex, but not anymore. Now they call it as cerebral visual impairment or visual processing disorder. So what do we do if we have a dorsal stream problem? Now, you need to divide what the parent is saying, and understand whether it's a dorsal stream issue or a ventral stream issue. Dorsal stream issue means the child does not spatially get oriented. So these are the children which, if you have lot of clutter, lot of toys lying around, will not be seen at all. You have to give them one toy at a time and try to make a space in such a way that there is only a black curtain or a white background across which this toy is given to the child. So this child takes time in spatially getting oriented to the toy and will start seeing slowly. Whereas if you have a ventral stream problem, now these are the children who do not understand what am I seeing? So they don't know a mother's face from a grandmother's face. So there's no stranger anxiety. They usually try to identify mother by the sound and not by the sight. Now this, of course, we can give something which we known as Heidelberg faces, which means there's a facial cut that we give to the child. There will be eyes drawn on it, nose and mouth drawn on it. Many times I tell the parents to highlight their features. So use a particular perfume, highlight the eyebrows, use dark lipstick, or use a red bandana to attract the child towards this face. Face is a low contrast surface, and child cannot see low contrast and can only see high contrast. So you have to increase the contrast of the face. So how do we come to a diagnosis of CVI? Your eye exam will be normal. Your brain involvement will be there on the MRI. And there are these 10 characteristic features. Gazing at light, the child may prefer a particular color. He'll see only red. He may not see other colors. Prefer motion. You'll see the children looking at fan or looking at a moving toy. Difficulty with visual complexity. So again, the same thing that I told you, the delayed response. The child looks away, then again looks back, then again looks away. So there is a problem with latency here, and you just need patience and giving the toy again and again. Then visual field preference. Many a times these children have inferior field loss or a hemianopia, and therefore that also has to be taken into consideration. And so I'll show you some examples of how I treat these babies. So children who love light, what you can do is you can give, this is a simple x-ray reading machine that you have, screen, digital screen that you have in your clinics. Give it to the parents, ask them to put the toy over that screen so that the child starts seeing across the light. Then if the child has a particular color preference, then have that color cards, that colored shimmery toys. They like this dazzle and shimmer because it's reflecting, right? So that is identified better. And have little movement. So this kind of yo-yo toys are really good for the child. Of course, wait patiently and do stimulation with the toys that the child likes or loves. So it becomes easier again. Again, remove complexities, don't have such clutter around. And this is something that I tell parents to do. You know, in their drawing rooms itself, they can make a kind of a isolated area with black things all around and hang toys in that area. Also highlighting the door, highlighting the carpet, feeding the child from up when you have inferior field defects, having these visual stands for elder children in vision defects, and teaching them to hold the book in 90 degrees, so that if there is a hemianopia this side, it would be covered if the child reads like this. Of course, refraction is again very, very important. Many of these children have accommodation or near issues. And as soon as we give plus numbers, they start identifying the mother's face. So giving glasses is very important. Just to go on, that preterm infants can have all these problems. They can have no visual impairment, or they can have ocular complications like myopia, squint, cortical visual impairment. They can have visual processing disorders like we understood, or they can even have long-term ocular complications like retinal detachments. How do you follow up these infants? Usually, of course, till the ROP, till the eye matures, you need to follow up. If there is no ROP, you do the first follow up at around 3 months of age to keep visual fixation. Then the next follow up would be around 6 to 8 months of age, where you are checking the child for squint. And then every 3 to 4 months once till 2 years of age. And of course, till then, if there is no major issue, then eye follow-up may be not required. But as a pediatric ophthalmologist, I'll tell you there are new things which can crop up for the child. There can be anisometropia which crops up because the child's eye is growing. And I like to follow up all my patients till at least 12 to 13 years of age. It's a team spirit, it's not a one-man show, and I would like to thank my pediatric optometrist and anesthetist for giving a wonderful support, and this is where you can find me. Thank you, Dr. Satish.
We could field them now, or if not, then we could go to the next talk by by Dr. Narayana, and he's going to talk on how do we deal with para and OAE. Okay, Alok, if they have any questions, I'll hand them over to you, Alok. Okay, thank you.
All right, yeah, thank you.
The presentation is like infants hearing screening assessments. As we all know that what hearing is, but as we all know, as a human beings, when we start our hearing, generally our infant starts hearing. I am getting hello. Hello. I think Dr. Ratna, okay.
Yeah, can you mute everybody?
Hello.
Yeah, please go ahead, Narayana. Please go
Sir,
ahead.
okay, sir.
Yeah.
So as a human beings, we know that how when we can able to hear the sounds. It's around 18 weeks of pregnancy, the baby able to begin the hearing the sounds, especially the mother's heartbeat. heartbeat and the stomach rumblings of the mother. By 26 weeks of pregnancy, the baby can able to hear both the sounds of inside and outside body of the mother and be soothed by the sounds of her mother voice also. In general, what happens, the outside noise your baby hear inside the uterus is about half of the volume that we hear. It means that whatever the sounds the mother hears, in that half of the sounds will be heard by the child. And even when the child is in the womb, they are getting startled or cry if they suddenly exposed to big louder noise. Now coming to the incidence, generally we see that in the 1,000 of infants, 1 to 3 kids are getting affected with the hearing loss. And the children and the infants with around 2 to 4 kids are per 100, those who have with that of high risk infants are of having the admitted into NICU hospitals. Children are at high risk for delay in speech and language communication and more globally delayed in cognitive and social development if the detection of hearing gets lost, in the late. Let's see the signs and symptoms of the hearing loss babies. Generally, what happens at the 0 to 4 months of age, newborn doesn't startle at louder sound. Generally, the normal kids who sleeps a deep sleep, if anything gets falling down, suddenly they startle and they cry. But the babies with the hearing loss will not get show that symptoms. As the weeks goes by, doesn't respond to your own voice or mother's voice, such as smiling, cooing, or calming down. By the age of 9 months, 4 to 9 months, baby does not smile when spoken to or not toys that make sound. May not turn head toward the sound that familiar sounds are coming from which side and does not make the sound able to hear the sound that where the sound is coming from. And in the same way, the baby does not able to wave the hand when he even though cannot hear properly in the hand motions. 9 to 15 months, infant still isn't babbling much more, attempt to repeat simple sounds, does not use his voice to get his and others' attention towards him, does not respond to his name call. By the age of 15 to 24 months, almost 2 years, child isn't using many simple words and can't talk and can't point out his body parts. Generally, by this age, the children can able to hear or able to express 2 to 4 words price level. But here they can't express all the sounds and can't name common objects that they use regularly and doesn't listen when with interested to songs or listening music or any stories and all. And most probably these kinds of kids will not able to follow the commands that is required for the daily life. Now generally coming to Joint Committee on Hearing Infant Screening 2019 statements and Universal Newborn Hearing Screening has given a program to find out the hearing loss and give proper intervention solutions. They have programmed one thing like early hearing detection and intervention program. They have hallmarked the things like around 1 month, 3 months, and 6 months. They have divided in this way like the infant screening should be done twice within a month, not more than a month. If the kid has a hearing loss, then they have to go for again rehearing screening, and then later sent to the audiologist for proper diagnostics of audiological evaluations, and if there is any loss, should be done below 3 months of age. By the age of 6 months, if the child is identified or if the infant is identified with the hearing loss, should be properly given hearing aids and should be proper intervention should be done. And there are some protocols and diagnostic things has been given by the JCIH. According to there, the recommended principles for the behind audiology assessments is like cross-check principle and the test battery principle. According to cross-check principle, there is no test is sufficient enough to diagnose hearing loss accurately in infants. And that's the reason test battery approach should be used. In test battery approach, we have included some test materials like taking case history or Heiser's registers or OAE, ABR, immitance audiometry, or behavior observation audiometry, or visual reinforcement audiometry. These are the test materials that 2 protocols that we need to follow for evaluating the infants with the hearing loss. And the same protocols continue, like the first and second screening should be done in the first month. And in India, it would be practical to do the second test at 6th week when infants come for the immunization. If the kid doesn't pass the second screening of the results and cannot obtain in or one or both ears, he should be referred to proper diagnostic, audiologist diagnostic for the evaluation and should do an ABR also. Neonatal intensive care babies, what are the things that we need to take properly? Like, ABR is preferred method for screening in NICU infants. OA is an alternative method, but ABR should be done clearly. And initial screening, as I explained briefly, same the way. And second screening, separate time for the day, then the initial screening. 2 attempts will be conducted each year before referral. One time, here I explain, like, one time putting in ABR or OAE, checking out the ears of the kid, but should go for 2 times, then confirm it, then go for the referral. Not just simply doing one time and referring is not appropriate, signals will commit out. So maximum 2 times should be done, but not more than 2 times. Infants in NICU who stays more than 5 days should definitely recommend for the ABR testing, and ABR will give the proper diagnostic of the outer brain system, and it will useful to find out the sensorineural hearing loss cases. What are the procedures that we use for generally for 0 to 6 months of age? It is very important. 0 to 6 months of age, the general we take an family case history, and first of all we go for an otoscopic examination. As otoscopic examination, we shows the clear cut of auditory canal, ear canal volume is clear or not and all. Then we can use for acoustic emittance. It's a very important test that will show that is there any infections in the ear. The probe tone should be used 1000 hertz frequency only, not more than that. Then in the same way, acoustic emissions and outer brainstem responses, the clicks are from 500 to and 400 hertz only, not more than that, by air conduction and bore conduction. In the same way, as developmental age is very small, the 0 to 6 of infants, so we mostly depend upon the behavioral observation audiometry or visual reinforcement audiometry, depends on child's development. Coming to 6 months to 2 years, same procedure can be done, but here we work on more on the outer brainstem responses. As age increases, outer brainstem responses, we use the clicks or tone burst around 500 to 4 kilohertz by air conduction and bore conduction. Depending on this, we can find it out. But the problem is if the hearing of one of the infant, one ear is normal and other ear is referral, we should go for 2 times for checking all the tests. Then we get a clear idea about the 1 ear is affected or 2 ears are affected with the hearing loss. Now coming to 2 to 5 years, here we use the same family history, otoscopic and impedance will be done same thing. But coming to the condition play audiometry, we'll use around 250 hertz to 8 kilohertz. There we use 500 to 4 only, but here we use 250 kilohertz to 250 hertz to 8000 kilohertz by air conduction. By bone conduction is 250 to 4000 kilohertz only. And speech awareness programs and the test can be done. Autoacoustic emission will be done, and later down that, after all this tests have been done, if really the kid is get affected, then we'll monitor the cochlear function also. Once the child is identified, referred for further evaluations. Before that, how the test will perform and how the results will get, let's see with that one. Little test procedures. OAs are used mostly for the cochlear integrity, that is like cochlear hair cells functioning. When the presence of OAE, when the presence of stimulus to the ear, the response from the cochlear hair cells, we will get it from this.
Narayana, you've got
However,
10 minutes, Narayana.
It's over, sir. So however, may be affected by the fluid in external and internal ear. OAE cannot be able to get out the sensorineural hearing loss in this test, and it will be excluded, may not detect the outer dysfunction, that is outer neural dysfunction. When the OAs are detected, when the OAs are passed, that indicate that outer hair cells are normal. When the OAs are referred, then the outer hair cells got damaged. In the same way, ABR will be done. ABR is a neural signal generator from the 8th cranial lobe and the brainstem. It is most preferably used in the NICU. See, I'll explain this generally. When the signals are sent to the ABR, within 10 milliseconds, we'll get the signals output. That means whenever we are sending the sound, within 10 milliseconds, we'll get it output. And there are some peaks, there are 7 peaks, out of which 5 peaks are considered to be more importantly. In that, especially, fifth peak is very important. Fifth peak is very important to evaluate or to get the thresholds of the hearing. Fifth peak will give us whether the child has hearing loss or not. This is very important. So here you can see this fifth peak is like very important. It gets from inferior colliculus area. This is a where midbrain area where we get most of the results from this area, which is more useful for the threshold to get it out. So AS is also same process. The steady state response, it is more specifically for frequency and screening specificity. Like we do in PTA for the adults, like who can able to give responses at different frequencies. Here also ASs are used for the infants to get specifically at the frequency different levels. And we use mostly 80 hertz and to around the 40 stimulus hertz. And the results that we are getting from the used will be place the electrodes at different place of the mastoid and all. We'll get the results. Based on that, we can able to diagnose whether it is a hearing loss or not. There's one more slide I can explain you detail like there's outer neuropathy spectrum disorders. It can be detected very difficulty to detect, but the thing we have to see is OAS will be normal. So generally, if we think that OAS will be normal, means the child is getting normal hearing and all. But the thing is, when the test done for ABR, there we can say poor wave morphology or sometimes maybe absent. Why specifically I'm specifying this is like, in this outer neuropathy, hearing will be normal. Hearing detection of the in inner ear will be normal. But the problem is the signal sending to the from ear to the brain is difficult, which means the children can able to hear the sound. Infants can be able to hear sounds, but can't make able to, but can't able to understand the things that they hear. So as I said previously, the impedance audiometry has to be done to the children, to the infants, to rule out is there any hearing, any type of infections in the ear canal or middle ear. Coming to in India, India has developed some programs to eradicate this type of losses, hearing loss in the children, especially in 2006. India has launched a national program for the prevention and the control of deafness. As I said previously, it has to be identified by within 6 months and rehabilitation should be started by 9 months of age. Under this program, they have given two part of protocols. One is based on institutional based and one is based on the community based. Institutional based is nothing but when the children are the children who are born in the hospitals should go for an OAE, and those who fail the like OAE and all should go for ABR. That will be done in 1, 3, and 6 months level centers. And coming to community based screening, the screening babies who has not born in hospitals. Sorry. Such screening has carried out using a brief questionnaires and behavior testing. This screening is performed when the babies attend for the immunization at the age of 6 weeks and onwards. A trained health workers like Anganwadi workers or sub-center workers who works nearby in the villages and all, this training has to be given them so that they can do this testing, and they'll send if they feel that this kid has infant has a hearing loss, they'll send to refer by nearby hospitals or nearby centers. There we can go for an OAE and the BERA testing, and then later we can getting up the results, we'll work it on these further intervention issues. Coming to the management, here plays a major role. Once the infant is identified with a hearing loss, as an audiologist will fit a hearing aids, appropriate proper hearing aids, that is BTE hearing aids. Nowadays, I have seen some children or infants are fitted with a BTE or RIC hearing. That is totally wrong. That is not recommended. Only BTE hearing aids are recommended till certain age. Now, after fitting of hearing aids, 3 to 6 months of speech and language stimulation for fitting hearing aids has to be done. After fitting of hearing aid, 3 to 6 months speech and language stimulation should be done. After that, reassessment should be done if the child is not learning language properly. That means this indicates that he is not getting benefited with the hearing aids. Then we have to send it for the kid for cochlear implantation. So these are the interventions like with the hearing aids and all. Now, as I said, explained previously that cochlear implantation is given to those kids who are not getting benefited by using the hearing aids. Those kids who are not able to learn the language accordingly. So for those kids, we will send this cochlear implantation centers. So these are my references. So, and thank you for Neocon, and thank you Satish sir for giving me this opportunity.
Thank you very much, Narayana, for the talk. So, if you have any questions, anybody in the audience, do they have any questions? In fact, there on the sides we have a Bera machine as well as a machine to check for the ROP. Okay, so they could come and display it, or they could come and explain to you if you want it. Okay, now the next one would be very, very interesting. This is Dr. Naveen Jain himself. He's going to speak on early intervention program. Early intervention, what has been done, what is the kind of work that he's been doing for the last 15 to 20 years. And over to you, Dr. Naveen.
Hello, all the co-faculty and delegates at the conference. And honestly, I miss out on this opportunity to be there. It was due to some personal and health reasons that I could not travel to the conference. To be able to ensure that we get a good quality presentation, I have shared my lecture as a video presentation to the conference secretariat. I am there live to answer any questions which will come after the presentation has been made. Early intervention program, yeah, there we are. Children look so beautiful when they're happy and play. Wherever they are in the world, we associate childhood with fun, play, trouble-free life, and the parents enjoying this happy mood of childhood. In those children who do not achieve their milestones, their function like other children should, a usual pathway that we see in our practice is the moment we detect a delay, the child is referred to a pediatric neurologist who may do certain tests, imaging, label a diagnosis, and then refer to a physiotherapist. From there, the child is then like a ball in no man's land. The pediatrician never wants to see this child again, mostly because he does not know what he can do for this unfortunate family. The pediatric neurologist gives them appointments after 3 to 6 months, and the child is destined to be managed by a physiotherapist who lacks guidance of medical care from these teams. Early intervention programs that start in NICU babies immediately after discharge from the hospital, and in other babies where we detect or find a problem in development as soon as it is suspected, aim at eventually getting healthy outcomes for these children. Although we talk of so many advances in science, often these children with disability are a typical example of how the science fails to reach the real needy child. In the next few minutes, we will discuss how we can translate the science of early intervention, firstly to state policies, and then to practices which will help children who need these most. What has changed in the last 1 decade is many of these therapies that have been offered to these children have been scientifically evaluated. There are answers to the questions asked by parents that if I undergo this therapy for 6 months, 1 year, will it help my child? Answers to pediatricians who always doubted that sending a child to these therapies, medical or physiotherapies, occupational therapies, were just engaging parents and that development does not really improve. There is now clear evidence trying to classify which of these therapies may be helpful, which of these may not be done because they do not help and may be even harmful. This is a recent document published in Care of Children with Cerebral Palsy. This is called as a traffic light approach, where all those green circles refer to systematic reviews which support A therapy and must be done. Yellow are those which may be useful, may be tried, and the red therapies are the one which have clearly shown to have no benefit or harm and should not be done. The size of the circles refer to the available literature or published evidence to support. We would first pay attention to what are the domains in which therapies were evaluated. The first one you can see is the motor domain. And then we have early intervention, therapies for tone correction, for established contractures, and alignment issues in bone and joint, therapies to alleviate pain, improve sleep, pulmonary outcomes, improve meal time at home, a very important function, reduce drooling, improve communication, improve cognition in those children who have this problem, improve self-care and functionality of the child, help parents and improve their outcomes. And lastly, evaluation of preventive therapies in the antenatal period and the neonatal period. We'll just go through a few of these and see what works. For example, in improving motor outcomes, you can see that certain things work like constraint induced movement therapy, botulinum toxin, home-based programs, goal-oriented treatment. What may not work, for example, is acupuncture, may or may not work, and strength training. And what possibly are not to be done is some of the classical ones which had been done earlier, like neurodevelopment therapy and sensory integration. They do not help motor outcomes of these children. Similarly, tone may be improved by botulinum toxin, baclofen, and diazepam, but may not be benefited by using things like stretching, reflexology, and established contractures and mobility issues may be benefited by casting with botulinum toxin, hip surveillance and early intervention, repeated casting, but what may not work is things like neurodevelopment therapy and only orthotics. Similarly, drooling may be benefited with botulinum toxin, self-care may be improved, and so many such scientific evidences are there. Parents and pediatricians can have a look at this chart. In prevention, these are something we know. Corticosteroids, magnesium sulfate, hypothermia, cooling, and caffeine are known to work. Now that we know or we have certain evaluations of which therapies are helpful in early intervention, we then need to see what states have done over the last few years to bring about policies which will bind to the pediatrician, to the state, and to guide each of these therapists on what they should be doing. In 2014, RBSK came out with a very elaborate document in establishing what is called as District Early Intervention Centers or DEIC. Clear guidelines were laid on what they would do. They would screen children who are at risk, like NICU babies, use tools to identify early selected health conditions like cerebral palsy, vision problem, hearing problem, make a holistic assessment of the child and not just independent disabilities, investigate as necessary, confirm the diagnosis, plan interventions, referral to specialists, and also do early preventive therapies. In addition, they would take care of psychological aspect of the children as well as the parents. Some of the core things that are available, services that are available at DIC would be medical care, that is essentially pediatrics, dental care, occupational therapy and physiotherapy, audiology and speech therapy, psychological support, cognition correction, vision, and many other important things like nutrition support, social support to the family, guidance on referral, provision of devices like orthotics, special education guidance, certification by government for getting social and financial aids, and support group formations to help these parents. This graph summarizes what they would do: screen infants, monitor the development of at-risk infants, confirm diagnosis, coordinate care with all other centers, act as a resource source, and then eventually refer the child and give them support like nutrition and social support. But having said these two aspects, that is evidence as what works, and having a state policy in place, many of the postgraduates and pediatricians who are in the meeting today would ask, tell me what I should do. What is this early intervention actually? What practices should be done? How do we implement these things? So what are the activities? Some of them are shown in this picture at the DIC centers: vision assessment, development, growth monitoring, speech therapy, physiotherapy, play therapy, and another important aspect is parent support and parent training programs. We're now going to look at what we do in our center to maintain the continuum from what happens in the NICU is good medical care, screening, and development supportive care. This concept of development supportive care cannot get abruptly stopped as the baby gets discharged and the family gets discharged from intensive care. You can see in our pre-discharge checklist, the last 3 items, not least, include continuation of early stimulation at home, making an assessment of parent coping. Are they adjusted well? Are they over concerned about the child's health? Or they need constant guidance to ensure that they will do early intervention programs after they go home? Did the parents attend all the structured programs for discharge planning and follow-up? This will help parents essentially to get back to be parents once again. When they go from NICU, often parents still continue to use hand rubs, keep the baby in a single room without allowing grandparents and siblings to come near for the fear of infection. Don't take the baby out even to the sunlight, and the child never sees the greens and the blues. The child is never tossed into the air. The parents never sing songs. They're afraid to buy new clothes. They don't bring toys to the babies without the pediatrician's guidance. We need to help parents to get out of the stress of NICU and develop what is called adaptive parenting, promote their simple competencies, and help them to remedify whatever disability is getting recognized, and essentially prevent deterioration in function even if you cannot reverse a disability. The first step in helping parents is ensuring easy logistics. It is very stressful for a parent to come to the hospital and have appointments with 4 different specialists in different parts of the hospital and not know where to go. So clear guidance of this kind: what is the date and time of appointment, which room number they have to go, and in another page we include even what costs may be involved in these tests, how long it would take. We need to educate the parents on the need for these care. Otherwise, their compliance is one of the problem most pediatricians cite. So you can see on the page that is there for the parents, the book to take home, the blue book to take home, it is clearly stated that NICU babies will need regular follow-up visits of development. It will help the medical team to determine what interventions and therapies will work. And by sticking to this regular follow-up, we may find out problems early and intervene early. So this kind of education is very important. These programs must continue to focus on function assessment. For example, by 4 months, is the child able to swallow well, develop a early suck swallow coordination without any choking, without having any drooling, and also whether the child is not having any of the persisting primitive reflexes. We need to ensure that these early intervention services are integrated with medical care so that the pediatrician would continue to have focus on both. It's not you focus on early intervention, forget the medical part. Guidance on when to start iron and stop it. And also simple reminders that refraction need to be done, squint needs to be looked at. These might get forgotten on a busy pediatric OPD day. So integrating these intervention services with medical care is important. Now, it is not enough to assess scores like Bailey scale or Denver development, which is only going to help us publish papers. We also need to ensure that whatever assessment is happening, the child is achieving ability of self-care. There are tools called functional independence measure. Do we know that this child will be capable of eating? He can groom himself, bathe himself, dress himself. These are more important measures than a Bailey scale or a Denver development score. As the child gets a little older, he should be able to get involved in social development. And you may use a simple tool like a Vineland social maturity scale. It's not at all complex. It would include simple things like, can the child share and play with other children? Can he interact well with teachers and parents and things like that? The first function, like we showed in the beginning of a child, is to play. Is the child able to participate in play? When he goes to preschool, what does the teacher say? Does he play without hurting other children? Does he attend and does he become a difficult to handle child? And therefore, the preschool teacher is the first person to be able to assess the functional participation of this child in daily life activities. By the age of 3 years and beyond, formal assessment of behavior by things like behavior checklists or pediatric symptom checklists can help us to understand whether babies are going to develop, infants are going to develop problems like behavioral problems like hyperactivity disorder. So it may include simple things like, does the child often fight with children? Does he absent from school? Does he refuse to go to school? And has he trouble with sleeping? Does he worry a lot? And does he take too many risks and hurt himself? So these kind of assessments can help you to know whether behavioral problems are building up or they are just parent or pediatrician perceptions. Very important to understand that the final care of these children is a little more taxing and demanding than taking care of otherwise normal children. We have to find out whether parents and the families are empowered, capable, do they feel comfortable? I feel confident in my ability to help the child grow and develop. I feel my family life is under control. I believe I can solve problems when my child, when they happen. This kind of an evaluation may not be by a formal tool, is continuously important to understand. Otherwise, the child cannot develop normally in a stressed environment. The parental stress can be also assessed, and one such tool is called as modified caregiving scale. My sleep is disturbed, caregiving is inconsistent, I get too tired, I can't do it anymore, and caregiving is restricting my normal life. and it is a physical and emotional strain. I had to make too many life adjustments to be able to provide the same. This attention to the child in the family and in the routine pediatric office practice, he may get a very good occupational therapy, but his hemoglobin and iron, flu vaccination, deworming, and these simple things get missed out. Therefore, these early intervention programs cannot work independently. The focus of all these programs for medical guidance needs to be pediatrician himself, and at home it has to be the parents and not the therapists. All these interventions today have to address parent perceived goals, and parents must be informed how long it will take to reach these goals, how are the therapists planning to do this, what are the intermediate steps they would see, and then measure whether these are happening. For instance, can he button his shirt? Can he take his pants down to go to toilet when he goes to school? These are the ones, rather than trying to say he gets a Griffith motor score of so much. One thing is for sure, which all of you would agree, whether a therapy works or not, a systematic program which starts from discharge from NICU, helping parents to go to the right place, educating them the importance of all these, giving them a feedback from each of the specialists, integrating the pediatrician and parents in the care of the child, providing all the specialists in one place, all these things with a clear timetable when to do what will surely improve compliance and result in improvement in whatever is possible. Most of these programs have failed in one aspect. The child goes to an eye specialist for a refraction check, comes back and does not know exactly what happened, what has to be done. So whenever we do a development assessment, we need to interpret, is it okay or not okay? Suggest if a developmental intervention is to be required. If required, we should refer in time. And then when the child comes back from the specialist, we should get a feedback first hand from the specialist and let the family know what is going to be done. If we all work together, the scientists who are trying to research what intervention works, the state which ensures policies so that children get equity and justice, and the pediatrician and parents together who are the core of the child's medical and social and developmental health work together, many of these children will at least not fall from their best potentials to a quality of life which will hurt both them and the society at large. Early intervention programs can surely be more effective if they have a checklist model, a compliance model. In our unit at KIMS Health, we call this the Blue Book, which starts in the NICU, which I have not touched upon today because we wanted to cover only the early intervention program after discharge, and continues on till the child is into school at 6 years of age. An ideal program would have to continue till adolescence and adulthood and help children who may need the extra guidance all across. Thank you for your attention. I hope we will help a lot more children by developing our own structured programs and be able to guide these families with whatever resources we have and whatever the resources family can afford, can find in the neighborhood so that the child may achieve this potential. Thank you for attention.
Yeah. Hi. Thank you, Dr. Naveen, for that beautiful talk. Dr. Naveen, can you come
Yeah, yeah.
live, please? Can you come live, please? Unshare the screen. Yes,
Hello.
Naveen. Yes, please.
Yeah.
Can you hear me, Naveen?
And thank you, Dr. Satish and the whole team for conducting the whole day's program. Look so beautiful all the delegates who have
when they're happy
participated.
and play.
More than going into the depth of each part of
Wherever they are in
early
the world,
intervention program, which will be
we
touched upon in the
associate
next session, that is
childhood with
the
fun,
actual
play,
therapies
how we
which may be
feel
involved
like,
will be presented in the next
and the
session by the
parents
team.
enjoying
But what is more
this
important
happy
to
mode of
try to
effort.
know that there is a need for a pathway, a flow, a
In
process
those children who do
for
not achieve
all the
their
babies, families, and
milestones, their
doctors to follow
function,
a common pathway
like
so
other
that things
children
could
should,
happen at the right time.
No,
a
So this
usual
exactly, Naveen.
pathway
So,
that
I
we
mean, can
see
you
in our
tell
practice
things
is
practically?
the
Because there
moment
are
we
many
detect
people
a
who want to
delay,
know things
the
as to
child
how
is
to do
referred
them
to a pediatric
practically.
neurologist
Because, you have
who will
lived
do
that,
certain tests,
you have done
imaging,
that, and you've
label a
got beautiful
diagnosis, and then
experience,
refer
working with
to a
children
physiotherapist.
with special needs as well.
From there,
So you have
the child is
vast
then
knowledge, vast experience.
like a ball
So
in
if
no
you could
man's
share
land.
your experience briefly
The
as
pediatrician
to,
never wants to see
first
this
and
child
foremost
again,
thing, is it doable?
mostly because he
And
does
how
not know
and
what
how
he can
nice
do
and
for
how
this
memorable
unfortunate
it is for
family.
you to keep doing what
The
you're doing.
pediatric neurologist gives them appointments after
Satish,
3
instead
to
of
4
going to the
months,
details,
and the
what I
child
would
is
just
left
suggest
handed
is that
to be managed
we
by a
have
physiotherapist
over the years,
who
every time,
lacks
every
guidance
year,
of medical care
tried to improve
on these
upon
terms.
our hard copy book called as the Blue Book, where we
Early
try to
intervention
see
programs
whether this processes that we are
should
doing are
start
helpful to the family.
in
So
liquid
every
babies
year we try
immediately after
to
discharge from the
change
hospital,
a item or a page on the
and
Blue
in
Book
other
so that
babies where we detect
a
or find a
process is
problem in
so smooth
development as
about the
soon as
families
it is
attending the
suspected,
hospital, specialists sharing
aiming
their
at
information.
eventually getting
So each
healthy
hospital may
outcomes for
have to
these
prepare
children.
their own manual. And I would say that in the absence of any printed blue book,
Although we
if your hospital is
talk
not doing, at least
of
give a
so
plain
many
notebook
advances in
to a
science,
family which says a
often
follow-up book and
these
leave three,
children
four
with
pages in the
disability are
beginning
a
of the book
typical
to be able to
example
write the
of
salient
how the
points
science
that
fails
are
to reach
important in the follow-up,
the real
antenatal,
needy child.
running time, and
In the
then
next few
allow
minutes,
each page to be filled
we will
in. At
discuss
least when the baby walks into the
how we
OPD,
can translate
you should
the science
differentiate a baby who
of
had no
early
difficulty
intervention,
versus one who is at risk
firstly
of getting
to
problems.
state
So
policies,
this way, we
and
may
then
get
to
closer attention.
practices which will
Everyone shares
help
their
children
information on
who
this book,
reach
and
milestone.
the child is one single child. He is not broken up
What has
into
changed in the
a
last
child who is
one
having ortho
decade
problem, eye problem,
is many
and
of
each of
these
them not looking at
therapies
the baby as a
that have
whole.
been ordered to offer to these
So
children
I
have
think
been
I can
scientifically
share the copy of
evaluated.
this blue book. People can
They are
adapt it to
answers
their
to the
unit,
questions
change it
asked
the
by
way they wish,
parents
without
that
any
if the
requirement of
undergo
any
this therapy for 6
copyright.
months,
They
one
could change
year,
it as they wish and
will
use it
it
for their
help my
center.
child? Answers to pediatricians who always doubted that sending a child to these therapies, medical or physiotherapies, occupational therapies,
Surely.
were just engaging parents and that development does not really improve. There is now clear evidence trying to classify which of these therapies may be helpful, which of these may not be done because they do not help and maybe even harm. This is a recent document published in Care of Children with Cerebral Palsy. This is
Am I
called as a
audible?
traffic
Am
light
I audible?
approach, where all those
This is fine. Audible?
green circles refer to systematic reviews which support a therapy and must be done. Yellow are those which may be useful, may be tried, and the red therapies are the one which have
Yes. I think I'm audible. So I'll describe or I'll just touch upon a pain a little to the context of this workshop. So what actually this what actually the pain actually like how is the pain is going to affect the baby's neurodevelopment is what we want to look into. So hello, audible now? Is it audible now? Yes. Okay. So what I try to look into is how is the pain? We call it as the fifth vital also presently. So how is the pain which is going to affect the neurodevelopment of these babies? So I go into the slides. So we know neonatal pain, it's not so late. Actually, the cortical pain perception develops as early as 24 weeks of gestation, and the function the pain nociceptive nerve endings will be functional by around 30 weeks of gestation. So at that early age of gestation, the pain is accountable. Preterm neonates have 30 to 50% lower threshold for pain than adults or older children, and around 15 procedures happens per day in a neonate who is in a NICU. So what are the signs these babies show us? So basically they show us like most of the babies will be fretful, they'll be unsettled, they have some facial expressions, fistings, playing, vitals will be up and down little bit, some walk to requirement for no real reason actually. So this may be some signs they'll be given, but we can objectively quantify them with pain scores like premature infant patient profile, neonatal infant patient scale, cries, etc. So next slide. So what actually does this pain affect on the neurodevelopment? So it is not, it has been studied that it does have an impairment in cognitive development, altered neurocognitive processing, decreased cortical thickness, and dysregulation of hypothalamic pituitary axis, adrenal axis. So this is one vital which we really don't look into in NICUs much actually. So even though it has been described as one of the core concept of DSC, very less ICUs actually look into pain and systematically, objectively score the pain and do needed things for the pain. So babies, another long-term outcomes consequences.
Hello, hello,
Those babies are exposed to
hello,
multiple painful stimulus in newborn period exhibit more
hello.
intense pain in
Yes.
the later life. For example, a baby is being
Check.
monitored for hypoglycemia, requiring multiple GRBO sticks. So these babies tend to be crying more in the later infancy or this one for any small painful stimulus. So how to manage this pain? Why managing is important? Because we know this have an implication on neurodevelopment. So first of all, first and most important thing is being aware that the pain and stress is abound in our NICU, and respect it as the fifth vital sign. Plain empathy and common sense will do the rest. As I was already mentioning, it has been considered as the one of the 5 core components of DSC. So coming to the management, first step is know the signs of pain and stress, quantify them, and alert your team of doctors. So what we need to do is like monitoring any other vital, the sisters should monitor pain also, score pain also at the beginning and end of each shift, document the pain score along with other vitals, and inform the team of doctors who will offer analysis as per unit protocol. So we have a lot of non-pharmacological pain management measures and like positioning, positive touch, breastfeeding, sucrose, etc. Likewise also we have a lot of things for pharmacological things which is not scope of this. So what I want to emphasize on this short presentation is pain is an entity which we have to look into, and it has to be, we have to be aware that pain is a thing which has to be looked into and managed accordingly.
Go to the
Thank you.
sit on the thing. Yeah. So the next part, we'll have a panel discussion, but let's have it more like a dialogue. Okay. So the panelists will be, sorry, the panelists will be here, and let's have it more as a dialogue. Okay. So we could discuss one with the panelists, the therapists as well, as to what are the practical things. So the questions I'll ask, but that's just to initiate the discussion. But it will be nice if you could get involved in the discussion. Is that okay? Come over, Ankush.
The parent support group is a very important requirement to be able to take the special care forward in each of these areas. Although most of the parent support groups are currently only for children with existing disabilities like Down syndrome or with some unusual disorders uh, storage disorders and things like that. Within our own hospital, for example, we have WhatsApp groups for NICU discharged babies. We have WhatsApp groups for children with learning problems. So these kind of groups have a great advantage because we as doctors, nurses and specialists see the problems differently than what parents require. And many of the solutions are actually better made by parents themselves at home because they are facing the problem every day and they need to answer this.
Yeah.
If you put parent support group on Google, sadly you will find a lot of parent support groups from other countries, but very, very few of them from India.
Very, very true. Very true. Hardly any support groups from our country. Yeah.
And appeal to all of the delegates is with this WhatsApp and IT technology and Zoom technology becoming so much highly available now, accepted now, at least make a WhatsApp group of all the babies who get discharged from your ICU who had something more special than usual.
Yeah.
In
I
that
mean, what do
way,
you all think? You know, because we see so many
solution many of the
NICU
parents will
babies
benefit.
going out. So these babies, how about, you know, every time a baby goes out, how about adding them into that group so that, you know, they can learn from one another what's the, you know, outcomes are going to be, what they can expect down the future, isn't it, Dr. Naveen? Yeah. Dr. Naveen, yeah. The other thing I would want to ask you is, you know, is there any financial or state assistance to these kind of children with special needs?
Sorry, Satish, the audio is somehow very limited, but I think I partly heard the question because we had shared the questions before. That is
Yeah.
about state assistance, is what I think you
Yes,
asked.
yes, please. Yes, please. State assistance or financial assistance to
Yes,
children with special needs.
there is an improving funding and care for children with difficulties. Yesterday, I had met a child who had required an insulin pump, which cost 5 lakh rupees otherwise and was given completely free by government of Kerala. Similarly, orthotics, our own hospital is giving limbs and other things completely free of cost. So there are a lot of these resources available. RBSK has made huge funding available through the district intervention centers, DEICs. And one must definitely refer these children, get them appropriately certified. But even still, the kind of funding, emotional and social support is very far from what is happening in many of the developed countries, like in Australia.
Yeah.
So we must be aware of these processes. Do refer these children to DEIC.
Yeah.
There, if they certify and assess the disability, then they can access help from the state.
Yeah. Actually, the DEICs they are heavily funded, and there is a big program where there's a lot of money which comes into the DEICs, but unfortunately, the money which has been allocated, it's not completely used. So lack of awareness and many other problems as well. Now, Dr. Nihas, uh, how early can autism be identified? And could you please tell us some early clues that you could see, please?
Sir, actually, mostly the autism has been diagnosed mostly after 2 years of age. But the thing is, if actually looked into, we can get early signs about autism or chance of high-risk babies at least maybe after 6 months of age. So most of the studies which has been seen is shown that those been studied in different groups who developed autism later, till 6 months the development seems to be okay. Maybe after maybe 1 year or up to after 2 years only the actual events has come out.
Yes, yes. I mean, anybody of you all have had any other experiences with children? You know, I've seen child maybe at 1.5 or 1 year, 9 months, because my psychologists, they keep saying, yes, sir, we can't label them as autism at, you know, 2 years of age. So what they write is this child has got a high risk for autism or a moderate risk for autism. Because by definition, correct me if I'm wrong, Ketura, I don't think you can label somebody as autistic below 3 years, right?
Yeah, so we are not supposed to diagnose anyone below the age of 3. We can just talk about risks like we use MCHAT to
Yes.
obtain the risk factor.
Yes, yeah. So that's the thing. Any other views or experiences from the audience? Yes. Priyanka, Dr. Priyanka. What are the follow-up rates of high-risk neonates? You know, if you see across the world, pretty much every single child is followed up, and you have something called community nurses, where the nurses go to the community and actually see the children, because all of them can't come. And it's not like a joint family system like we have here. So there it's different. So here, do we have any rates, or do we have any?
So the recent studies that have gone through, the rates of the high-risk newborns, the follow-up has increased significantly to around 59% to 60-62%. But this is at around 1 year of age or 36 months of age.
Yes.
Ideally, it has to be followed up till 8 years of age, but there are no studies till 8 years of age. But this has increased significantly over the last 1 decade, where it was around 20 to 28%. And I think the reason for increased follow-up is increase in the educational level in the parents, and when they're closer to the facility provided, and the nurses go to the houses, they give reminder calls to the parents for the follow-ups.
Yes, please.
So now it has increased.
Increased it. But I think something more important here also, in addition to what she said, I think extremely important is even the legal perspectives as well. So, and the discharge summaries, it's extremely important that we write up, what is the next follow-up for the eye? When is the next follow-up for the ear? Let us say you forgot. At least you have it on your discharge mode. So every single neonate who's going home, if they have that printed, at least you're going to save your backside. That's very, very important, okay? So that's important. Dr. Anil, any special immunization requirements, and if you can sort of highlight on what's cocoon vaccination?
Basically, cocoon vaccination is the vaccination of family members or immediate contact of a patient when patient might develop the disease but cannot be immunized because of either immunocompromised or there is no indication like underage. So as we know, preterm or term neonate, they cannot be immunized for like pertussis, but they can get pertussis. So if we immunize the family members and immediate contact like pertussis or other vaccines, so they can get protection from the infection. This is more true in current scenario like COVID. So because we know it has not been permitted in neonatal age group and children's.
Yeah.
So if family members are immunized, so the childs are getting protection.
Yeah. Okay, great. Now, in your personal experience as well, when do you usually immunize them? Do you wait for 1.8 kilos, 2 kilos, or corrected gestation of 37, 40 weeks? Any personal experiences? 1.8 kilos? Around 2 kilos? 1.8 to 2 kilos, and maybe roughly once their corrected gestation is about 37 to 40 weeks, right? Is that okay?
As per IAP or that AAP recommendation, the vaccine should be as per chronological age as soon as they are medically stable. We should not delay the vaccination for that weight. There is no criteria except hepatitis B. Usually wait for 1.8 to 2 kg.
Yeah. Yes, actually that's what he is trying to say. Better preferably vaccinate them before they go out of the NICU. That's the most ideal thing. So if you heard what he just said, it could not be, it might not be 37 weeks, it might not be 36 weeks. Even at that 35 weeks, if the child is clinically stable, doing well, reached around 1.8 different units, either maybe 2 kilos or 1.8 kilos, it might not be, they should reach 34 or 35 weeks gestation. See, what happens in our country is very different to what happens abroad. What happens abroad, at least in the place where I worked in Sydney, child can't be discharged before corrected gestation of 37. Now, in our country we know we have to send them at 34 sometimes, even 33 sometimes if they're clinically stable. So but at the same time we need to, the most important thing what I tell my students is, write it up on your discharge summary. Until corrected gestation of 38 to 40 weeks, you will have blah, 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 problems. So at least then you can say, listen, I have already written it up here. You didn't see, that's your problem. Again, most important, one of my friend, I had him, he told about ROP check. He mentioned that, but he forgot to write it in the discharge summary and the notes. Okay, it was a 32, 33 weeker. Both the babies, for some reason, had ROP, and he had to pay 8 lakhs. I'm not joking. So be very, very clear, especially in the discharge summary. You have to have it written up very clearly. Ankush, when to consider and which imaging and medications? Would you really consider imaging?
In preterm, told in my talk also. So now they are doing MRI at 40 weeks of gestation when they reach the term age, at which at this stage we can clearly see the white matter changes, the gray matter the cortical gray matter changes, and the cerebellar and the deep gray matter changes. Now actually some studies they are being published. They are becoming more confident, and they are doing MRIs even in the preterm age also. Okay, more and more literature is being published.
Anything about diffusion weighted imaging?
Yes, diffusion weighted images you do when in children who suffer from perinatal asphyxia, or even who suffer from neonatal hypoglycemic brain injury. Then imaging has to be done within the first 5 days of the insult. Then you can see the changes in the diffusion weighted images in the parieto-occipital white matter injury will be there. Parieto-occipital diffusion restriction will be there in children who suffer from birth asphyxia or hypoglycemic brain injury.
Yeah.
Especially term injury, I mean the changes would be more seen in the basal ganglia. That would be more can be more clearly seen in the T1 weighted images actually. Later on at 6 months, I would say, they become more prominent in the T2 weighted images. But neonatal age, T1 weighted images, they become more hyper intense. It is very difficult to distinguish. Usually the plic is myelinated, so that is also hyper intense. So you have it becomes you have to see the basal ganglia area, the thalamus and the posterior putamen, that becomes hyper intense on T1.
Yeah, thank you, Dr. Ankush. Now, Nitish, if you are online,
so drugs.
Nitish.
Yeah, I can hear you, Satish.
Nitish, you are online, right? So, see, parents go through a lot. And they're often stuck in the ICU and the hospital along with their babies. Do you think they have a psychological trauma, and do you think it would benefit them having some sort of psychological assistance? Okay, and then a second question after that is the medical needs. Kids who are being followed up, some of them go home on home oxygen, some of them we do send them on tracheostomy. So could you just evaluate your points on these two questions, please?
Yeah, so as much as I can understand the question, the first question is, would parents benefit by psychological assistance? Of course, yes. I guess we've actually, developmental pediatrics is more to do with the emotions. And I feel the people who suffer most are the parents, because while the child is in NICU or a high-risk child, obviously every minute the morbidity is causing a great degree of anxiety. Even if we talk about express breast milk, when they're anxious, they're not able to make that milk. And imagine the same child, we are actually closely following up to at least 3 years post discharge. So there is a great degree of anxiety. That is the first and foremost problem, and then depression. So a fair degree of psychological support will help for overall development of not just the family but the child as well. If you should see at the role of social worker in the Western world, that is what they do. I mean, they are providing the ongoing psychological support. And if, let's say, when the child is brought to us as well at the child development clinic, and if we, instead of saying your child is not able to reach this milestone, we can probably put it, well, he's trying to reach this milestone, and probably this is the way forward to make him reach it in a better way. So that kind of simple words will give a lot of positive impact to the maternal psychology. And if the mother is strong psychologically, she feels encouraged, then obviously that gets translated to better therapy, because these kids, obviously some of them will need ongoing therapy for prolonged periods of time. This is just a simple thing about positive parenting. And then the second question is about special needs, home oxygen, tracheostomy and gastrostomy. Now, what I feel is, to a major degree, our country is still not very well equipped to handle these pictures at home. But yet, I mean, with the kind of pressures of the economy, pressures of the family, I mean, we do have to send some of these kids home on oxygen. Yes, I think there is a role for both private and public sector to be able to kind of provide oxygen at home. Then from our perspective, from a medical team's perspective, clarity of instructions, how much oxygen to give. We used to, in the Western world, we used to kind of get it checked every week instead of doing it every day. Like in NICU, we are checking oxygen saturations and then trying to wean down the oxygen. In the community, that is not practical. So we used to do it weekly. We need to get that kind of a regulatory program in India, and some stage we have to do it. Tracheostomy, gastrostomy, these are specialist things in the Western worlds, or even in India for that matter. In the adult world, there are stoma specialists, for example. There are gastrostomy specialists. These are nurses who have worked in the gastro teams, and they are able to help those patients at home, monitor them as well. But in pediatrics, somehow that kind of concept is still lacking. So something which we could encourage with the speech therapists being involved to a certain extent, the OTs being involved to a certain extent, to be able to kind of advise on care of these stomas, tracheostomies, and the role of aseptic precautions and those things. I think there's a fair degree of learning and teaching that needs to happen in India for these things. That's how I would think of it, Satish.
Yeah. Thank you, Nitesh. That was very nicely answered. Dr. Naveen, if you're still online, Dr. Naveen. Dr. Naveen, are you still there online? Dr. Naveen, Naveen Jain, are you still there online? Yeah, it's okay. Ask him to unmute. Okay.
We request Dr. Naveen to kindly unmute.
Yeah, now I can hear you. Previously, it was difficult to hear. Please tell me.
Yeah, Naveen, I've got quite important practical questions for you, Naveen.
Ah.
See, we see a lot of babies in the NICU, and we know they are high risk. How early do you actually involve or tell the parents that family involvement is important? How early do you say? And then do you prime them up right from the beginning? Because we all know that parents' involvement is very, very important in these high risk things, right? So, how early do you involve them in your NICU?
Ah.
Can you unmute yourself, Naveen? Please unmute yourself. We can't hear you.
Just 1 second. I'll just be back. 1 second. Just 1 second. Huh?
Yeah. Who said 1 second?
Sorry
Yeah.
for staying on hold. But this is the most important part, I guess, which should be take-home message from our end, is something called early parent participation. In our unit, as soon as the preterm baby comes to the NICU, we have the father coming in with the baby right away, and he is talked to about what is happening to the baby. He has to touch the baby even if it's a 26-25 weeker as soon as stabilization is over. The mother gets the breast pump within 1 hour of the baby being born. And I'm not going to details of breast milk expression and things like that, but within 24 to 48 hours, the mother is brought in a wheelchair to the NICU. And even if the baby is intubated, she gives the tube feeds by herself. She touches the baby, talks to the baby from day one. Although I'm trying to project this as a program, it is only very common sense to understand that a baby should be taken care of by the parents. It is not a development supportive care nurse who has to understand whether the baby is ready for care or not. It is us. And therefore, we have a checklist program which says from the first day onwards what the nurse, doctor, and the parents need to know about being involved in the care of the baby from first day. Besides which, we have a modular program for educating the parents step by step on what is going to be happening besides intensive care. When would ROP screening happen and why? When would hearing screen happen and why? How long development follow would be required? Development supportive care is mediated by parents themselves, and so on. So the appeal to all the people who are in the group is, if you are keeping parents out of the unit even for the first day of life onwards, we are starting the process of creating disability from word go. So please involve the parents from the beginning. That's what I have to share.
Yeah. Thank you
Sir,
so much.
sir, I would like to make a comment as well.
Yeah.
The concept about parent or family-centric care, I mean, wherein individual rooms for that matter, with including ventilator facility, with the parent being in there, allowed to be in there round the clock, and a nurse. So even for ventilated child, and again, that is kind of trying to promote the parent-centric care right from day one for, as sir was saying, for even 24, 25 acres as well. So that is something which is happening a fair bit now, and it's only going to get more and more happening.
Yeah, very true. I mean, family-centered care is what's happening now. I mean, it has its share of good things and bad things as well. So depending on the unit policy, I think we need to take a call on that as well. Now, the other thing is, Dr. Naveen, can you unmute yourself again, Naveen? See, Dr. Naveen, yeah, thank you so much. Thank you. Dr. Naveen, I mean, you are a teacher. You are a teacher for many teachers. I know that, Dr. Naveen. So, I mean, this is important for everybody in a practical point of view. So, where can we train, pediatricians, neonatologists, therapists as well, or nurses, specifically for neonates and infants with special needs? I know you do it. I know you do it in your place. But what are the centers where, somebody is interested in taking up, early intervention, being a pediatrician, it's for us, early intervention, or for that matter, wanting to be a developmental pediatrician down the line, what would you advise, or what would you say is the right course? Having done that for such a long time, could you pass on the advice to the younger generation?
Thank you, Dr. Satish. The IAP now has a 2-year for developmental pediatrics, and that is now about 3 or 4 months. Kerala University had a program called PG Diploma in Developmental Neurology, which was initiated by they also have a program called program for special educators, which takes in basic graduates. They don't even have to be health graduates, and train them in early assessment and training. And currently, Dr. MKC is into yet another level of program called as training nurses to become developmental therapists. The bottom line, Satish said, whether it is a doctor or nurse, once you decide to take up the subject and you have one person focused on the subject, automatically the program will take a different shape in a minute. We need to recognize 2 things at least. One is, if you have intensive care unit, do you want this baby to go to hospital and that hospital telling that
Can all the other speakers, can you please be on mute except Dr. Naveen? Can all the other speakers be on mute except Dr. Naveen?
So one incentive for a follow-up program would be that you don't want your NICU babies to go to some other center and they interpret your care in a different way. So this is really a practical point. Second one is that the follow-up program teaches us backward what we have done, and we learn that what we did previously was good or bad. That is how the world learned that steroids postnatally may not be good. That's how we learn caffeine is good. So these are bigger picture, but we learn by each case. We have had brain abscesses, completely bad looking brain abscesses who do so well in follow-up. Babies with 35 bilirubin done exchange and coming well. So you will become more confident in trying to offer care and take care of babies. So please have follow-up of your babies, document them. We don't have any big infrastructure. We have just an Excel sheet and we keep entering. And these same development therapists who are basically BSc home science girls have made this follow program to this level. It is not us. It is these simple BSc home science girls who were trained by MKC Sir's unit who have reached this level. So there are formal programs under IAP, under Kerala University, and now under the NIMS spectrum where Dr. MKC Nair is there. And I'm sure there are other programs across the country which are now starting to train. Dr. Amitav Sen at Paras Hospital also is involved in a lot of training program in development supportive care.
Thank you. Thank you so much. Thank you so much. Thank you. Yeah. The next thing, I'll move on to the therapists and get some practical insights from what the therapists have to say. Dr. Soumya, how early do you think can we have start the physiotherapy and neonates, obviously, especially if we find them to have some kind of an abnormal muscle tone? Do you think you should wait for them to get discharged, or do you think you could do something in the NICU?
Oh, absolutely not. I mean, we can start as early as day one. But first thing first, we need to see for that when we are doing for any kind of optimizing the tone, whether it is a high muscle tone or low muscle tone, we should not give any distress to the neonate, giving any other sensory input. I mean, which will create distress to hamper their physiological process. So that should come first in first. But then we can start the therapy programs like the passive range of motions, mostly what is done for hypertone, and the gentle massages, kinesthetic massages for improving the muscle tone with a low tone neonates. That can be done from the day one itself. We don't have to wait for the discharge.
So you want to intervene early?
Yes.
Early
Absolutely,
identification and early intervention, right?
Correct.
Yeah. So the other thing, Soumya, is we all heard about neonatal splinting, especially children with some, again, motor movement problems and other things. Would you insist, or would you really plan to do something like neonatal splinting in the NICU early on?
Yes, there are the researches suggest like when there are tone abnormality that induces to a abnormal posture of the limbs, and mostly when there is a abnormal posture of the limbs, that gradually increases the tightness of those muscles. So to prevent the further tightness and to correct this, so the splinting is usually used mostly the soft material, or either it can go for a low temperature thermoplastic which can be remolded again and again once the correction happens gradually. But it can be done for the neonates through.
So is there evidence to say that, by doing it early, you could prevent contractures?
Yes, the first
and maybe deformities
the
as well?
basic principle of the splinting is prevention more than the correction. So here
Yes.
it is more of a preventive method we are using rather than correcting. So we are not trying to go for a not correcting here that something is been more tight and we are trying to correct. So we are trying to prevent it majorly
Yes.
by doing.
So I think what's important here is the involvement of both occupational therapists as well as physiotherapists early on, and trying to convince the parents that this is what is needed. That is extremely important, right?
Exactly, sir.
Great, great. Okay, next is Ketura. See, so in the NICU, right in the NICU, okay, we do observe that when the babies are slowly getting to term, we watch them, and we watch them for eye contact and things like that. Uh, do you really emphasize on eye contact and their future development? That is one thing. And then how does it help in development of language from a psychological point of view?
Yeah, so eye contact is one of the major milestones that the baby achieves much more than any of the things. That's the first one it reaches.
okay.
Eye contact is the way they start
not there.
assimilating things around in their world and start making concepts in their brain at early point of stage. And eye contact with parents stimulates a lot of love and support. So the hormones that are associated with the feeling of warmth and the cuddles and the happiness that they share with the parents also start with eye contact, because they start recognizing the familiar shape and the people and their voice and so on. So eye contact is one of the most important things that you have to kind of start engaging the child in. There are a lot of methods to do it as well if the child is not able to give you eye contact. And there are a lot of studies that show that children who are engaging in eye contact early on, their vocabulary, the size of the vocabulary at the age of 2 is much more in these children than children who are not engaging in that many eye contact activities. So somehow eye contact kind of promotes and facilitates language development. It starts with non-verbal communication and moves on to a verbal communication method. So yeah.
Thank you, thank you. Dr. Nihas, see, we spoke so much about early intervention, and we heard that it's good, isn't it? So how early, how early is early, and what's the most easiest and effective of them?
So early intervention has to be actually we used to tell like soon after the NICU, but the development is supportive care has to be started inside the NICU also.
Yes.
And once the baby
And
is
maybe
stable,
when the baby is in the womb
baby is in
itself,
the womb
isn't it?
itself.
Yeah, yeah.
So once the baby is stable, even the therapist also can come in and help us doing some help to the babies also. And there is nothing like a single procedure which can help the baby like that. Is a multidisciplinary team effort which has to be carried out, and it includes all the therapists and along with the doctor or the pediatrician or the neonatologist being the center point of attention.
Can you ask them to unmute whoever is not on? Yeah. Dr. Soumya, the next question is for you. You are an occupational therapist by profession. So how can we promote sensory motor, neurobehavioral development, and what's the importance? And what are the various things that we can prevent by using this?
Yeah, so basically what are the approaches we use? So everything is the sensory motor is a very vast term when we see and NICU, NICU, like what my colleague suggested, Ms. Ketura, that is it's not only promoting the simple eye contact, is not only promoting the language development, it also promotes more of a visual coordination, which gradually improves the eye-hand coordination as well. So when we are trying to do like if the simple nesting as well when we consider, so that not only giving the tactile input, it also gives a proprioceptive input to the child and improves the posture. So when we go for a visual stimulation, that also improves the visual motor coordination of the child to fix towards one object and differently converge towards the object and diverge from the object as well. So it is whatever it is, we can say that it is more of a overlapping whatever the activities or whatever the modalities we do, but it is more of a multisensory input what it gives. But then that promotes the next step of development, where like tactile it is associated with proprioception. When it is coming to visual, it also somewhere related to maintaining the posture and balance when he tries to coordinate the head and trunk. So that's how the vestibular system matures and the improve of the posture happens gradually. So definitely sensory motor approach is, I mean that's what we do normally in the NICU, but it is a type of way looking into the things we do mostly.
Sure. Yeah, the next thing, Dr. Anil, in the NICU, especially children who've had a perinatal insult, how would you actually identify children who have suck swallow difficulties? What's the earliest or the easiest sign that you can pick up and then you can intervene early? Any children, especially with a history of some perinatal insult, we often see them that they're not able to suck. But what are the earliest things, and what is it that we need to do down the line?
Earliest clue what we get, like if they have poor suck swallow, like there will a lot of drooling will be there.
Yes,
they're not
yes.
going to swallow. You can see that some drooling is coming out,
Yeah.
and they have constant tongue thrusting will be there. Whenever try to put pacifier, they try to they won't have that sucking movement. They will have a biting kind of movement.
Yeah.
So these are the like early thing we can have. Normally when we put pacifier, they try to suck it, but
Yeah.
if you have sucking swallowing difficulty, they try to bite it. They won't any proper sucking movement. And to intervene early, we need to start the oromotor stimulation for these kind of babies. One thing is like using pacifier, you have some different special kind of oromotor stimulation technique. Like you can use some electrical brush which helps them to have good oromotor skills. Like that.
Yes. Thank you, Anil, for that. Because that's a big problem. Dr. Naveen, you're on line. Can you please unmute yourself, Dr. Naveen?
Yeah, please.
Dr. Naveen, I mean, this is something which is very fascinating, very interesting. See, I mean, we have these children coming out of the NICU who Dr. Anil has just spoken, where earlier on they have, trouble holding their secretions. They are not even able to swallow them. And they have drooling and they have difficulties. And obviously, instead of swallowing, they have suck swallow incoordination as well as biting onto the palada rather than actually drinking. And sometimes they end up having an aspiration as well. So in your unit, Naveen, right from the day one, what are the precautions you take to prevent that? And how early do you have the therapists, the speech and language pathologists or the occupational therapists? How do you deal with them? This is a very, very fascinating thing, and we would like to learn from you.
For the last 3 years, we have an ongoing program of trying to improve feed tolerance of these babies and transition to oral feeding. And two important practical points that are there in trying to do this early is, one is the milk or colostrum both need to be given in a few drops to the mouth of the baby every time you are going to plan an orogastric feeding.
Yeah, very,
So
very
these
nice.
2 or 3 drops are not going to cause the baby to choke. He is swallowing his saliva also. So the baby continues to have a feeding experience. And there are more reasons than just mechanical swallowing. We have shown that stem cells also go through from this milk as well as from the colostrum to improve the baby's brain outcome also. So if you bypass the mouth by putting in OG2 for 2 months and then ask the baby to start feeding, this will not happen. Most of the units are already doing non-nutritive sucking on the breast. It is a good practice. So as soon as the baby is stable from a respiratory point of view, the baby should be put to the mother's breast to just try and suck. Encourage the mother by telling her breastfeeding will not happen. She empties the breast and tries to suck. And by this time, our speech pathologist is also involved. There is a program called POME. You can see on the one of the programs. There are many of such kind programs. That is preterm infant oromotor stimulation. It is just a very simple program where you use a gloved finger and you can stimulate the mouth and the tongue to help the baby to develop rhythmic movements. So our speech pathologist or occupational therapist, both of them in fact are involved from something like the 7th or 8th day of life in a very small baby when he is medically stable. And they are there till the end of this program. I'm not sure completed 1.5 years of this clinical trial where we are having this whole package, what we call as the nutritional care bundle, where from the beginning you would have a few drops of milk going to the baby's mouth before OG feeding. You would have non-nutritive sucking, KMC, and also more importantly, the speech pathologist involved. If you look at the American Academy program, right from 2004, they have now listed both speech pathologists as well as occupational therapists as a part of the NICU team. And they should be there in all NICUs all from the beginning itself.
Thank you. Thank you so much, Dr. Naveen. That was fantastic, because that is some area or many people actually don't know what needs to be done. And many referrals, we do have them because they end up aspiration and choking, and because those things are not managed well. So that was a beautiful thing. Dr. Priyanka, Dr. Priyanka, who should coordinate the follow-up services, and when should they be doing it? Because, as you see, you have about 6, 7 experts on the panel. You have many of them online as well. So, it's a big team, right? So who do you think should actually coordinate? And then what are the kinds of, therapies that you need to be doing or involving?
To decide that, actually it's better to first stratify the newborn according to the risk, whether it's a high risk baby or a moderate risk or a mild risk. A high risk baby would be who is born less than 28 weeks of gestation, less than 1 kg, with severe perinatal asphyxia, with meningitis and bilirubin encephalopathy, and the list goes on. If it's the baby is falling into mild category, then the pediatrician alone may be enough for follow-up. If it's a moderate category, then along with the pediatrician, you will need a neonatologist, a developmental pediatrician, and also a ophthalmologist, a physiotherapist, a dietitian, social worker, and occupational therapist. And if it's falling in the severe category, then along with the team that is required for that, for the neonate in the moderate risk, you also require a pediatric neurologist, pediatric surgeon, endocrinologist, geneticist. And the follow-up actually should start right from the NICU and should go on till ideally 8 years of age. And for example, ophthalmologist, in case of severe prematurity, then at 34 weeks of gestation, 44 weeks of gestation, and 9 months of visual checkup. And the list goes on, ideally at 1 month, 3 months, 6 months, 9 months, 18 months, and then every 6 months till 8 years of age.
Yeah. So, in short, you're saying regular follow-up is a must, and with all the people that you've mentioned. Dr. Nitesh, you are still online, right? Nitesh? Nitesh, you are still online? Can you unmute yourself, Nitesh? Nitesh, can you unmute yourself? Or Dr. Naveen, can you take this question, please, Dr. Naveen?
Okay, please.
Yeah, Naveen, Dr. Naveen. Another very, very important question. See, the child passes OAE at birth, a couple of days after birth, child passes OAE. And does it mean that he or she, the girl or boy, will not have hearing loss later on?
When it comes to babies who are in NICU, it is not enough to do OE for these babies
Yes, yes.
because it only tests the outer part of the hearing. Babies can pass OE and still have, if you look at hypoglycemia, you look at meningitis, you look at asphyxia, all of these are damaging parts of the brain which are not tested in OE. So these all children can have hearing impairment and pass OE. And second thing is some conditions can have acquired hearing loss, which can happen over the time, like virus infection. For even if you pass an OE, on the footnote of it, it should be stating clearly that the early language milestones should be monitored still. And in the NICU, one must have both OE and BERA being done. It is not sequential that one who fails OE then goes for a BERA. That test should be done. For many parents do get worried. Unfortunately, we as pediatricians also answer questions to parents like it is not required, baby is able to hear, chalta hai, dekhenge. But minimum hearing loss, testing of both the ears, having different frequencies are many reasons why a BERA should be done in all babies.
Thank you so much, Dr. Naveen. Thank you so much. Thank you so much. And the next question is for Dr. Soumya Kant. Soumya, see, when you do your occupational therapy, right? You deal with the parents and then you do a lot of counseling, right? So how do you, when you do the counseling with these parents, how do you give something like a home program, or do you think that is beneficial or detrimental in the long run?
So when we think about a neonate or a child as such, so most what we our primary thing what we focus is the movement emerges from the environment. So it's movement as in the interaction of the person. I mean how the child or the neonate is developing, and the environment is not only the objects or what is the environment is the objects. It's also the people who are in the environment. And when we think about environment, then the neonate and the child mostly spends the time with the home. And who are the person who normally the child will be interacting there, the parents or the caregiver. So it is very, very important rather than the therapist continuing the therapy, the parents to be the therapist of the child and keep continuing whatever the program according to the need of the child or neonate. Whoever the therapist, whether as an occupational therapist or physiotherapist, as a team or the psychologist or speech therapist, to train the parents and definitely give a hands-on confidence that okay, the parents can be the therapist of their child in the natural environment of the child, that is home.
So you do
that
have
is
a
very,
home
very
program,
important.
right?
Yes.
You do have a home program. Okay, okay. Dr. Ankush, we see a lot of babies again in the NICU and even otherwise. Do the orthopedic surgeons or the orthotics people whom we work with, do you think they have a role in the management of these kind of children?
I mean, children with cerebral palsy who
Yes.
develop contractures.
They're not, we haven't been diagnosed them, but children who've had difficulties in the NICU. And do you think early on an orthotics, or like he spoke about requirement of orthotics when the tone is abnormal, more as a preventive strategy or a preventive tool rather than treating them, right? So that way.
I mean, those children who develop spasticity of the gastrocnemius muscle, or so they will develop an equinus deformity of the foot, or they develop tightening of the hamstring muscles.
Yes.
So they will develop a flexion deformity of the knee or the hip. So they can be provided orthosis to prevent permanent contracture development of the permanent contractures.
Great.
And even they can be provided orthosis for the for the
So
spine
involving them early on, along with what she has said, as part of the developmental team, you need to have orthopedics and orthotics as well in the team, right? Thank you. Ketura, what are the behavioral issues one should be looking for in a baby so as to, again, in terms of early identification for us pediatricians and neonatologists, when we are in the OPD, what would you advise us to have an eye for so that the early cues which you pick up from a psychological point of view?
One of the major forms of communication for a baby is crying. Usually they'll end up having differential cry, but then the parents will not be able to distinguish that cry. So that is a tale, or that is a sign for the doctors to be aware of, and to probe more questions about how the child is crying, when the child is crying, because children who are not able to communicate, or they are not able to express themselves with a particular form of non-verbal communication, just cry for everything. So crying is one thing that you have to kind of look for, and also the crying spells will be lasting longer. They won't be able to stop it, they won't be able to distract it. Parents will also find it difficult to distract it. Those are the kind of spells that you have to pay more attention with, because that can help us to identify other problems in the picture, especially from a psychological or a sensory point of view. Usually if you wear them a texture that is they are not comfortable with, they are going to start screaming. All of these are, you know, signs of the child having sensory issues. So crying is one of the major things, and then tantrums of throwing things, holding their breath, head banging, all of these also are signs that the pediatricians can look for. Like one of the doctors mentioned, most of the problem behaviors, parents, especially when grandparents are involved, they are like, no, this is a child, they will outgrow it, they will be fine. All of this kind of delays the entire process of our, you know, neurodevelopmental team coming in and doing early intervention.
Delay
So
or denial?
denial.
Either they deny it or they
Yeah, their denial causes the delay,
delay.
basically,
Yes, exactly.
because they are not going to come to a psychologist or an occupational therapist, as I told you in the beginning. They're going to come to the pediatrician. Yeah. So if the pediatrician and the neonatologist are able to pick up these signs and, you know, kind of identify these kids, then I think it will help in the early identification part.
Thank you so much. Thank you. Thank you. That was fantastic. It was a beautiful round of discussion. Anything else anybody would want to add? Anything else from what we have covered? Okay. If there's nothing much, anything? Sure. Thank you so much. Thank you, everybody. Dr. Nihaz, Dr. Ketura, Dr. Priyanka, Dr. Ankush, Dr. Anil, and Dr. Soumyakant. And thank you so much, Junior. That's for you. That's for you. No, that's for you. Thank you so much. Thank you so much. You've been an absolute sport. Thank you so much. Thank you.